structure is the pedicle. So this is the pedicle. Below the pedicle is the foramina. This is the facet. This is for your discal procedures, and this pedicle for vertebral augmentation procedures. There are various ways of doing a discal procedures. One is a traditional safe triangle approach where you just go below the pedicle, and then there is a Camben's triangle approach. Fine. So just don't look at this image. So what is this? Pedicle. Below the pedicle? Above and medial, this is for the disc space, and this is for the median nerve block or denervation of the facet joint. Is it clear? Any doubts I can repeat? So again, more images. Right? So now what we also do is, once we have identified how do we do it, we also need to be clear. We enter the foramen in the lateral image. So we identify the pedicle. This is the foramina. This is the foramina. Now things get a bit interesting when we talk about the cervical spine. Now in cervical spine, since we are going for only a cervical epidural, so rather than having these finer details, we just try to follow certain lines. We have the anterior vertebral line, we have the posterior vertebral line, and then we have the spinal laminar line, and then we have the posterior spinous line. You should not cross the spinal laminar line when we are going for cervical epidural. Right? So how do we start? We start with an AP view and then we make it lateral. And these are the lines which you need to identify. Getting a too lateral can be quite challenging at times, but once you identify, we make sure that we do not cross this green line. Dye, we are using omnipaque dye. In other words, I always say use a cardiac dye, never a urological dye. So just to finish this topic, what is this, sir? Everybody? Pedicle. This is the pedicle, this is the foramina, this is the facet, this is the median. This is the Scotty dog, this is the superior articular process, this is the eye of the Scotty dog, this is again the superior articular process, the eye, the superior. This is the facet. But unfortunately, in patients, this is for demonstration, but otherwise it's very difficult to get a perfect image. So this is for transforaminal, which is around 6 o'clock with respect to the pedicle. This is for the disc. Right. Eye, sir. It's basically the eye, or in gross anatomy, we have to talk about. This is the junction of the superior articular process and the transverse process. So it has to be placed like this.
This Scotty dog, to achieve that, what is the best view for that?
I got the Scotty dog out of the equation. You just make it AP, you make it oblique. Try to get a good vision of the pedicle, sir. Because Scotty dog practically is not possible most of the times.
Theoretically, the Scotty dog is, it gets best
around
in which view?
Oblique 15 to 35, 15 to 35, 40.
Same level as the foramina. Because when this doctor came there, you said that the best way to watch the foramina is from above and oblique.
So the point is, so this is your patient. So I see it like this. I identify, this is for counting. So identify, for example, this is L4. So I identify L4. Then I identify it is left or right. So then I make it left. So what happens for squaring? You need to do this.
Try to raise it to your eye level. That is the best view where you see the foramina.
You have to manage the X-ray tube with your head.
The tube has to be at the same horizontal flat level.
नहीं सर ये है ट्यूब.
ट्यूब को फ्लैट पोजीशन में ले
लेटरल व्यू आएगा. लेटरल व्यू आएगा. हमें ना सर it's a very basic and a very pertinent. When we are doing fluoroanatomy, our job is to find the shortest possible route. Right? So अब मुझे यहाँ enter करना है.
इधर enter करना. So the easiest way would be create an angle and enter like this. Theoretically, yes, you can do it like this also. मैं यहाँ पे लेटल करके यहाँ से लेके सीधा भी जा सकता हूँ.
About the view actually, if we talk only about radiology, the best view would be true lateral. There's no doubt about it.
Yes, of the foramen.
Of the foramen.
Yes, sir. But the point is, we have to enter the foramen.
So if you keep the same view and you enter it by that, that's also will be a good thing.
Longer trajectory, na, sir, multiple structures will be punctured. Here there is going to be just, see, this is the body, there is going to be muscles, right? So what happens is, if I am trying to do this, I'll be entering from here. So I will be, firstly, I'll have a longer trajectory. So second would be that I will be punching a lot of structures.
When we do it for the neuralgia, foramen away, you can see it in the oblique, you know. There we, when we put the needle, that is the shortest way. So why can't we have a shortest way?
Because sir, anatomy ऐसी है ना, ये shortest है ना, हमने इसको इतना कर दिया, इतना करेंगे तो लंबा हो जाएगा.
So that means 40 would be in an oblique. So that will be around
Keep
15
it
to 20
vertical, sir
degrees.
might understand it better. Keep it vertical and turn it, maybe sir might understand. It's fine.
नहीं, I think sir, this is the patient here.
Thank you.
So what?
So once we are clear, so you can always move on. So this is something I have started doing where we are going at C0, C1 and C1, C2 for CC instability, where we are injecting intraarticular and doing a PRP. And the basis remains the fluoroscopy. So only thing is that in cervical, when we are doing a cervical epidural, we ask the patient to open their mouth. So that is something for the next time. So this is one. So next would be, I can move on to the next topic. Yeah. Any questions so far? Yes, sir. Yes, sir. Omnipic. Or आम भाषा में cardiac dye, the one which is being used by the cardiologist, never a urological dye. Why? Because just in case if you are in an artery, vein or anything, no, you can't do any harm. So
Omnipic comes with three sets, I think 180, 240 and 300. So which one?
whichever is available and cheap, sir. No, basically because we generally go for the 180 ones or 240. 300 becomes too dark for us, because what happens is viscous, that is one, ma'am, and second thing what happens is we might miss our targets also. So if what we generally do is if we inject, it becomes totally dark, then manipulation becomes difficult. So again, when you are putting in the dye, we just try to put in a little bit so that we are sure, and once we are sure, then we put it in the entire. Yeah, sir.
Or you can actually always dilute it with
Exactly.
1 ml of saline and then push it, so that even if you are wrong in the first shot, so that when you manipulate the needle, at least the first dye will not object or obscure your image, the subsequent images.
Yeah.
That is another problem.
Exactly, ma'am. Fine. With that, I'll be moving on to the next topic, which is the basic history. And I think what we need to understand, again, coming back to the basic thing, what we started from the lateral foramina and the central foramina. So, for example, what could be the possible causes? So, possible spine causes, obviously, I'll be discussing about and I'll be talking about. But please be aware that in chronic pain, there can be multiple factors also. So, there can be a patient coming with osteoarthritis knee. There can be a patient coming with AVN of hip. There might be a patient coming with ankle issues. There might be a patient coming with SI joint. And one more important thing, which even I have missed initially, was the patient can have Berger's also, peripheral vascular disease. The symptoms would be very, very close to a central canal stenosis, right? So that is one. Second thing is that I am old school when it comes down to history taking. So I generally follow what was taught to us in our med school, where they talk about that you start with a chief complaint, then ODP, and then the history in detail. Please do not try to miss it, because in pain things can be funny, and 80 to 90% of the conditions and the management plan is based purely on history. Because when you have multiple discs, multiple structures, then targeting is purely based on history. Even the first talk where we were discussing about glossopharyngeal neuralgia or facial neuralgias, it is purely based on history, and then we plan to do an intervention. So, as I told you, so there can be a compromise of the central canal or the lateral canal. So if the patient is having a compromise of the lateral canal, the symptoms will be of radiculopathy. And if the patient is having central canal problem, the patients will have symptoms which are suggestive of neurological claudication. So this, okay. Now, because we come from an interventional background, so we have to be extremely careful regarding the red flags. The classical red flags are tumor, trauma, infection. And then there are specific neurological red flags in which there is a loss of muscle power, there is muscle power tone, bladder bowel, cauda-equina syndrome. So these red flags identification that goes for any pain condition that you come across, whether it's headache, whether it's trigeminal. What does this mean is that in that scenario, you will have to either refer the patient, ask for investigations, or you can have to totally be very honest to them and tell them that you require a surgery, and with interventions, we cannot help. So that is why identification of red flags is extremely important. Now the yellow flags. A small brief history. I think most of the audience is the younger who are just starting off their careers. See, what happens is when I started my interventional talk, everybody is a bit cocky about their techniques, but in chronic pain, trust me, not only in practice, in life also, it has humbled me down. After a point of time, your interventions do not give them what you expect them to give, specifically in chronic pain. Therefore, please be aware of the yellow flags, the psychological issues. Otherwise, your interventions will keep failing. So you might have a patient, classical patient would be that, doc, my pain is reduced, but still I am not able to do things. So that is a clear-cut indication that there are certain psychological issues. Few tricks how to do it. First, impact of this pain on their quality of life. And that will be different from a 20, 25, 30, 40, 50 and a 60 or 70-year-old. So how much that pain is impacting their quality of life? That will help in prognostication also. Second, quality of sleep. Are they able to sleep properly? And third is the thoughts. Overall generalized well-being. Rest, we follow what is about the pain, character of pain. Character of pain is very important when we talk about tingling, numbness, paresthesia and things like that. Location, radiation, aggravating, elevating factors is important. Origin is extremely important. So just giving you a very practical example. So a patient comes to me saying, मेरे को टांग में दर्द होती है. I have a leg pain. Now, if you go into the detailed history, there would be 3 or multiple conditions. One would be, doctor साहब मैंने एक वजन उठाया था. I had a back pain. Then the back pain went, and now I have a leg pain with tingling numbness and to the entire leg. Scenario 1. Scenario 2. The patient says that, doc, मुझे ना नीचे बैठने उठने में घुटनों में दर्द होता था, अब वो बढ़ते बढ़ते पूरी टांग में होने लगा है. Scenario number 3. The patient says that, doctor, मैं चलते चलते मेरे पैर भारी होने लगते हैं और मुझे बैठना ही पड़ता है. Fourth, doc, मैं एक बार ऊपर से मैंने I did a round of where I went barefoot. After that, I had a heel pain, and now that heel pain is traveling up. Right? Because they tend to because they make it chronic, so there is a lot of referred pain which happens. And this can only be elicited when you take an history. So finding out what is the origin of pain, which was the first pain that came to you, that is extremely important. Regarding character whether it is associated with any sensations. That is one. Another important thing is, any joint pain is a mechanical pain. So when you are doing that motion, it is supposed to pain. Rest pain are generally have a nerve component to it. So that gives you a basic idea. Now these are not the dictum, but they do give us an idea. When you have a pain which is more while sitting, suggestive of an L5S1 disc, walking is L4, L5, sitting down or lying down supine. So whenever a patient comes to us with back pain, we are trying to differentiate whether the patient has more flexion related pain or an extension related pain. Flexion related pain is more suggestive of a discogenic. When you have an extension related pain, it is more suggestive of a facet. So here, giving you a basic example would be that I had a patient who said that he was a carpenter. So he said that when I hammer that I have pain. So because they are doing a lot of hyperextension. I had a bodybuilder who says that I am fine, but when I do a pull up, I have pain. Or whenever I am doing a bicep curl or without support. So when you try to mimic the pain, so what they will be doing is they will be doing a lot of hyperextensions. So that is a classical thing which gives us an idea because facets are mostly underreported in MRI and even underappreciated in MRI. So that is why it gives us an idea. Only when the foramina starts compromising, you will have a radiating pain, whether unilateral or bilateral. Coxodynia, again, very interesting. So you have a patient who will not be able to sit the way you are sitting. He will be stooping forward. Then again, one more interesting pain is an SI joint pain, where the patient will say sitting is painful and specifically cross-leg sitting becomes painful. So he cannot do a cross-leg sitting. He can do a normal sitting, but he cannot do a cross-leg sitting. When we talk about examination, you obviously talk about posture, deformity, the paraphernalia, then the palpations. Now the tenderness, so what we start with, we start palpating the center. We try to find, because in the center you have any disc issues, whether sometimes if the patient is lean and thin, you can diagnose listhesis, bony tenderness can be there, even acutely prolapsed disc can also be slightly tender. If you move paraspinal, you have the facet. If you still move further, then you come to the SI joint, and then if you still move further, you can have trigger points or tender points. Right? So this also gives us a fair bit idea of the condition that we are doing. Then the reflexes, extremely important. As I told you, these are the red flags that we need to be aware of, because if there is a red flag, to be very honest, unless the patient is a very high risk for surgery, the person is an indication for a surgery, no intervention should be done. Basic tests, please write, please document it, and try doing a follow-up also of your interventions when it is being done. This is again the reflexes and the dermatome pattern. Now this is with regards to the SI joint. So you have a low back pain which is in the pelvis, buttock pain, hip, groin, leg pain with instability. Now with SI joint pain or referred pains, the referred pain doesn't cross the proximal joint. So for example, an SI joint will not cross the knee. So you will have a pain which is associated with the hip or the butt. It will mimic an SI joint, SI pain also, S1 root compression also. So that is something you need to be aware. So these are certain things. So this is the exact sign of tenderness which might be present. Regarding neck pain, the principles are more or less same. Where when it comes down to neck pain, the only thing what we are worried for neck pain is that in cases of neck pain, obviously most common is radiculopathy. The other thing is if there is a cord compression, then you will have upper motor neuron lesions. Now this is not something which I would be discussing, but when I talk about in orthopedics or my anesthesia with my anesthesia friends, I always tell them wherever the signs are more than symptoms, you need to go up. So for example, the patient says दर्द तो ठीक ठाक हो रहा है, but उसको चलाने के लिए there are people who are supporting him, right? So when you do the regular UMN tests like Babinski's and reflexes and tone and power, then you realize that there are more signs than symptoms, then you need to go up. Okay, this we have discussed. So this gives us a rough idea about C5, C6, C7, T8, bicep reflex and tricep reflex for radiculopathy to be sure that which nerve is being. Now with cervical facets also, now Now, other thing which is quite common these days is a text neck syndrome, office syndrome. These are the new names which are given because a lot of patients come to us with a lot of neck pain. In those, the patients predominantly have a typical bad posture which has made them neck, those trigger and tender points or the facets have been brutalized, I would say, and the patient have a long-standing neck pain which is not radiating. The other symptoms which in these kind of patients, there can be a little bit of vertigo and a tinnitus. So the first time a patient comes to you with neck pain, with vertigo, tinnitus, please get him scanned. There can be other red flags which we need to be aware of. Classical symptoms, again, the patient will have an isolated neck pain. The neck pain will be more when the patient does a lot of extension. Absence of neurological deficits. Now this is again gives you a rough idea about the distribution of the facets, but not a comprehensive list. So there can be this, then there can be patients of occipital neuralgia which are there, and then there can be multiple trigger or tender points which can be present. So it is a very close diagnosis, but yeah, so these are the things that you need to be aware. The most comprehensive way is to tell them the emphasis of a good posture, good basic exercise that will give them a long-term relief. Thank you so much. Fine. Any questions? Yeah, please, sir. Okay, so sir, those nodules are nothing but muscle knottings, which come as trigger or tender points. So what basically what is happening is that because of bad posture, nerve is getting irritated, and the muscle goes into a constant contraction. So they will have multiple trigger or tender points which are extremely tender. So what we can do apart from the neuropathic agent, muscle relaxant and NSAIDs is that you can consider going for needling. You can do a wet needling or a dry needling to break those trigger or tender points. Any other questions?
Dr. Dhruv,
Yes, sir.
I must congratulate you first thing
Thank you so much.
because this lecture that you have given is basics,
Yes, sir.
and
Thank you.
we have gone through a very nice DD.
Yeah.
I hope that you are also going to tell us about the management of each that you mentioned here.
I will be concentrating on the intervention part, sir. I will be talking about the intervention part.
Yeah.
How do we do it and how to make it easy.
Yeah, like the SI joint pain and sacroiliac.
Probably in the cadavers tomorrow.
Acha. And one question is that why does that pain radiate like a S1? Why does it do?
Because see, sir, what happens in chronic pain, there is a change in the character of pain, which we generally call it the central sensitization. So what happens is any pain, any joint pain over a period of time turns to spread, right? So there, because of an SI joint pain, you will have a pain which encompasses the entire butt or the groin region. That is one. This can even happen in a chronic hip pain. If you have a hip OA knee or an avian, then also you can have a pain in that region. SI, because of the nerve compression, the dermatomal pattern of the S1 root. So you generally have a pain which is involves your buttocks. So it is a very close happen. Even in the cervical region also. So you might have a cervical radiculopathy and a frozen shoulder.
And why have we not talked about piriformis syndrome?
Yeah, that is also, sir. Yeah. So, yeah.
Fine. Thank you.
Sir, whether there is any other thing also or no, any other tumor, trauma, what I'm looking for is any focal neurological thing happening in the brain. Right? Vertigo, tinnitus, patient having bouts of hypotension, falling. So that are more dangerous than pain. See, I understand your question, but you coming from a neurosurgical point of view, you are looking, it's something normal for you. For me, it is an odd thing. Generally, patient come to me when all these things have been done and then they do come to me. But still, if the patient is coming fresh to you, I always feel that if the patient is having any added symptoms with pain, in that scenario, you need to find out why it is happening, just to be sure on the safe side. Fine.
Do you generally come across patients with vertigo
Yeah.
who turn up with cervical spondylosis?
It is the other way around. It is the other way around. So you have a patient who has a long-standing neck pain, which have over a period of time started developing this vertigo and bouts of sudden loss of consciousness.
Thank you. Thank you.
Cervical epidural in your clinical practice.
Cervical radiculopathy.
How much duration, how much you did on conservative first, then go
So the thing is, for any radiculopathy, the normal time is around 4 to 6 weeks. So it doesn't mean that I will wait for 6 weeks. It is what I'm looking for is the graph, whether this week is better than your last week. If we are on the positive trajectory, then I can hold on. That is one. Second thing is, as I told you, it has to be customized based on the patient, how much it is impacting your quality of life. God forbid, if you have a situation, your threshold and functionality will be different from your parents. Right? Say they might have, they will like to wait for more couple of weeks. But for you, you would like to be more physically active. For a sports person, it is going to be hyperactive. So it has to be customized. But around 4 to 6 weeks, things do settle. Yes, sir.
Take questions in the medical side.
Yeah. So, okay. This overdose of me. Okay. Fine. So, briefly, we will be going with the basics of radiofrequency ablation. Again, small, crisp, I will not bore you with a lot of physics. But why are we ablating a nerve? Anybody thought about it? Or was it the first modality of ablation that we knew?
think sensory fibers get ablated, so
सर इतना टेक्निकल हूँ ही नहीं मैं, आपको नहीं लग रहा? See the point is, एक वो बहुत पुरानी कहावत सुनी थी, ना रहेगा बांस ना बजेगी बांसुरी. So the ablation, the principle of ablation is exactly like that. Ablation is basically we are functionally damaging. Now this is extremely important. We are functionally damaging the nerve so that it doesn't do its job. It can be done by chemical. Classically it was being done by chemical only. We were using alcohol, we were using phenol, glycerol. I have only seen, I've never used. Then the problem with chemical neurolysis is it spreads. It's like an AK-47. You just fire. You do not have that precision. And sometimes you need that precision. So for example, in trigeminal, you are inside the cranium. So you need that precision. Versus a sympathetic block, like a celiac plexus block, where you need that volume. So there you will need a chemical, here you will need a more precision. So whenever you consider कि ये nerve को ablate करना है, this is my target, this is what I am trying to do. First thing would be anatomy, to find out whether whether I need to cover a larger area and I can allow the drug to spread, or whether it has to be isolated. I need to have that precision. So whenever there is talk about precision, like intercostal nerve, like Gazerian ganglion, like glossopharyngeal, you need precision. There we go for radiofrequency ablation. Where we require that volume, where we require that spread, where we can be a lenient, and where we want to have that volume, we go for alcohol or a phenol. Lumbar sympathectomy block, celiac plexus, superior hypogastric, inferior hypogastric. There we require volume. But where is precision? We go for radiofrequency. Now precision comes at the cost where we are trying to be very accurate also. So there your positioning becomes extremely important. What is basically radiofrequency? In radiofrequency, we are increasing the temperature. Because of the increasing of temperature, we are causing the denaturation of protein, which is causing the functioning of the functional damage to the nerve. These were the guys who did it for the first time, Sweet and Kosman. The first machine that we had, and even the first radiofrequency machine we had, was from Mr. Kosman. So what we have a generator, then we have an active electrode, then a thermistor to measure tissue temperature, and then the passive electrode. So just to complete the cycle. So this is the cycle where you have, this is, things have moved up a lot. So you have the generator, then you have the probe, then this is the grounding part, and this is how the circuit gets complete. I think it was discussed, so I won't be based. Now this is a basic thing. This is a manual thing. We have moved on to electronic. This is the impedance. This is the stimulation, the output, time, temperature. This is what we set, desire, and this is how we can manipulate. The only thing in this was that because we were doing it manually, so there was a lag of 2-3 seconds before the desired temperature could be reached. Now this was a single port. Now we have multiple ports, 4 ports, 6 port machines also, which have come up. The basic remains the same. Okay, this because we are using cauteries regularly, so we wouldn't be going into the detail. So now RF cannulas. Now this is again, so what happens if you can see, so you have this black insulated part and then the active tip. I think yesterday you had a case, and today in the discussion also you would have realized that we talk about a lot about active tip. So this is the insulation part and this is the active tip. Now the active tip can be straight, it can be curved sharp, or it can be curved blunt. So how do we decide? We decide based on the structure that we are going to target. So for example, Gazerian ganglion, we use a 10 centimeter or a 15 centimeter with 5 millimeter active tip. So before using a needle, first thing you need to identify what depths we are looking for and what active tip are we comfortable using. Now this is how we place the electrode. We take out the stellate and we put the electrode. This is the exposed part. So basically all the action is happening here. Now this part needs to be close to the structure which we are going to target. Now this is the coating electrode. So this is where the things are going to happen. The factor size. Now this is the important thing. What affects the lesion size? So now there are 3 or 4 things. One is the size of the electrode. The bigger the electrode, the bigger is going to be the lesion. Second is the time. The larger the time, the larger is going to be the lesion. Third would be the temperature. The larger the temperature, larger is going to be the lesion size. The higher the temperature, the larger is going to be the lesion size. Then that is one. So what is the thing which we are trying to limit? Why do not, for example, yesterday you would have seen sir doing say 60 degrees for 1 minute, 60 degrees, 70 degrees for 1 minute. Why not beyond that, or 90 seconds? Why not beyond that? See, the point is, if we go, or for example, why are we just restricting to 80 or 90 or not going beyond 90? The problem is that once there is heat production, we are trying to denature it. If we prolong that heating process, whether by increasing the temperature or the duration, there is going to be tissue burning, which is going to lead to charring, and that charring will prevent the adequate dissipation of heat. So basically what happens is, the electricity comes, radio frequency waves increases the temperature. That increased temperature will increase the temperature of the surrounding tissue. And if the surrounding tissue temperature goes beyond 45 degrees Celsius, that is when the denaturation of protein starts. So the target is, we go close to the nerve so that the temperature rises to beyond 45 degrees. The temperature that we are setting in the machine is the active tip temperature. It is not the tissue temperature. So there is going to be some heat dissipation, and then we are going to achieve it. Therefore, if we increase the duration of temperature or anything, there is going to be tissue charring. Therefore, we do a cyclic thing where we are doing it, letting the temperature to come down and then reheating it. So what we have, so these are the 3 zones which are being found: yellow, orange and blue. So we need the structures, whatever we are targeting. either in the yellow or the orange range. Then only we would be able to achieve the tissue temperature of more than 45. Agar 45 nahi, then this. If we are far off, no. That is why when we are doing radio frequency, precision is the most important thing. We have to be in the direction of the nerve. Okay. Probe in contact with the lower structures. Obviously, the tissue structures will also be important. Now, if there is any fluid like a blood vessel or a CSF, so it is like a dumping thing. So in that case, the lesion will become unpredictable. We need a standard lesion all throughout, like this. So this is not the structure, the lesion which we want. Even if CSF comes, it's not a major issue. In fact, it gives us a surety that we are at the right spot. But again, this disfigurement should not be there. Okay. One more thing. As regards to that, nerve stimulation and identification of the nerve is extremely important. Most of the times when we are doing a denervation, we are restricting ourselves to sensory nerves. Or max, very rarely we go for mixed nerves. Motor nerves only in cancer patients. Therefore, identification of the nerve is extremely important. And for that, we use a nerve stimulator which is there to be very sure that the placement is right. It has to occur at around 50 hertz, 0.4 to 0.6 volts. So we should get paresthesia at these voltages. That is one. Second thing is, we need the patient cooperation. Therefore, do not try to over-sedate the patient. The patient needs to be awake. Patient needs to be responsive when we are doing these procedures. With motor, things are easy. So what we do is we take 2 hertz, 1 volt, and we are just seeing the muscle contractions. So if we are seeing the muscle contraction, things become easy. So for example, if we are going for trigeminal, if it is a V3 division, it becomes easy for us because we can see the motor stimulation. So in that case, probably a little bit of sedation is also can be done. Precise treatment. Okay. Few steps. Identification of target. The nerve has to be there. Cannula is advanced. It has to be placed in parallel to the nerve, and then we do a sensory stimulation. We do a motor stimulation. Now, stimulation is also done. First is about the precision, that we are able to target the nerve which we are doing. That is one. Sometimes we do a negative stimulation also. We are not looking for a response, or we do not get a response in any other distribution. So stimulation is extremely important, both to identify the correct and to be very sure that we are not damaging any other nerve. Okay, so which is the right way of placing a needle, A or B? B. Thank you. So this is exactly, so when we talk about the lumbar,
So this has to be the placement of the exactly in that pattern which is being formed by the transverse process
and the articular process. So what can go wrong? So everything can go wrong on a bad day. So electric connections, gel pad, improper localization of needle, and low temperature. Burns can also happen. So please be very careful about it. Low temperature is again, but yeah, that is one one thing I will request. There are a lot of cheap companies which are there. So when it comes down to radio frequency, better to get a second-hand machine rather than a cheap alternative. Now there are again two things. One is a continuous RF, another is a pulsed RF. Continuous RF is an RF where we are increasing the temperature, causing a functional damage. Whereas in pulsed RF, we are trying to restrict it at to 42 degrees Celsius. Now, continuous RF is actually an ablative procedure where we are actually doing a damage to the nerve. Pulse radio frequency is something where we are just doing more of neuromodulation rather than ablation. And I'm not a big fan of radio frequency, and what I always tell is, pyar karo to pura karo, so it has to be a continuous standard thermal radio frequency. Now, this is what it would be the lesion produced by the two. So now we have a latest one thing, which is a coolif, in which what they have done is they are trying to cool the tip, because of which the lesion size is increasing more. There is only one 60 degrees, 2.5 minute cycle. It is coming up in a big way. Now we have been using it around 6-7 years, bit on the costly side. Only advantage what I feel is that because the lesion size is big, therefore it gives you the liberty of being careless in positioning of the needle. Apart from that, cost is actually quite high. So this is the lesion what we get. So it's a round shape, whereas in that we had a flame shaped. So if you place, if your structure is anywhere in this space, things become easy. Now this is radio frequency can also be done in disc procedures. This is biculoplasty. And I think that should, what are the side effects? Now the side effects, as I told you, can be mechanical side effect, electrical side effects, and the regular side effects of damaging the structures around it. Therefore, please be careful while doing it. Do not be in a rush. Identification of the nerve with sensory, with motor. Do not over sedate the patient. With that, I think clinical applications, these are the things which we are doing regularly, and gradually once you become comfortable even with the modality, you can go ahead and do it. Yeah. These are the decent level of evidences that we have, I think. Thank you so much. Any questions? Sure, sir. Thank you.
I would like to invite Dr. Ashish Tandon to present his talk on ganglion impar for coccydynia.
Thank you once again. So I'll be talking about ganglion impar block and RF lesioning. This is again a very common problem that we encounter in our day-to-day practice, which is coccydynia. And coccydynia happens secondary to acute or chronic inflammation. The pain worsens on prolonged sitting or abruptly rising, and it apart from regular pain, it also interferes with sexual intercourse and defecation. The etiology are multifactorial. You can have trauma, and you can have a direct fall. So that is one cause. Then obstructed labor, prolonged sitting on hard surface, especially if your posture is not correct. There are instances of idiopathic coccydynia as well. And then you have pelvic and anorectal malignancies leading to coccydynia. Initially, we treat conservatively with non-steroidal anti-inflammatory drugs, hot and cold fomentation, TENS therapy, coccygeal cushions, and this is generally we miss out on levator ani relaxation exercises. So we need to send the patient to the physiotherapist as well, and they need to learn levator ani relaxation exercises. So ganglion impar is located at the sacrococcygeal junction. It is on the ventral surface of the sacrococcygeal disc or just in front of COX-1, and it is the caudal end of the sympathetic chain. So every junction has a ganglia, so like a sympathetic ganglia. So for example, yesterday we were talking about stellate ganglia, which is at C7T1, or ganglion impar, which is at sacrococcygeal junction. The ganglia typically innervates or receives nerves from the perineal and perianal region, as well as visceral sensation from the pelvis through the ganglia travels to the CNS. So what are the indications for ganglion impar block? You have coccydynia, intractable perineal pain secondary to prostatitis or endometriosis or proctalgia fuga, cancer pain of involving malignancies in the perineal region, distal rectum, distal third vagina, radiation proctitis. What are the contraindications? That is typically for any of the blocks or RF. There are various different techniques. You have the 1 needle, 2 needle, and radio frequency. So we'll go into the basic technique of needle positioning. Your patient is positioned prone with a pillow under the hip, and you need to again have an optimal view of the sacrococcygeal junction. First take an AP shot, mark the midline because that is where mostly the ganglia is. You identify the SC junction on C-arm. So sacrococcygeal junction needs to be identified, and you have the ganglia right in front or just in front of COX-1. So we typically insert a 22 gauge needle. You confirm the position. The tip is just anterior to the sacrococcygeal line, and there has to be a negative aspiration for blood and stool prior to injecting the drug or undertaking RF. So you inject dye, it's a bang in the midline. And you inject the dye 2 to 3 ml, and typically you have a comma-shaped appearance when you put in the dye. And then you inject 4 to 6 ml of either bupivacaine or ropivacaine. Then for radiofrequency ablation, generally preferred two needles and 2 RFs. So that has a better result because you need a larger lesion. So for RF, you have 22 gauge RF needle through the sacrococcygeal disc, and the other is in between the COX-1, COX-2. Again, the position remains the same. After nerve stimulation, you give a lesion of 70 to 80 degrees for 90 to 120 seconds. So these are the type of lesions that you can create with single needle or double needle, and this is the, if you look here, this is the location of your 2 needles. And when we were showing you yesterday, trigeminal, we showed you the machine with 3 or 4 simultaneous lesioning electrodes. So this is one area where you can use simultaneous RF lesioning. It gives a higher success rate when you have dual lesion. So results of the block, you have a reduction in VAS score of almost 50 to 65%. Recurrence is common at 3 to 6 months. However, you can repeat it. Failures secondary mainly to anatomical variation of the ganglia, and if it is not at sacrococcygeal junction, then it is the ganglia is at in front of COX-1. So you need to be aware of the anatomical variation of the ganglia. So if you're just giving one block, 50% of the ganglia gets ablated. If you're giving 2, then 2 areas, then almost 70 to 80% of the fibers are affected. So multiple studies reflect better outcome with RF ablation as compared to just giving steroid and local block. Again, as with any procedure, there are a set of complications. The common ones are more milder, and rarer are more serious. You can injure the rectum, or your needle can break. You can have a hematoma, or you may have bowel or bladder incontinence in the short term. So it's a very simple procedure, and we come across a lot of patients of coccydynia, and we are not perhaps doing this. The other thing that I've been practicing for last 2 years, though I'm still in the learning phase, is digital manipulation along with RF or blocks. So the combination still gives better results. Thank you. So per rectal, you have a digital, you feel it, and because they are abnormally placed, the COX-1, you can manipulate. It's like spinal manipulation. So you manipulate it into the correct position, the coccygeal bone, and along with that, you give an RF as well. Give, no, not simultaneously. You can do that and then give it. Yeah, you can any sort of ablation, but then the results are not good, complications are higher. So
Always said that coccydynia is because of the ganglia?
no. So coccydynia is not because of the ganglia. Ganglia is just a pathway. The pathology is either trauma or malignancy or any other form of inflammation. But it is the pathway taking fibers to the CNS. So you're targeting the spinal because they're coming from both sides and merging there and then moving up.
Traditionally, coccyx, the lactic X-ray, the orthopedician especially used to see where there is an acute angle
Yeah.
at the coccyx tip.
Yeah.
That still holds.
Yeah, that still holds true. If there is coccydynia and if there is an abnormal shape and if you are able to correct it, results supposedly are better. Though it is very variable, but the results are better.
Traditionally, they used to excise the tip.
No. Traditionally, they never excise the trip. And even today, excision is absolutely the last because of the fear of infection. So there's very limited number of series if you go through. There's a recent Korean publication where they have published almost no infection with coccygectomy in 6 to 12 of their patients. But that is always the fear and that is the last choice. No, sacrum is a single bone. So if you're talking of pelvic incidence, then it is different. But pelvic incidence has nothing to do with the shape of the sacrococcygeal or the coccygeal bone. So that does not change.
Any PD physician, tips that he always gives is, don't sit on a hard seat.
Yeah, that's what. So yeah, that's what I've shown that on conservative treatment. Yes, sir. See, that holds true. So even if you have done all this and if the patient goes and sits on a hard surface, so it's like a burn. If you have burn and if you keep rubbing it, it's never going to heal.
And sits baths are still in practice.
Yes. And they're very helpful as well.
How much time after the symptom you consider for a block? For 6 weeks, 8 weeks? And how frequent it is?
Okay, so generally not before 3 to 4 weeks where you give a repeat block. And also you need to give a conservative trial of 2 to 4 weeks, especially physio as well. So you have cushions. If he is not, for example, if he is not following your advice of sitting on a cushion or taking sitz bath, whatever you may do, it's going to fail. Thank you. Thank you. Thank you.
Before the system and campaign of this. The reason is, see, even we in the OPD sit for long, but it is the posture. If you're sitting straight, generally the pressure on the coccyx is not there, it is in air or just touching. But if you sit with, if you slouch, then you are putting a lot of pressure.
To add to this, always before proceeding for a ganglion import block, you can always ask an X-ray in sitting position so that we can see the position of coccyx in sitting position, how badly bent the coccyx is before manipulation, how manipulation is going to have the benefit post this thing. And to Deepak sir's answer, like whether we can do chemical neurolysis, if the patient is having an LAR and having colostomy and already the pelvic structures are damaged, yes, sir, we can do chemical neurolysis provided the volume is very less. But it is going to be excruciatingly painful to the patient when we are doing with alcohol instead of RF. So glycerol availability is very difficult nowadays because we need to dilute, and the dilution is difficult with the glycerol, and phenol also, that is the same problem, availability. And absolute alcohol, so with pathology lab people will just come and give it.
This flexible, it's already flexible. So the spinal.
That's why, sir, the recurrence is very common, very common. So we try to reduce it and tell them to follow all these tips, like sit on a donut pillow, carry it even in your car, and all these tips will tell. How compliant the patient is for the treatment depends, the results depend upon that. Thank you.
With this, we conclude this session. May I request the chairpersons to kindly facilitate our guest faculty, Dr. Dhruv Bibra. Dr. Dhruv Bibra, please come on the stage, please. Dr. Deepak Agarwal, may kindly join the chairpersons in facilitating Dr. Dhruv Bibra, please. A memento also needs to be present to Dr. Dhruv. Thank you. With this, we now take a break for breakfast, please. All are requested to join us in foyer. Within 15 minutes, we will start the next session. 11:30, we will start the next section, please. Hello, good morning. Welcome back. We will start with the next session now. This session is on blocks, related to the techniques of blocks. So, for this session, I invite Dr. Tushar Arora to chair the session, please. Along with Dr. Tushar, may I request Dr. Milind sir to kindly chair the session.
Thank you, Dr. Rajiv.
Thank you, sir.
And the first talk is by Dr. Dhruv Bibra. Dr. Dhruv. Dr. Dhruv is going to talk on cervical facet and median nerve block, including RF ablation.
Okay. Thank you so much. Uh, I think you can come up if you don't mind. So I'll be talking about the technical details of doing a cervical epidural block. We basically touched upon the anatomical part and the fluoroanatomy during our earlier discussion. So I will just be carrying on with it. Most of the times, patients which require cervical epidural would be patients who are having complaints of cervical radiculopathy. The good thing about cervical radiculopathy is that it is more responsive to conservative management. Therefore, you won't be requiring to do the cervical epidural for a large set of patients. Mostly, lumbar is definitely more. Cervical is self-resolving, smaller disc. So therefore, you doing these procedures is less. That is one. Second thing is, because of the anatomy and the presence of the cervical artery in that region, we abandoned or we stopped doing cervical transforaminal blocks some times back. Now we have restarted it by using ultrasound. But fluoro-guided, we are not doing selective root blocks. So irrespective of the level of the procedure, we go for a cervical epidural block. Okay, first things first, so how do we enter it? So we enter it through the PA view, and we do not cross the cervical spinolaminar line, the things which we have already discussed. So the patient is lying prone with neck extended. We identify the level. So normally the entry level is either C6, C7 or C7, T1. And for doctors who are starting their career, I would suggest that you can even start a step down. So you can even start from T1, T2, and then you can go up. So once you have identified the level, you place the epidural needle. We generally follow the classical interlaminar approach or the loss of resistance technique. So once we have identified it, we introduce the needle for a couple of centimeters inside the skin to get a hold of it. Then we gradually introduce it and take it in. So once we are doing it and once we have identified it, we put in the dye to see the spread, and you would realize in this case the contrast is has not crossed the spinolaminar line. Now that is the Lakshman Rekha, as I like to call that. In that case, it should not cross. So we start with an AP view. Once we have done the AP view, we make it lateral to be sure that the dye spread is there. How do we identify it? We identify it by a classical loss of resistance technique. So once we have done that, we put in the dye. Once we put in the dye, this is the dye spread. Now, I would really like you to have a look at this dye spread in any epidural space or in any space is going to be a vacuolated appearance. So you will have something like a dye area with a little bit of vacuolations which are present, right? That is one. Second thing would be, we are, if it is in the muscle, it will be a more universal spread. So once we put in the dye and we have put in the drug, this would be the spread. So this was after we had put in the drug. So this is a small video that will help you. So you can appreciate that the patient is lying supine, is lying prone, where there is a pillow below his chest and the neck is hanging. We identify the level. We are identifying the level as well as we are identifying the right or the left side. So once we inject the local anesthesia, we give ample local anesthesia. This procedure is done in an OPD procedure with minimal sedation. One more thing which I always request doctors who are starting their intervention, you need to understand that this is a nervous OT. So do not try to over sedate the patient. Patient is the best control. So they won't let you harm them. Because you are anxious, your staff is going to be anxious, and once you have, and if you are, and the patient has all the right to be anxious. That is one. Drug, dye which is fine. Drug, generally there are recommendations that if you go in the thoracic or the cervical region, you should ideally be using a non-particulate dye. So people use dexamethasone also. So once we have identified it, so this you can, this is C7, this is C6. So we are going at the C6, C7 level. Based on the symptoms also, you can put a marker on, the other, on the side where you want to do the procedure also. So once you have identified it, so these are the, normally we do that thing, 5 for local, 2 ml for dye and drug. So this is, we will be using the classical LOR technique, the loss of resistance technique, while doing the procedure. Whenever you are trying to learn this LOR technique, start from the lumbar region and then gradually you need to go up. So once we have introduced the needle, we take out the stylet, we confirm it under CM. Ideally, you should try to get a tunnel view. Even if you are not able to get a tunnel view and you are not sure and you do not want to damage, you can target the lower part of the lamina. As I told in my first talk, bone is your friend. Do not hesitate to touch the bone. Go, hit the bone and then manipulate. And tomorrow in Cadaveric lab, we will be discussing more about it. So as you can see that we will be going millimeter by millimeter into the space by using the LOR. So once we are inside the LOR, there will be a loss of resistance. Now this around 1 or 2 minutes job is the one which is going to be quite intense, and you need to focus with regards to the exact value level which you are trying to do and how you are trying to do. So this, as you could see that there was a loss of resistance, we reconfirm the loss of resistance. And once we have done that, we will be putting the dye. Other way is, this is, so once other way is that you can even consider putting in some normal saline also. So once you put in the normal saline, there has to be a free flow. So this is the dye. This was the area where we were, there were symptoms were there. So the patients, this is the dye spread. Once we put in the drug, you will get a better spread. C6, C7. Yes, sir? C6, C7. But as I told you, since you are starting off and it is a good, you can go up, no harm in doing C7, T1, or to be very sure, T1, T2 also. Right? Because it can be, because you get a chord as you go up. Now, once you have identified, given the drug, you will see the yeah, you can see the drug has gone up to here. So it has gone C2, C3 also. This is paramedian. So you can go midline also, but we generally prefer going paramedian on the side, on the symptomatic side. Right? This is a classical interlaminar approach, but as I told, since you are starting, you can go at a lower level and try to hit the bone, try to hit the lower part of the lamina. So once you hit the lower part of the lamina, you are sure that you are not gone deep. And once you have done that, you can just manipulate and go in. So you can see the spread. It has gone really up. Fine. Now we will be coming to the cervical facets. Now again, as I told you, the answer to all the questions lie with anatomy. Okay. So, sir, you had a question that why we are not going lateral. Now the cervical facets, because it's a small structure, so the distance whether you go from posterior to anterior or you go lateral is almost the same.
So, if you look at these joints, these are the cervical facet joints which are direction like this. So either you can enter them in the PA view or you can enter through the lateral. Totally up to you. So what we generally follow is for upper level cervical facets, we generally go for lateral view. For lower level facets, we go for the AP. Because here you get shoulders, so getting a lateral image is difficult. There you have the base of the skull, everything. So getting the AP image is difficult. Right?
We'll be little sticking to time because we are running.
Sure, sir, sure. I'll just push.
You can just round off.
So yeah. So this is the direction of the facets. So this is how we would be entering. Now, now this are the facet joints. These are the facet joints and these are the median branch. So this is what we are trying to target when we are doing to go for it. Yeah. This is will give you an idea about the intervention. So this is the facet joint. So this is the slit-like opening is the facet joint, whereas the lateral mass, that is the structure where we are looking to block the median branch. Now with median branch, these are small nerves, small area. So you can again go through the PA view or you can go through the lateral view and the target is the lateral mass. So this is when you are going intra-articular facets. So this is, we have discussed and talked about. So this is in the AP view. We just try to get a slight oblique view and then introduce in the needle. This is in the AP view. Once we have done that, we put in the dye. Now, this is the median branch. So in the lateral view, we get the lateral mass. We just go and hit the lateral mass end on. The trick or the challenge is to get a perfect lateral view without getting any sort of overlaps. So once that is identified, doing a median branch in the cervical region is quite easy. So that was in the lateral. In the oblique, in the AP view, you will realize that there are certain curves which are there. So these are the waist, we call them. So this is our target. So whatever is your primary, you either start from lateral and get it AP, or you start with AP and you get it lateral. So the point is that you have to hit the lateral mass irrespective. Thank you. Any questions? I knew I just rushed. With cervical, once you are comfortable with cervical epidural, cervical facets becomes easy. Trick is just to get a perfect lateral image, identify the lateral mass, and you just enter it. Intra-articular facets are generally not being done and so much in the cervical region. Thank you.
Thank you, Dr. Dhruv. Our next speaker is Dr. Ashwin S. Raj. He's going to talk about role of ultrasound guidance in pain blocks and spinal interventions. We'll stick to time, Dr. Ashwin.
Yes. Good morning, everyone. Myself, Dr. Ashwin. I am currently working as assistant professor in Department of Emergency Medicine at AIMS. Basically, when I was told to give a lecture on like the role of ultrasound in guidance in pain blocks, I was a bit confused. Basically, like everyone knows this thing. Like recently, like the landmark techniques have already been replaced by ultrasound like because of ease of technique, safety, and all. So I was sort of confused. क्या बोलेगा इसमें like और क्या like सबको जानते हैं. So I thought like I will start with a story. So we had a patient in our emergency. He was a 32-year-old male who came with a history of fall from stairs, like 4 or 5 stairs only. He came after one day with severe low backache, and he has actually pain score of 10 by 10. And there was actually we evaluated the patient as severe pain was. He was not even able to ambulate. He was lying down, not even like touching my itna tenderness. Thoda bhi movement karo itna tenderness that he is not even ambulatory, like getting up from his trolley. So we did evaluate the patient. CTB kiya sab normal, no trauma related finding. We gave multiple analgesic, fentanyl, 50, 100 sub. Like no improvement for the patient, slightly like from 10 by 10 maybe 9 by 10 or 8 by 10. Then we thought like what else can we do for this patient? Like finally, like we discussed with our senior faculties and like finally we decided to go with erectrospinal block. How many of you have heard about this? Okay, thanks. Basically, as you see in this picture, there's a problem. Actually, erectrospinal blocks are basically like on literature, जो भी हम देख रहे थे, like mainly for posterior fractures. वो distribution यही होता है, like that's classically which is used for. So, but in our department we have multiple publications already in erectrospinal block, like in rib fractures and even in like pancreatitis, and even in cholangiocarcinoma patients are there. Even we have developed the AIMS TRAP protocol for management of like pain-free ED, like for posterior rib fracture patients. But before going to the like what happened to that case, I will just brief some anatomy. Like basically this erector spinal muscles, it consists of 9 muscles which are grouped into basically 3 categories. One is a longinus dorsal. I have already highlighted in this. So basically this muscles actually run over the transverse process of the vertebra from thoracic, abdominal, lumbar. And we are actually giving the local anesthetic just below the transverse process. Like, no, just above the transverse process, like below the muscle. Electrospinal, we identify the electrospinal muscle and give the like local anesthetic in the area, like so that we are actually targeting the dorsal rami of the spinal roots that's coming at that Joby level we are giving. Just it will spread both 2 to 3 like cranially and 2 to 3 caudally, and it will be like giving analgesia by blocking the dorsal rami. So how we do this procedure? We prefer is always sitting position. If not, then we can go for lateral decubitus position. And identify, basically we identify like we can start medially or laterally, but always in the parasagittal plane, we start from laterally, and we first identify the ribs and then swipe more medially to identify the this is just the ergonomics of the how the procedure is to be done. This is actually the ultrasound anatomy. Basically, we will be you can see the transverse process over which there is a erectrospinal muscle. We need to deposit the local anesthetic in this area. So the needle will be inserted like you can see first actually most important step is to differentiate between rib and transverse process. Like rib will be more rounded, but transverse process usually will be more like, I have one more image. We can see like more squared off, transverse process more squared off, which we are the erector spinae muscle. This is basically the ultrasound view that we are getting. Like we have the transverse process, two transverse process, and above that the erector spinae muscle. We will be targeting this area, like just above the transverse process. Ultrasound, and we deposit the local anesthetic. Around 20 to 30 ml of BPO can be given. So this is the video showing actually how we start. Here we can see the basically the pleural line. There you have the ribs, and first like this is the first view. After that we go more medially. Medially actually you can see the it's turning into the transverse process. You have to give the local anesthetic in this area basically. And the case we were talking about those have already been published. This is the reference. Actually, we gave the patient the local anesthetic in the L1 level, and patient actually had a very good improvement. Actually, he like became ambulatory, and he actually this is the patient. He walked out of the ED and was asked to follow up in OPD only. So, thank you.
Got questions? Yeah, please.
Don't have a which or say even energy is operated dependent.
Okay.
How about integrating the intelligence about to show the part, so at least we can put those side and blocks by taking them.
Basic. Okay, but actually in periphery also you can like just need an ultrasound machine like portable. Basically these procedures are not done by radiologists per se. More anesthesia people do, but I don't think radiologists itna ye karte nahi hai. Yeah, no.
If you have a CM, you can do it under CM also, because the landmark is the transverse process. So you just need to hit the transverse process and not get lot of volume. And this is a volume block. And
No,
you
volume.
said it is around
20 to
30. 15 to 20 ml you can give ECG. So the identification is our transfer. Whether you use USG, whether you use Neuro, it is going to be the same. If you do not have a USG, you just give lot of volume, aspirate, no blood, you give lot of. And level is also not an issue. So if you, like as he said, ideally thoracic, you might get confused. But because it is a volume block, you can even identify it L1 and push it up. So it is a technically very easy thing.
Why did you choose L1?
So actually in pain, tenderness and all was there.
And why don't you want to give it inside the muscle rather than in the plane in
So
between the
actually
transverse
it's volume block. Actually we need to like craniocaudal. We need
So
to
it
like
spreads.
spreads in the craniocaudal junction like fascia
Right. Thank
through
you.
the fascia.
Thank you very much. Thank you. I now invite the third speaker, Dr. Dhruv again. Dr. Dhruv Vibra is going to talk about transforaminal epidural steroid injections, lumbar, thoracic, and cervical.
Okay. I think this is the last one I have. So thank you for bearing with me. Okay. So I'll cervical I had covered in the last talk itself. So I'll be talking about lumbar. Since you have already seen a lot about it and discussed, so my job becomes easy. Okay. So selective nerve root block or transforaminal. So this was supposed to be my first about interventions. So generally I follow two basic principles. One is sniper theory. So people who are into video games, they will realize that there are two kind of guns. One is kind of an assault rifle, Kalashnikov, AK-47, where you don't aim and you just fire. And then there are snipers. Sniper meaning where you target and then you deposit the highest concentration of the drug at that spot. So all our interventions, most of the interventions that we are trying to talk about, or the pain intervention, is about that sniper shot. So whether it is going to foramen ovale or transforaminal or intraarticular facet, all are sniper shots. The one we discussed previously, that is a Kalfenikov. You are just aiming for the entire plane. So there you are going for 20 ml. Otherwise, it is always about 1 ml. So one principle is this. So whether you use fluoro, ultrasound, landmark, or multiple CT, the point is of precision. So do not try to compromise. That is one. Second thing, the RRR principle. People often talk about it that this intervention didn't work. So an intervention is going to work if you get the right candidate, the right intervention, and the right timing. If these three are correct, then only your intervention will work. With that background, let us talk about a transforaminal epidural. Now, question often asked is why transforaminal? What is the difference between interlaminar or caudal? So just imagine the caudal space or the epidural space like this room. You can enter this room through these doors, you can enter through the window, or you can just break down the wall and come in. But at the end of the day, all the drug is going to come in this space only. As I told about my first principle, our target is to deposit the highest concentration of the drug, mostly a steroid, at the point of impact. So impact is happening at L4 level. Why would you like to deposit something at L3, L4, L5? Then also you are trying to target the L4 level, the DRG. So that is why transforaminal is better. But in case if you get stuck, if you are not able to do, you have a bad day, or you're just in that learning phase, you can shift back to Kalfenikov. You can enter through a caudal space. That will give you that, but in caudal space, you will have to give that volume. Right? So transforaminal is entering through a small window and targeting the entire object which we are going to do. That is one. Coming back to the same thing of the lateral foramina. So what you have the anatomy says body, disc, body, pedicle, fasces and pedicle. So just below the pedicle. And to be precise, it has to be at 6 o'clock position with respect to the pedicle. Now why 6 o'clock position? Anybody? That is the site for DRG. Dorsal root ganglion is supposed to be at a 6 o'clock position. We have had discussions about the Scotty dog. So nothing new about it. So what we do is we just identify the Scotty dog. Even if we are not able to identify the Scotty dog, we identify the pedicle and we go below the pedicle. And this is, again, I would be repeating, if you are not sure about the foramina, you will always see a pedicle. Try to hit the pedicle, rotate your needle and go in. Practically, I'll be demonstrating it during tomorrow's workshop. We just try to bend the tip of the needle. So what we do is we hit the pedicle, we rotate it, and then again we rotate it and enter the foramina. 22 gauge spinal needle, tunnel view is in the safe triangle. So safe triangle is not so safe. That is a discussion for some other day. So we just need to go below the pedicle. Once we have gone inside enough, we make it lateral. We enter the foramina in the lateral space. As we were discussing, the foramina is best seen in a lateral space. So once we have identified and put it in the lateral space, we again make it AP, and the end position has to be the 6 o'clock position with respect to the pedicle. We put in the dye. If we get a good spread, we put in the drug. Right? So this is how we place it in an oblique view. Oblique, generally you get a decent oblique view around 15 to 20, 35 degrees. But it is all decided by the patient. Endpoint just lateral to the superior articular process at the level indicating the neurophenomena or the 6 o'clock position. Bend the tip. So bending of the tip helps us in two ways. First, it helps us in directing the needle. Second, it also gives us a perspective where we are medial or lateral, because once you are doing the needle, it becomes very difficult. So any intervention that you are trying to do, initial few try to bend the needle. Otherwise, needle orientation is a challenge. You are not sure whether you are overshooting medially or laterally. So once you have identified, you enter in the lateral. Needle position is in AP condition. You aspirate and then you get a dye spread. Okay, what all possible things you can get? One, you can inject in the blood. So what happens is you inject the dye and dye is nowhere to be seen. So that is blood. Other is CSF. You can enter into the CSF also. And what happens in the CSF is few shots you will be able to see the dye, and next couple of shots the dye will be gone. First, yeah. So this is the ideal spread. Entire thing. So if you are outside, then it is not. So this is there. So a part of it has to go inside and the part of it has to come outside also. So this is the ideal spread. Too much outside, too much inside again is not good, because if it goes too much in the epidural space, then it becomes a interlaminar kind of an epidural. It doesn't cover the root that we are trying to target. So this is a subneural approach. Yeah. Ye to ho gaya. I think that's it. Any questions? Ideal, yeah. Any other questions? In the nerve. Into the nerve. Unless and until you are on a mission to do it, you won't be able to do it. I think आपके कल केसेस में कभी ना कभी सर से टच हुआ होगा, right? The moment you come close to the nerve, the patient will shout, right? So that is why whenever you are trying to do any intervention, make sure the patient is awake. This is one thing which I always tell. Little bit of sedation, that is all. Because patient will never let you harm. And trust me, आप नर्व को टच करोगे पेशेंट चिल्लाएगा, आप 4 लोग पकड़ के डालोगे तभी डल सकता है, अदरवाइज हो नहीं सकता. तो unless until you are on a mission, it will not be there. So yeah, this is the dye spread.
Dhruv,
Yes,
you
sir.
talked about the selection of patients.
Yeah.
3 hours, na? So in selection, how careful you are in not selecting a few patients? How do you choose your patients?
Okay, so I'll quote my guru as this, my teacher. Dureja sir always said, let the patient earn that intervention. Right? So you have to see whether a good trial of conservative management is there. Second, the patient knows and understands what is his rehabilitation going to be there. So that is one, that part. Second would be the right candidate. For example, if what is the pain, what structure is the one which is causing the pain and at what level. So if you are able to identify those are the right candidate where you will give a good prognostication and go ahead with the rehab.
This thing was, out of 10 patients, how many of them will not be discs?
Of back pain.
Yeah, no, you're giving a selective block, no? So you must be targeting those cases where there's a selective compression of the root,
Yes.
some reason or the other.
Hanji.
So in 10 cases, how many of them would be discs, and what would be the other diagnosis that you generally get?
Okay. So we are talking about a radicular pain, right, sir?
Yeah, we are talking about a focal.
See, the thing is, no. See, so what happens is any structure, every structure which compromises the lateral foramina can have a radiculopathy. Yeah. So it can be a disc, it can be a facet. So those need to be targeted separately. If the patient is having symptoms, then we target the L4 root. Okay.
In all cases, the symptoms would be there, no? That's why you're doing the procedure.
Yeah, so that is there. So most of the times, if you have a radicular pain, it is the nerve which is being compressed because of the disc or the facet. Sometimes it can be entrapment neuropathies, most common being a piriformis syndrome. Right? Piriformis syndrome can be there. Then peripheral entrapments can also be there. Fourth, there can be joints also, which might be responsible for this kind of a referred pain.
Thank you.
Yeah, but most of the radicular pain are disc related. Very good. Now that also depends what kind of a disc we are dealing with. So for example, if it is an acute disc herniation, that will respond beautifully for these interventions, right? If in that, otherwise, if the patient is having degenerative disc diseases, it's a degenerative condition, then it won't. I hope there is no straightforward thing, but acutely prolapsed disc will respond better versus anything which is a degenerative thing.
That it should be an acute disc prolapse to respond better. So this like adequate trial of conservative treatment should have been found. So is there any time interval that we need to do this?
Okay, I think I answered it earlier also. So what it has to be customized based on the patient and how it is impacting their quality of life. That is one. Second is, are we hitting a plateau? So for example, we take a 30-year-old male, female, averagely physically active, comes with acute radiculopathy. No, 2 days back. So I wouldn't rush him to an intervention. What I'll do is I'll put him on meds, neuropathic NSAIDs for say 10 days, ask for a follow-up after a week. If his pain is reducing, I will wait. Again, I'll call him after 2 weeks. If the pain is either same, उतना ही रिडक्शन है और फर्दर रिडक्शन नहीं हो रहा, या फिर बिल्कुल बढ़ ही गया है, या ठीक हो गया, these are the 3 options. ठीक हो गया, nothing doing. Plateau है, I'll go for an intervention. और relief बढ़ गया है, but still it is impacting his quality of life. Then I will ask him कि I think you are the right candidate for an intervention. But again, compare it to a person who is like a footballer or a sports person. वो तो 4 दिन में भी करते हैं. Because they want, हाँ, yeah.
Thank you.
The
Dr.
pause, yeah. Thank you.
We close the session. So we now come on to the next session. This is Neuromodulation 1. And I invite my co-chairperson, Dr. Milan, to talk about basics of neuromodulation for pain. Now, if you want a gap, we can call somebody else. See.
I think I'm supposed to give 3 talks in this session. One is on basics of neuromodulation. The other one is on DBS, and the third one is on spinal cord stimulator. So let's start with the basics of neuromodulation. So it's kind of basics of neuromodulation in pain. It's not basics of neuromodulation. I'm not going to talk to you about neuromodulation in movement disorders. Okay, these are my COIs. So we're going to talk about the concept neuromodulation in pain and the networks that we modulate, some theories about pain and how that affects different interventions and surgeries. Definition, you all know the definition of chronic pain. Definition of pain, there is shortcoming in it. Chronic pain is not only temporal. Chronic pain has a lot of other aspects. Chronic pain is a disease on itself. It's not that for 3 months you have pain, so you become chronic pain now. It's a big burden. 20% suffer from chronic pain of all the population. 8% suffer from high impact chronic pain. So high impact chronic pain is where you cannot do your day-to-day activities or the activities needed for your professional activities. And surprisingly, in India, the rate of high impact chronic pain is very high. It's unrecognized. We say we don't have chronic pain, but we do have a lot of chronic pain. So what's the concept? I mean, the concept of pain, chronic pain and pain in general, has traveled in last few centuries from the initial René Descartes that it rings a bell in the brain. So we thought it's a linear circuit. So you get injury and there is a bell that rings in the brain. It's not all that simple. Then That's about acute pain. So acute pain, you cannot confuse acute pain with chronic pain. Acute pain is completely different. Chronic pain is completely different. These two are completely different entities. Chronic pain is not a sensory phenomena. It's a psychological phenomena. It's a psychiatric phenomena. It's generalized dysfunction. It's not a localized dysfunction. Chronic pain is always generalized dysfunction. Also has lot of psychological overlay. There was a 13th century philosopher Spinoza who said pain is a localized form of sorrow. So all chronic pains have a localized form of sorrow associated with them, and you got to be mindful of that when you treat it. And we used to do bold fMRI scans in these chronic pain patients with intervention, without intervention, and you can see the whole brain gets activated. So this was actually one of our articles came on the front page of Neuromodulation. You can see the parcellation of the whole brain, and there is upregulation or downregulation of all the networks in the brain. There are a lot of theories and pathways. Everyone knows gate theory, and this was actually the newspaper article that had come in after the gate theory was published. But the gate theory is too simplistic. It's good for acute pain, but it doesn't explain chronic pain. So actually, one of the proposers of gate theory himself came with neuromatrix theory, that gate is fine. I mean, if the gate opens, you feel the pain. But what happens when the gate is not involved at all and you feel the pain? So then neuromatrix theory comes in. And neuromatrix theory basically says that from every network in the brain, there is contribution to the perception of pain. So pain is a global, chronic pain is a global disease, and it's not a local disease. Are you okay? Okay. As far as the main actors are concerned in this chronic pain in the brain, thalamus is there, absolutely the main grand central station for pain. Corticolimbic circuits, anterior cingulate, amygdala, basal ganglia, insula. Insula has a big role, anterior insular gyrus has a big role in chronic pain. Hypothalamic reward circuits, DMN, dorsal mode network, salience network, all of these play part in perception and propagation of chronic pain. So all of these could be targets of intervention if you want to break that cycle of chronic pain. There are three concepts we need to know about when you talk about the basic of chronic pain and neuromodulation. The first one is thalamocortical dysrhythmia. And this was me many years ago with Rudolfo Linas. Rudolfo Linas is the guy from NYU who brought this concept of thalamocortical dysrhythmia. He did MEC studies, and MEG studies showed that in chronic pain patient there is synchronicity. Any kind of synchronicity in brain is bad. So when they fire synchronously, you get epilepsy. In Parkinson's, any positive neurological disorder, you will see synchronicity in thalamocortical circuits. And exactly the same happens in chronic pain. The thalamus and the cortex fire in a unison, so they reverberate each other. So it's like a train going through a tunnel. Suddenly the sound goes up. And that's what happens when you have chronic pain. The thalamus is firing and it's oscillating the cortex along with it. So normally when thalamus perceives your touch as touch, this hyperexcited thalamus will perceive touch as pain. And that's where the fibromyalgia type of symptoms come from. That's where chronic pain and deafferentation pain comes from. So thalamocortical dysrhythmia is basically a low frequency coherent electrical activity which is all over the hemisphere. And when you do thalamotomy, you break this dysrhythmia. Second thing you need to understand about the duality of pain, painfulness of pain. Francis Kirk again did a lot of research on it. So this is what I was talking about, is the medial pain pathway. That painfulness of pain is different. Painfulness is different. So when it starts hurting you, when it starts pulling you down, when you start feeling bad, and when you don't interact socially along with others around you, that is medial pain pathway. That's the affective pain pathway. Central sensitization of pain. That's another important thing. 3 months, 6 months into the disease process, if the pain is not properly treated, the brain will start recruiting central areas into perception of pain when there is no pain, and that's called central sensitization of pain, and that's why you get phantom limb pain. So even after supraorbital neurectomies and occipital neurectomies, the pain sometimes remains, deafferentation pain, and the reason is brain is still perceiving it. And that's why the pain remains, and that's when the central sensitization happens. And again, thalamotomies or even spinal cord stimulators will break the central sensitization of the pain. There are a lot of types of chronic pain. We all talked about it. I'm not going to go into details of it. There are a lot of points of intervention. So you can go here, you can do a peripheral nerve stimulation, you can do a DRG stimulation, you can do a spinal cord stimulation, you can do a thalamic DBS, you can do a cortex stimulation. So this pain pathway, anywhere in the pain pathway, if you intervene, you will get 50 to 60% improvement in pain. So the key points is, try not to cure chronic pain. Any chronic pain that is there without a cause for more than 6 months will not be cured. It will get better, quality of life will improve. So try to reduce the pain with minimum risks. So all those interventions I showed you, even if I put a peripheral nerve stimulator or a motor cortex stimulation, I'll get about 50-60% benefit. So why to increase the risk of intervention? I'll do the minimum intervention to get the same benefit. Again, knowing your patient is very, very important. Patient selection is very important. In patient selection, you have to look for what type of pain it is. As I said, neuropathic responds the best, visceral responds the worst. Larger areas of pain don't respond as well. Smaller areas responds very well. Allodynia, sensory loss doesn't respond as well. Neuropsychological issues, important to have neuropsych testing in every chronic pain patient before you intervene. And those patients who come to you saying, you are my last resort, beware of them. Also those who come for a trial and you put in a stimulator and next test they say, I got 100% benefit, beware of them. 3 months down the line, they're going to come back saying, my pain has come back. Lot of procedures, we talked about it. We're going from more invasive to less invasive. This is my practice trend. This is an old slide, but the 2018 or 2016. But as you can see, my PNS number went up significantly, while my DBS and motor cortex numbers kept on going down. So as I said, going from more invasive to less invasive. So in conclusion, select the right patient. Make sure the psychological comorbidities are a result of pain and not cause of pain. Imagine if we have back pain, I'm having knee pain, if I'm not doing anything full time, in 6 months time, 1 year's time, that niggling pain will make me go crazy. So craziness is associated with chronic pain. Only got to find out whether this was before the chronic pain started or after the chronic pain started. If it is after the chronic pain started, then it gets better. And that's why neuropsychological testing is very important. Do not try to cure the pain, and make sure the patient is on board with you in the journey. Be very clear about expectations. Walk with them, and then even if you fail, the patient won't complain. Thank you.
Question? Sir, I wanted to ask you about residual pain after surgery. There are some cases where the nerve anatomically has been decompressed, but the pain remains. So any intervention, what intervention should?
I think it depends on how much is the pain remaining. If it's not very, like, I mean, if you decompress a carpal tunnel and patient has some local pain, you ignore it. If the patient develops CRPS after that and the whole hand gets red and starts migrating up, then obviously you have to intervene. If they have some residual neuropathic pain, you treat it medically. So extent of pain and type of pain that remains after surgery, it's important.
Thank you.
I think the next talk is DBS for pain. That's me also. And then we talked since yesterday in bits and pieces about DBS. So I'm not going to try to repeat things. I'm just going to go over some facts which we may or may not have covered in the last few talks. Again, DBS is a part of central neuromodulation. And central neuromodulation is where the brain gets neuromodulated. And to tell you something, everything that we do modulates the brain only. No, it doesn't modulate, doesn't, huh? It doesn't modulate the spinal cord or peripheral nerves. Even medications that you take, they modulate the brain. Syndopa basically modulates the brain. Meditation, that also modulates the brain. We have done fMRI scans in meditation where there is modulation of brain networks after doing deep meditation. Invasive cranial procedures like DBS and motor cortex stimulation obviously modulates the cerebral networks. But even wearable things like TDCS or TMS will modulate the brain networks. Spinal procedures also modulate the brain networks. When you put a spinal cord stimulator, it basically dissociates limbic from sensory systems and not inhibit the gate pathway. Peripheral procedures, occipital nerve stimulator, with an fMRI scan in those patients, and we see activation of anterior cingulate. So it's not the blockage of occipital nerve, it's the activation of anterior cingulate that will improve the migraines. So everything modulates the brain networks. But we're going to, and the earlier ones were lesioning, and the commonest lesioning that we've done is cingulotomy. This is a very useful tool. If you have RF ablation probe, just do cingulotomies in cancer pain. I mean, cancer pain in India, there is not a very good pain management for metastatic cancer, and cingulotomy will take the pain away. Simple to do surgery. Nowadays, there is MR guided focus ultrasound. That's the part of lesioning. Deep brain stimulation, as I said, there are only 4 or 5 targets for pain. The one is sensory thalamus. The second is CL or CMPF. Then there is periaqueductal or periventricular gray matter, nucleus accumbens, and posterior hypothalamic DBS. Sensory thalamus, as I said, as I showed in previous talk, I mean, you have to go to the posterior part, posterior most of the thalamus, that's VC, nucleus ventralis caudalis. And you put in the lead inside the VC, generally in the middle of the VC, depending on the somatotopy of your pain. Normal coordinates are 11 from the wall of the ventricle at the PC level and at ACPC line. Programming is slightly difficult because of the sensory reactions of the patient. CLDBS is, as I said, it's like a tanpura playing in the background along with the VC, and that modulates everything. I mean, these patients, it modulates the sleep, it modulates the dreams they get. These nuclei, whatever we say in brain does not have any function, has so many functions we just don't know about. Insula is the same, interlaminar nuclei are the same. They get inputs from everything and they kind of regulate everything. We just don't know about how they function. This is the CLDBS, nucleus accumbens DBS. This was an NIH grant we did, 25 patients in post-thalamic pain. We generally go down here in the nucleus basalis of Minot or nucleus accumbens, and you go 7 millimeter lateral to the midline, 2 millimeter in front, and 4 millimeter below ACPC line. That's also the target for depression. That's also the target for OCD. That's also the target for addiction. So basically, that's also the target for obesity, because obesity is food addiction. So we use this target so much that we ourselves don't know what its function is. This was published in Annals of Neurology back in when I was in Cleveland Clinic. PAG, PVG DBS works in nociceptive pain. So these thalamic DBS would not work in back pain. We had done it for chronic back pain, and one of our patients had a morphine pump implanted and wasn't responding. So we did the DBS, and 3 days after we doing the DBS, he went into morphine toxicity, and that shows, that was kind of definite evidence that it releases endorphins. Because it releases endorphins, the morphine levels in his blood went up, and we had to actually stop the pump and take the pump out. Again, targeting is a little bit complex. It's very close to the ventricle, and it's very posterior. Posterior hypothalamic DBS, we've done this for cluster headache, only 2 cases. It's another complex area to go. Hypothalamus is a a very kind of chaotic structure. Lot of things very closely packed in a small area, and a lead which is 1.2 millimeter in diameter is stimulating the thing. So you kind of upset so many of things, diurnal variations, the sleep, autonomic, all those things are, it's very difficult to program this patient. Long-term effects are good in DBS. Motor cortex stimulation is another option. Central neuromodulation, maybe we'll talk about it sometimes later, but that's about it. I would make sure that I don't repeat the slides that I talked about yesterday. Thank you very much.
Very nice talk, sir.
Thank you.
What couple of questions. One is the procedure itself is the same as for Parkinson's in the sense that the technique, or is it in awake and you do all the electrode micro electrode recordings, or you do it anatomically like you once mentioned?
Now we most of the patients will keep awake. Now the patient who have deafferentation face pain, one of those patients, I could not put a frame on his head because of the pain. So that patient was done under general anesthesia. But most of the others we do awake. For nucleus accumbens, there is no need to be awake because there is no microelectrode recording. So we can do that asleep, and especially if you have an O-arm and you just make sure that it goes right to the target, you can do it asleep also. But for thalamic DBS, where you want to make sure the somatotopy is correct, it's better if the patient is awake.
Also, is it possible to do completely frameless? What I mean to ask is if the target is not so precise that we can have a 0.5 millimeter of error. So we can just do it based on just image guidance.
Freehand based on image guidance.
Yes.
Now, the only thing I done using the Medtronic stereotactic biopsy handheld probe without using stereotactic frame is cingulotomy. I mean, cingulate is a big structure, and you make lesion here or there, doesn't matter. But for DBS, all are stereotactic frame based.
Continuing with sir's question, like in Parkinson's, there is UPDRS charting for DBS. Is there any other criteria for pain also for DBS?
We normally used to, when we evaluated these patients, we had a team of people. We had pain specialists, we had psychiatrists, and we had pain neurologists and neurosurgeons. So the preoperative evaluation was done based on 4 scales. One is a VAS. That's the commonest visual analog scale. That was done in every patient. The second was PDQ-9 to basically tell you the extent of depression. The third was SF-36. That's the independence index. And fourth was the ADL scale, activities of daily living scale. So we are looking at functionally how much is improved, pain how much is improved, and depression how much is improved. So all these 3 things which are interrelated. The whole point of doing the intervention is improve the functionality, reduce the pain but improve the functionality. So those 4 scales we used to use.
Thank you. We wanted you to make a hat trick today. Third topic, spinal cord neuromodulation, mechanisms, clinical applications, current evidence.
That's such a big topic in such a small time. So I just skipped to spinal cord stimulation technicalities, because if you go in the theory of it, this will be, even with that, there are 40 slides. I run through it, so it should not be. So spinal cord stimulation is another form of neuromodulation, which is for some reason hasn't picked up in India. Maybe the bad name it got because of indiscriminate use in non-indicated patients in certain centers. But this is a very good tool in right patients. Conflicts of interest, agenda. Okay. So, you got it? Okay. So, as I said in previous talk, the brain of pain is all in the brain. So, it's all brain. It doesn't matter where you stimulate, block, modulate, medicines. It's the brain. So brain will get modulated even with spinal cord stimulation. And that's why some of the trial patients will get good coverage, good paresthesias in pain areas, but will not get benefit. And that's primarily because it's not doing the dissociation, sensory limbic dissociation in the brain. So indications, chronic extremity pain of any type, axial pain, spinal cord stimulation doesn't work. So if the patient's back pain is worse than leg pain, don't even think about spinal cord stimulation. Go for, I don't know, facet joint blocks or morphine pumps or things like that. But extremity pain, when it's worse, of any type, CRPS, radicalopathy, peripheral neuropathy, diabetic neuropathy, normal neuropsychology evaluation. As I said, no, it won't be normal, but it has to be no basic underlying untreated anxiety, depression, because that will make the outcome way, way worse. Acceptable spinal anatomy, unless there has been a big, long instrumentation and you don't have access. So all these three things, these are the three minimum criteria for doing the spinal cord stimulation. Again, key points, as I said before, this is true with any chronic pain patient. Make sure you tell the patient that 50% of patients will get 50% or more benefit. It's not going to cure your pain. Again, as I said before, in DBS, same applies for spinal cord stimulation. Neuropathic pain will respond the best. Visceral pain, some types of visceral pain though will respond very well with spinal cord stimulation. The anginal pain, we done spinal cord stimulation for angina and works very well. Neuropsychological issues, you have to make sure in your patient selection. So there are a lot of leads available, a lot of companies available, and there is always discussion going on that I use perk lead, I use paddle lead, which leads to use, when to use. Basically, I'll always use a pair of perk for simple reasons. One, they're cheap in India, even abroad they're cheap, so insurance doesn't have to pay for it too much. Why a pair? Because a single lead generally moves, so the migration of the lead is very common if you use a single perk lead. If you put two perk leads side by side, coverage is better, the chance of migration is much less, and the cost is still 1/3 of the paddle lead, so it's still way cheap than the paddle lead. The only time I will use a paddle lead is if there is lead migration, if there is no space to go up. Like if there is an instrumentation from L1 to L5 and the patient has radicular pain still in the legs or deafferentation pain. So for putting the lead, I had to go, if I don't have a good access as T12 to L1, then I'll do a T10, T11 laminotomy and slip in a paddle lead. Because if I don't get access, if there is epidural scarring a level above and I start doing CSF tap, then it's not worth it. Another reason why perk lead, if it doesn't work, 4 out of 10 patients it will not work, then pulling out perk lead does not need another surgery. So you can just pull the leads out in outpatient and let the patient go home. Where should be the lead placed? Always posterior epidural for sure, but depending on where the top of the lead is, the coverage is. So if your top of the lead is too high up in dorsal spine, you will not have coverage of feet. So if you're putting this for diabetic neuropathy, where the feet pain is the most important point, then you put the lead lower down. So top of the lead will be at T10. So when I say T10, it's the middle of the body of T10. So it covers T11 and little bit of T12. So that will cover all the sensory fibers going down to feet. But if you want to have a coverage where the pain starts from hip, then you have to go to the top of T8 or sometimes middle of T7. That will give you full coverage from hip down to the foot. If you go above T7, the canal becomes so small that even slight increase in pulse width will cause root stimulation, and that becomes very uncomfortable. So somewhere between T8 to T10 is where you put the tip of the lead for chronic pain. Entry point, epidural entry point is at L1, L2. A skin entry point we do at L4 pedicle. I'll just show you. Positioning patient most of the time, 90% of the time, local anesthesia, no sedation. Uh, the needles that I use are Tuhi needles which are curved. So this needle have a little curve on it. They are curved up like this. So when you actually make the epidural entry, less chance that you can damage the dura. And when you slide the lead, it will come out of the tip of the needle up like that and not go down to the side. So curved Tuhi needles. And these are the leads. There are a lot of different types of leads, and you want to access as parallel to the spinal, the epidural space as possible. If you go like this, the lead won't go ahead. So you should be as parallel. That's why you want to go 2 levels down in the skin. So this is where I want to go inside this is my epidural entry. My skin entry will be down here somewhere. So 2 or 3 levels down on the lateral side if I go. Why lateral side? Because a movement of interspinous ligament can migrate the lead, can pull the lead down. It can also break the lead. And just in case you get a wet tap or something, less likely the CSF is going to come out of the muscles. It's more likely it will come out of the ligament. So it's always better to do a lateral entry. And if you're going to put 2 leads in lateral entry, you can put 2 leads from both sides. This is how you go, the skin puncture will be here, epidural entry will be there. And this is how you might advance your needle. And when you are in the epidural space, you make sure you enter the epidural space with the hub up. But when you are inside the epidural space, you turn the hub to the side, and then the lead comes out of it. If the hub is on the other side, the lead will go in the lateral epidural space. And then you just make sure with one hand you push the lead, with the other hand you direct the lead. And then the first lead goes up. The second lead is easy to put. You just advance it with the and both the leads. You generally don't keep them side by side, up, down, so you got a better coverage. Make sure you always do a lateral one after the leads are put in, because you will never understand if it goes anteriorly. So you have to do a lateral X-ray, and you have to make sure the lead is posterior epidural and not anterior. With this needle sticking out and lead sticking out, you will stimulate and ask the patient, is it covering your area of pain? Patient may not feel any pain relief there. You just have to make sure that the coverage is right. If he has a calf pain, then the stimulation is going to calf. If it's not, you adjust your lead. And that's why it's important not to give any sedation. Sedation makes people confused. So the patient has to be under only local anesthesia. And if that's not possible, then give full GA and then put EMG and SACP on both legs. And you stimulate, see the changes in the EMG, where are the changes in the EMG, and make sure you do SACP collision to make sure the right lead is on the right, the left lead is on the left. This is the intra-op testing. Paddle lead is much more easier for us neurosurgeons. Simple laminotomy, put the lead in there, make sure it's centrally placed. I also use paddle lead for cervical spine. I don't use leads. I don't use pork leads for cervical spine. Always paddle lead. And for upper shoulder pain, we put in the retrograde lead, like this is between the occipito C1 space. There is a little make a little opening and then slide the lead down. This works much better. There is much more space up there between the occiput and C1. You make sure the leads are anchored properly. Migration risk is about 5 to 10%. These are the anchors which are available. All these things are available in India. And then you trial for 5 to 7 days. And if patient gets good benefit, then you come back and you make an incision here, tunnel the wires down, attach it to the battery, put it there. Programming is very easy. The stimulation has to remain in dorsal columns. If it goes too laterally, it will cause root stimulation. If it goes too anteriorly, it will cause motor stimulation. So you generally make bipolar stimulation. And there are ways to drive the stimulation on one side or other side, and you learn it as you start doing it. Motor reanimation, this is a topic for another talk, but I thought I'll just put a picture in this. And this is one of our patients who's actually now walking. I just don't have his videos on my computer. This is an 8-year Asia grade paraplegic for 8 years. And this was immediately after surgery. Within first 2-3 weeks, he was able to lift his leg completely on his own with the stimulation on board. And now he's walking with 2 sticks. So this is a very good therapy for rightly selected candidate and rightly done. And Dr. Deepak Agarwal and we are going to start it in AIMS at some point. Thank you.
Dr. Milind, can you talk a little bit about the selection of cases? A little bit more about it. How do you select cases for
Spinal cord stimulation? Again, this is not the initial thing that you offer. This is, the diabetic neuropathy. Patient on high dose medication, still just not able to sleep, affecting day-to-day life. You can do this. For radiculopathy, you have to make sure they have undergone, if there is a corrective surgery, they have to have corrective surgery. If no corrective surgery, then multiple blocks and all the things that can be done are done. And then as a last resort, CRPS, again, bad CRPS, we done 2 CRPS patients in Calcutta. A patient who had knee surgery had 22 knee surgeries, because every time the incision is to get red and swollen, they thought it's infection. So they will open and then the redness will go away. No one even thought of CRPS. So we did a sympathetic block. With sympathetic block, he had 4 months of good relief, again came back. So we put in a stimulator. We had a patient with L1, L2, the immune radiculopathy, lumbar plexopathy, upper lumbar plexopathy. Couldn't do anything else. So we put in a stimulator. But in normal the bread and butter radiculopathy, you make sure everything is done. And in spite of that, if the pain is so significant that patient wants to have an implant in his body, and patient wants to spend 16 lakhs for it, then he's your candidate.
So for diabetic neuropathy, what are the success rate? You said 100% will never come,
No.
50%, 60% relief,
Yeah, about 60% benefit, 60%.
and this will remain for the duration of
As
the...
long as the stimulation is there.
Also, you said that for axial pain it does not help.
Except angina, and if you do DRG stimulation, it will help with axial pain. But spinal cord epidural stimulation will not help.
But in one slide you showed that for back pain you can put it up to T6. So by back pain you mean when it is combined with other...
Correct. So back pain means lower lumbar hip pain and leg pain. Real back pain, upper lumbar, thoracic, and absolutely not. So back and leg pain with like 70-30 distribution, you can put it in. But if back pain is 80% and minimal leg pain, I would not even offer it. So two types of two types of pains. One is neuropathic when there is damage to nerves or coming from nerves. But nerves are continuous and sending signals, and normal signals. That's a neuropathic pain. It's just inflammation, C fibers are active, and you are getting the pain. When there is damage to ligaments, muscles, bones, the pain that you get is basically nociceptive pain or musculoskeletal pain. And then the pancreatitis and GI intra-abdominal pain is the visceral pain. So those three are the basic types of pain: neuropathic, nociceptive, and visceral. Now, when the nerves are either damaged completely and the brain is getting wrong signals from the other nerves or remaining fibers, that's a deafferentation pain. Brain perceives that the nerve still exists, but the nerve is already damaged. So any other sensory stimulus coming from that region is perceived as pain. That is deafferentation pain. And that is generally burning, very, very severe burning, with lot of allodynia. Patient doesn't let you touch that area around. So that is deafferentation pain. Neuropathic pain could be partly burning, partly tingling numbness. So that's a combination of some fibers damaged, so some deafferentation, but primarily tingling, numbness, and pain. And nociceptive will be just a dull aching over standard pain.
Thank you. Thank you, sir.
Thank you.
I now invite Dr. Deepak. He's talking on should we continue prescribing pregabalin? Quite an interesting topic.
Is pregabalin one of the sponsors?
So obviously, this is PDF. ये PDF है क्या? ठीक. So, how many of us use pregabalin or gabapentin? All of us. 100% of us. It becomes the mainstay of our brain practice. Because I remember during my residency and a long time after it, there was no pregabalin or gabapentin. So we had a very limited option. We were using NSAIDs in high dose, and at that time the side effects of NSAIDs were coming in. A lot of drugs were getting banned. New drugs were coming in. So I think all those NSAIDs have now, nobody even writes them, you know, after this pregabalin and gabapentin came in. And we got so enamored by these two drugs or this class of drugs that we have not thought of going back. So but if you actually, although we are getting sponsored by these companies, but it's still, I mean, it is very important for all of us to understand that every drug has side effects. And the side effects of pregabalin or gabapentin are, I would say, on the higher side. So what do we mean by higher side? So you can see all these side effects coming in here. We'll start with the neurological side effects. Now, if you classify side effects, very common side effects means that they are between 1 to 10%. That is what the literature defines as very common. And you see the percentage, 37% dizziness, 25% somnolence. So it is very sedative drug, and people get very dizzy, somnolence, and depending on person to person, obviously every person is different. Also, the word common, when we say side effect common, it means 0.1 to 1%. That is the common when we talk about side effects. Here, these are the gait instability, neuropathy, speech disorders, patient complaint of slurring of speech, very common in not very common but common in these patients. And obviously we have rare which encompass a huge I would say array of symptomatology. Cardiac side effects, which none of us are aware of, very common. So what are the cardiac side? I'll come to them. ECG changes can happen. Peripheral edema, we don't check. More than 10% of the patients will have peripheral edema. Chest pain is common. So chest pain also we find commonly in our patients. Psychiatric manifestations. So you by psychiatric manifestations we can have the standard confusion, euphoria, but anxiety disorders, depersonalization, abnormal thinking, this is all, I would say, side effects specifically for this gabapentin class of drugs. And the most amazing, I would say, side effect which we don't ever think of is immunological side effects. 10% of the patients or more, and this is what is documented. We don't even know actually what is the rate. This is what is documented. Infection gets higher. These patients are more prone to infections. And there's a what is called the influenza syndrome, which is common in these patients, where you have flu-like symptoms coming in because you're taking these drugs. Genitally, again, ladies who are already predisposed to incontinence will have increased risk of incontinence, erectile dysfunction, impotence, urinary frequency. All these are relatively common side effects which nobody thinks of. Ocular side effects, 10% or more, which include blurry vision and diplopia. And respiratory, I talked about the influenza-like symptoms. Add to this dyspnea. Patients can have dyspnea at rest or dyspnea on walking, bronchitis, nasopharyngitis. Musculoskeletal also is common. So I am just giving you the plethora and how common they are in patients who are getting this. This is a kind of a dangerous side effect which is common in patients getting. They can have angioedema with swelling, including that of the throat and the larynx. So obviously it can cause problems for the patients. So what can we do? Obviously we should be very judicious when we prescribe this drug. That is number one. Number two, what are the tests we should be doing? Which none of us, including me, I read about it, I also didn't know, because the company people will never tell you about all these things. ECG should be done in all patients, they say, simply because it has a high propensity to increase the PR interval. So already if the patient is having some kind of block, type 1, type 2, type 3, we should be aware. Eye examination should be done because visual field changes are common. We should know the baseline visual field. Platelet count, because bleeding disorders are increased in pregabalin. And what is recommended in textbooks is creatine kinase should also be done because patients are at a high risk of rhabdomyolysis. So if you look at the reports from various regulatory agencies, patients are actually being directly attributable to pregabalin and gabapentin. There are documented reports of patient dying again because of respiratory depression because of taking these drugs. And more than that, patient, because this is a very addictive drug, although we don't, we continue giving it for months and years, because once a patient starts taking it, there is no alternative. Right? So either you increase the dose and they will come back to you to refill their prescriptions every 3 months. Please continue giving it. It has become a huge cause of concern, and there have been articles published in that after stopping of other things like cocaine and everything, pregabalin is the next cocaine in parts of the world, because firstly it is easily available. Every chemist gives it almost like over-the-counter drug, and people are using it. Standard doses which we prescribe is usually, let's say, 150 maximum BD. That's the dose. People are taking it 10 to 30 times this dose daily. And this is articles which came in. This was last year, that it has become the go-to drug for a lot of places where addiction is common in India. And if you look at this is an article from this month, last month, sorry, April 4th article, where this question was raised in the parliament, and our health minister Nadda told that in Punjab itself 6 crore worth of pregabalin was seized, because of marketing illicitly. And this was a recent story about pregabalin in Mint, which again came this year itself, that now the government, because of everything coming in from various sources, including the police, including judiciary, including what is happening on the ground by the social, the NGOs, they have pinpointed 2 drugs One is tapentadol, which we don't really write as neurosurgeons, and the other is pregabalin. That this tapentadol is a very high schedule equivalent to morphine, but pregabalin comes under schedule H. So this is what the tapentadol comes under. They were planning to bring it under schedule X of the drug rules, and pregabalin under schedule H1. So this, obviously there's a huge lobby. It is at more than 1,000 crore industry in India, maybe more, for pregabalin. So it's not going to happen overnight, but at least this thing, we need to be aware that there are serious side effects of using pregabalin. To conclude, there is, as this point of time, they are valuable adjuncts. There is no denying it, and but we should be aware of the potential side effects, abuse potential. So we should be careful about the patients we are giving them to, and be ready to do the baseline test for these drugs so that we become better at detecting all these side effects and managing our patients. Also, the most important thing, we should be giving the minimum possible dose and stopping as soon as possible. So many times it's not possible. We are also in a hurry that, okay, this is simpler to just carry on giving the drugs, keep increasing the dose. But we should realize that if it was our relative, would we continue giving with this kind of side effect profile or not? So that is very important to understand. Thank you.
Any questions? Yeah, please.
Actually, what we see in OPD, many of the patients take this drug for months and
Yes, yes.
Many. Those who is having chronic pain with and in my neurosurgeon, I have seen they usually prescribe a smaller dose. Neurologist, higher dose. Patients from Canada, they prescribe 400 mg gabapentin for 6 doses, 4 to 6 doses in a day. So I've seen extremists with taking gabapentin for maybe 400 4 times a day. So, is there any data of long-term use of pregabalin?
Yes, there is in terms of abuse potential.
Needs to be stopped. Actually, more than 6 months is definitely what you should.
Many countries have actually banned this drug, banned it, that it should not be allowed, and they have made it very difficult to be prescribed. However, India is not one of them, and long term there are very serious side effects which people have reported. But again, it is, as I said, all these are industry driven things, and it is very difficult when you have a conflict of interest. So when we have a conflict of interest, all your conferences sponsored by them, you also are a little worried about writing anything against them. So this is the reality across the world. Yes, maybe this is stronger. Yeah. I cannot say, because we have now purely shifted to pregabalin most of the time. As most of the neurosurgeons, gabapentin is a very small part of the practice, so it's difficult to compare. And but I think the safety profile of pregabalin might be slightly better, but it's my I cannot comment on it. Yes. Alternative. There is no. I would say crocin is the paracetamol is the best drug if the patient can take it. And I usually prescribe paracetamol, physiotherapy. You know, it's a holistic management. It is not just the drug, because giving the drug is the easiest but the most dangerous part of it. And patient is also happy taking this drug. But you have to look at it as a holistic problem, and especially for long term. For acute pain, it is fine. You give pregabalin for 2-3 months, but with the clear vision that after 3 months it needs to be tapered off and stopped.
Several of the things which you have told, we got to know fresh. And many patients came with complaint that we just tried them, it's not because of pregabalin. And one more, this thing you told, some countries are not accepting pregabalin. Recently, I got a patient from Saudi, and he complained the same, sir, this medication is banned in our country. Then I had to think a lot, what alternatives should I choose? Then there was an option to choose duloxetine. I told for some better thing I'm prescribing duloxetine. Which
So,
is never selected.
yes, yes.
And one thing is regarding the pregabalin and gabapentin. Pregabalin I more choose for the diabetic patients, but the non-diabetic patients I choose gabapentin, sir, because of sedation, mainly drowsiness and sedation.
Okay. Well, I can, yes.
I'm being from the neurology side. I've read something about pregabalin versus gabapentin, and I would like to share it.
Sure, sure.
Cardiac side effects.
Mike, give a mic.
The cardiac side effect profile favors gabapentin usage over pregabalin, and the main problem, this abuse potential of pregabalin and gabapentin, is because of its dopaminergic property that causes downregulation of the dopamine receptors, and over time the dosage requirements of the drug
To
increase
increase, correct.
for anything.
Correct.
And that we, in scientific terms, we call it augmentation. But that is, there are some risk factors which have now discovered that if there is a concomitant iron deficiency, then the risk of augmentation is high. And the risk of augmentation is not high in the first 6 months of therapy. As we go ahead,
As you
then
go ahead,
the
then-
chronic postsynaptic changes
Changes.
take place. The acute, I mean, in the acute phase, till 6 months, we do not have the down regulation of the receptor. So it's very, very safe to give it. And
So
it's-
short term it is good, but long term it is a problem.
and pregabalin has also been shown as an augmenting agent in patients who have depression. So giving pregabalin with duloxetine in the acute stage, it also takes care of the psychiatric
This is,
comorbidities.
I would say this is classical vendor marketing because they combine the two drugs also and they market it. I am myself very skeptical of adding the drugs. Yes, because pregabalin is supposed to further precipitate depression. But yes, that can be tried. I think neurologists try it a lot.
Our main purpose of adding duloxetine early in the phase is to prevent the cardiac side effects, to prevent the postural hypotension that the patients have with 150 milligrams of pregabalin.
Correct, correct. That is. Yes, ma'am, please. Please come, take the mic.
I'm Dr. Ela. I'm a neurologist from AIMS, New Delhi. So, as you rightly said, the GABAergic drugs, pregabalin, gabapentin, have a lot of adverse effects. But we do use them in conditions like epilepsy as adjuvant treatment, and also in essential tremors, and also in RLS. Basically, we balance the risk of the medication versus the adverse effect. So my specific question to you would be like, in patients who are having chronic pain, diabetic neuropathy, radiculopathy, and other patients who are not fit for surgery, would you, if we refer the patients for blocks or something, would you consider that these patients have good relief with gabapentin, but they are on the pathway to a long course? Would you, in such situations, suggest blocks as compared to continuing the medication?
A very interesting question. We can definitely consider blocks, but blocks, especially in these neuropathies, are very short acting. They have no role in chronic pain. So either you think of, as Dr. Milind said, spinal cord stimulation, or go higher that way for chronic diabetic neuropathy. Other than that, we are left with these drugs, gabapentin, with the attendant side effects. As of in today's, unless we get some new drugs, this is the problem we are faced with. And Dr. Milind can comment.
There are acute radiculopathy. I don't think it should continue gabapentin, pregabalin types of drug beyond. Now, I don't see people giving simple things like indomethacin, naproxen.
Yes.
People forgot
Have
about
stopped
that.
giving
just,
everything.
Some big muscle relaxant and big this thing. But in chronic conditions, like you said, diabetic neuropathy, we don't have. So US 2 years ago made that part of the narcotic pain medication panel, gabapentin. And in US there is this OVER system. So that's statewide. Actually, it's nationwide now. So any doctor prescribes any narcotic medication to patient, it goes in a central system. And before you prescribe something, you look at that patient what is taking. So there were like 5 points for
10 points for morphine. So you have to see how many total points the patient has. And if it's beyond a certain point, you cannot prescribe anything. So gabapentin also is there with 4 points, same as codeine. So, and then I saw pregabalin also. And I saw that 2 years ago, I keep on coming home. I said, this is stupid. I mean, gabapentin, pregabalin with you, so many patients without any limit, nothing happens. But then when I started reading about it, why they converted this into a narcotic medication, then I saw this, that we should not give this. But again, options, there are no options. Another drug, what you say is tryptophan, amitriptyline. People prescribe amitriptyline like vitamin.
Right, left, and center.
That's like that is bad for cardiac. I see people going into cardiac block, needing pacemakers because of that. But just keep on prescribing.
Also, I would like to add here that, every person's disposition is different. So like some people are into gambling, so they cannot get away from that fact. So it's a kind of an addiction. So if you give these drugs, if the person's threshold for being addicted is low, they will become addicted. So it's a big problem because we obviously cannot assess these patients for them. So of which, I would say those addictive potential becomes higher for drugs like this. That is the only thing. So we need to be careful and select these patients carefully. Anything else?
A drug like Parmiges you must have, it has become popular as an alternative to pregabalin. They promote it like that. Any experience?
We don't use it. Yes, a lot of vendors come with all kinds of fancy things inside which they say works, but there is no literature to support it. So it's up to you to. A lot of drugs. Thank you.
Thank you, Dr. Deepak. Thank you. Yeah. So we'll continue with the second session, that is Neuromodulation 2. And Dr. Vaishnavi, is she here? Yeah. So he is going to speak on peripheral TENS for neurogenic bowel and bladder incontinence.
Good morning, everybody. Sorry, good afternoon, everybody. For the people who doesn't know me, I'm Dr. Vaishnavi, Senior Consultant Neuroanesthesiologist. I work in AAG Hospitals, Hyderabad. Sorry. I hope I'm audible. Yeah. I have interest in chronic pain and neuromodulation, as minimally as it is, not DBS and all. So now I'm going to talk about TENS for bowel and bladder incontinence in these headings: the overview, indications, and what are the goals. Before going to know about the continence and incontinence of the bowel and bladder, we just need to know where the centers of the bladder are. The bladder has both sympathetic as well as the parasympathetic innervation, and the bladder centers or the involuntary centers. The autonomic center is in the Pontine micturition center. That means the bladder gets filled, and once the bladder is filled, the sacral nerve sense it, and the signals are sent through the spinal cord to the Pontine micturition center, and the detrusor contracts and the sphincter relaxes, and that's how we void the urine. And voluntary contraction of the bladder, that's how we control in the public places, is being happened by the cortex. And this is all an integral part of the micturition cycle, the central and as well as the peripheral control of the bladder function. As though we know that it is very clear-cut demarcation of lower motor neuron, LMN bladder, UMN bladder, LMN bladder, UMN bladder, and mixed bladder.
But unfortunately, it is very difficult it is very difficult for the physician to diagnose whether the patient is actually having a stress incontinence, urge incontinence, or an overflow incontinence. And urodynamic studies hardly say what the patient is actually having. All they come as either with hydronephrosis or recurrent UTIs or overflow incontinence. And when you see the KUB, the patient will have the residual volume in the post-voidal residual volume will be more than 80%. This is the commonest presentation for most of the bladder dysfunctions. In the lower motor neuron, as the word itself says, the damage is beyond the anterior hornsel of the spinal cord. So it impedes bladder's ability to sense the fullness. So that means the patient's bladder is full, but he can't feel the fullness, but then the bladder is full and the overflow incontinence happens here, and patient's symptoms of dysuria happen because of bladder fullness and overgrowth of bacteria happening. And here the patient will have nocturia and incomplete empty and urinary retention and overflow incontinence, as I already said. And UML bladder is beyond the anterior hornsel. That means patient is having disruption in the voluntary bladder control. That is, patient will have detritus or overactivity. That means the sphincter is not in coordination and patient will have frequent urination and urge incontinence will be there. And sometimes it will be a mixed bladder symptoms where there is no clear-cut demarcation between the UMN and as well as the LMN bladder, where there are both spastic and flaccid symptoms. And the treatment option should be individualized after thorough examination, history, urodynamic studies, KUB, and especially the history. The causes I'm not going to go deep into the bowel and bladder dysfunction, as you all know, because the people here day in and day out deal with it. And the commonest thing that we see, in our hospital who come to us for the neuromodulation mostly are people with spinal dystrophisms. So what if we don't treat the bladder dysfunction? One thing, stasis happens, they will have recurrent UTIs, and they develop recurrent UTIs. Because of that, they have multiple exterior organism colonization will happen. They develop antibiotic resistance, and it is very difficult for us to treat. And then they develop, because of the retention, they develop calculi, reflux will happen, vesicourethral reflux will happen, hydronephrosis will happen. And then because of continuous trickling of the urine, there will be maceration and skin ulcerations, especially in patients who are not very well cared, especially in elderly patients. So how does the peripheral TENS for bladder and bowel incontinence can actually help? So neuromodulation, I'm not going to actually talk about how it is actually affecting or modulating the system. It is like by giving simple current in the peripheral nerves, we are going to recruit the nerves that are going to target the particular autonomic. We are going to train the nerves which are autonomous to act in a particular way that we want. How are we going to train it? That is by doing the modulation, just like how we do it in circus. So how does it work? By doing the TENS, in a unique way, we recalibrate the dysfunctional neural circuits. So how do we do it? Sorry, I'll come to the guidelines later. So in our hospital, regularly we see patients with fecal incontinence, because I work in a gastro hospital where our input of fecal incontinence post surgeries for LAR is more, as well as we have more of spinal dystrophism cases, because our neurosurgeon is primarily a pediatric neurosurgeon. So we operate on meningomyelins more. So in these children, the common complaint is either self-catheterization if the child is little more than 10-year-old, or less than 10-year-old, the catheterization is done by mothers. But what the child goes to school, when the child is around 5 to 6-year-old, where they can't catheterize by themselves, at the same time they are going to school and they are away from the mothers. So that is their main problem. And because of that stigma, the children are not going to school and they are being actually given home tuitions only because of capitalization issues. So we started doing this peripheral tense. Actually, previously in olden days, the stimulation started way in 1960 actually, but the stimulation points were like behind the scrotum and anterior to the rectum where the S3 nerve was situated. But then McGury started like, he chose one peripheral nerve which is having the S3 nerve root, and it is the posterior tibial nerve which is very peripheral and which is having the nerve root value of L5 to S3. And here we have put a small, she is 3-year-old girl child who is having the same complaint. So we started using the peripheral tense, and we start with the parameters as the child tolerates. This child tolerated we usually use the normal mode, and it is the tense machine that we use. The tense machine is very normally available and hardly it costs around 5,000 to 6,000, easily affordable for a common man. And the hertz we use can vary from 2 to 10 hertz, that is the frequency of stimulation. And the pulse width, that is nothing but how long you really want to stimulate that particular nerve. That is the meaning of the width, and that is for 100 microseconds. We start with 20 microseconds and slowly increase up to 100 microseconds, and we can even go up to 200 microseconds. And the middle figure that is showing is the current. So the child could tolerate without any painful or disturbing feeling up to 3 milliamperes. And this audio I am going to make you hear is about a child. It is not about this child, it is another child who is a 13-year-old boy who was actually using TENS for the past 3 months, and it is his father's
normally the category is too much of going towards bathroom is also reduced.
The frequency of urination has gone down. That is what you are saying.
For example, in a day he was going 7 times earlier.
Okay.
Now I think we reduced it considerably.
Okay. So we are working on it. As of now, we have 6 children who are under our follow-up using this peripheral TENS, and bowel diaries we are using. Mostly our bowel incontinence people are elderly people after LAR repairs. So we are encouraging them to use it for 30 plus 30. Morning session use 30 minutes and evening session use it for 30 more minutes. The problem is in the spinal dysraphism cases, it is obviously a neural tube defect, and it has formed during the pregnancy itself. So we exactly don't know whether it is an LMN or a UMN thing, whether it is incontinence, what kind of, where the defect is, whether the anterior horn cell is involved or not. So we are just trying to know whether the peripheral TENS can work or not. And because it is a non-invasive thing and it is easy to apply and not painful, and the child also can cooperate when the mother is actually having perseverance, so we are trying it. And few children are actually shown much effect, and the number of, and this is the diary we are giving to the mother or the father, whoever it is taking care of the child, to fill it, and they come to us after every 2 months. Either limb, but fixed to that particular limb, don't change the limb. That is what we tell. And after every 2 months, they come to us with this diary, and we see the how frequency has increased, whether the leakage has improved or not, whether the number of usage of the wet diapers have increased or decreased and all. So after seeing this, we change again the current depending upon the tolerance or pulse width or frequency according to the tolerance of the child. And again we will change the settings. And again they come back to us every 2 months, and we keep following them up every 2 weeks, because we need to know whether there are any, because the child will be getting stimulated in the particular local space again and again every day. So skin ulcerations and local burns are also have to be kept in mind. So we tell them to liberally apply the gel and don't put the plaster too tightly, because the child will not be able to tell whether it is hurting or not. And regarding the bowel incontinence, the studies are going with the incorporating with gastro department. Right now, I don't have the data. I'm so sorry to say. It is mainly after the earlier surgery, post colostomy closures, we are seeing for the bowel incontinence, and mostly because these people are mostly adults, they have good cooperation, and we are incorporating biofeedback mechanism as well. So the results are better with sacral nerve stimulation. I mean, like we are able to stimulate the sacral nerve, and they are all adults, so they are able to stimulate themselves in the perineum, putting the sacral electrode, the same TENS machine only, and the results are little better. So we are yet to have a statistical data for the bowel incontinence. Any questions? So TENS, there are many proven data. Sorry, I'll show you. Regarding the TENS in children for spinal dystrophism is the study that we are doing in our hospital, but these are the many studies, supporting studies, which they have used for peripheral tibial nerve for this overactive bladder have already been proved for incontinence, for overflow incontinence. Yes, sir. So that is what, if the paraplegia, that means the spinal cord or the higher centers were already affected. We actually, one patient was insisting because he had actually transverse myelitis. Unfortunately, he is very young. He's a 24-year-old. Autoimmune transverse myelitis is the cause. He's on rituximab, and the level of lesion was somewhere between T4 to D7. His bladder was involved. He was insisting that he is on self-catheterization. Because of that social inhibition, he stopped working. He's working from home and all. So he insisted that he wants his bladder also to be corrected. So I told him that because it is a typically human lesion, he's having spasticity, he's having baclofen pump in situ. And we told him that the chances of you getting better, because of it is a higher motor, like human palsy, the thing that is happening, and the cord is actually involved. So getting improvement with TENS for the bladder is very unlikely, but still he's trying. As of now, it is only 4 months. So he wants to wait for 2 years and see whatever result he can get.
What's SNS, actual SNS, S1, S2, S3 stimulation would work in the paraplegic bladder? So you put bilateral
S3, directly S3, sir. Root S3.
Yeah.
So even in spinal dystrophism, we tried for a few children for S3 stimulation, direct S3 stimulation. For few people, even that did not work. For few children.
Most of our spinal dystrophy kids and paraplegics will do the Medtronic implant.
No, Medtronic's only have it.
S1, S2, and we also include S1 on one side for bladder.
Okay, we never
and
did.
the other side for bowel.
Okay.
And that works very well. So doesn't matter the pathology, but as you said, it's very difficult to categorize these things. But the paraplegic patient can self-time their bladder stimulation. So you can time the stimulation cycle the stimulator every 4 hours once, and then they can empty the bladder after the nerves get stimulated directly. This is a direct stimulation, so you have parasympathetic preganglionic stimulation, and the bladder contracts and empties itself. So that's possible in patients with conus injury, or even higher up injury, or even spinal dystrophy patients. And this is the posterior tibial nerve stimulation is the established procedure for overactive bladder. I mean, years and years, electrophysiotherapists have been doing it, and we had a patent on it, and we had a wearable stimulator just here, a little bit of capsule here, you have to strap it, and it will stimulate 4 times in a day, 10 minutes each. So I think what you are doing is very good, using the TENS machine. There is some kind of antidromic reflex that it generates. It's also good for dysmenorrhea. We tried it in dysmenorrhea. It's also good for
Chronic pelvic pain also it works for endometriosis.
Erectile dysfunction, we tried it because we had patented it, so we tried all the indications. But it's amazing, you stimulate there, and the idea came from acupuncture. So if you look at acupuncture or our ancient Indian traditions, some of these, some points are not physiologically very understandable, but they work. So going back and looking at our literature is good thing. Yeah, this is.
So, considering the traditionally used indications for TENS, it has been used for chronic pain, knee osteoarthritis, chronic cancer pain. The mechanism of action of TENS in that case is gate block theory. Like we stimulate the slow pain pathway so that the fast pain pathway has not got any way to go through the spinal cord. But I want to know the mechanism of TENS in bowel and bladder.
To be frank, actually it is.
Basically anti-thrombin stimulation. So you put a stimulation on the fibers, you will get delta, alpha, beta, C fibers, everything will get stimulated. There is some downstream stimulation, some upstream stimulation. Now when this upstream stimulation happens, the root value of the nerve you are stimulating and the root value of the autonomics coming out of the spinal cord or the autonomic reflex arm. So it goes up and actually activates or deactivates that autonomic reflex arm. So if S3 autonomic, S3 parasympathetic is deactivated, the voiding urge will deactivate. So the overactive bladder will quieten down. So there is no direct relation. It's just antidromic reflex or parasympathetic reflex.
So my question to both Dr. Maran and you is, see the two major bladder issues in the world. One is stress incontinence, which is the most common. And the other is, let's say, in elderly age, in the male, it's the following prostate or whatever, where you have increased frequency. There it is neither upper motor neuron, neither lower. It's just a localized thing. One is because, and despite all your efforts, because of the elderly nature of the patients, they are not ready to do anything, just live with it. So can this work in that? Or have there been studies of,
Yeah, there have been studies on this. As long as there is no structural issue, there is
Yes,
no outflow.
as long as the neural connections and the circuitries are fine,
see stress
they
incontinence, everything is
elderly,
Basically,
the
if
sphincter.
pelvic floor is amazingly weak, then it may not work. And you will still keep on getting stress and confidence. Might improve a little bit. If your prostate is too much enlarged, it may not work. But as long as that is not the case, these things will work. I mean, we actually sold that implant in US for, like, we sold the company also. But most of the elderly working women, stress incontinence is an issue.
It's an issue.
So just put that implant inside your socks, the issue. You will keep on stimulating and it works.
So till the time is stimulating, maybe it will keep the bladder. No, it helps. It has to be kept on continuously or just for
No,
the.
no, just 5 minutes, 4 times a day, or 10 minutes, like they are doing 30 minutes twice a day.
So I mean, it's a solution which we can think of for all.
And all these Kegel exercises and all what they say, the compliance is very, very, very less. No, sir. No.
No, that's
No.
a completely different
That
thing,
is
but it
because-
can. No one has tried it.
Maybe.
Basically, it could. It possibly could. The bladder is the same thing like that Dr. Dhruv was saying. When you look at the X-ray, there are a lot of the things one after another. So bladder dysfunction is never isolated. Starts with something and then it becomes detrusor becomes overactive. Then something else, because detrusor is overactive and the neck becomes hyperactive. Then again it's something else. So where it starts and where it ends are two entirely different things.
We have some validation study. It's using dystrophism or
For dystrophism, no, sir. There are no validation studies for dystrophism as such. There are many studies for overactive bladder. Yes. That is what I am quoting here. For overactive bladder, there are many studies, meta-analysis also, and there are recommendations also for using PNS as an adjuvant therapy along with other treatments for as an overactive bladder. There are many recommendations. So because we are not directly stimulating the S3 nerve root here and we are recruiting the S3 nerve root which is like a very much peripheral, at least 6 months is what we are expecting. As of now, the child that we have seen result is like 4 months, 4 to 6 months. And we also have to remember the degree of the injury of the spinal diffractive. If it is only the cord, it is only the third cord, I think the results might come very quickly. And if it is a lipomeningocele with most of the, like the very much tethered cord with where the S1, S3 and everything is matted and the nerve root injury is very much, then I think it might get delayed, or we never know, it might not come back. No. That's how we counsel that it is not an invasive procedure and there is no harm in trying. That's how we counsel and we start them to recruit into the study. I mean, like the dysenergic, this thing, we haven't started yet.
But this thing, why we sit like this when we do meditation? There is a point here. This is heart rate, the person is very
Increases vagal tone.
These things, I think we can produce these variable low-cost stimulators on these points outside. A lot of medicine cost will go up because medicines are expensive. I mean, like minimized tablet is like 18 rupees or something. And you can get 1,000 rupees that is willing to put it there.
Sir, there have been animal studies in case of TENS where it is shown that it stimulates the opioid mu receptors responsible for tolerance. So if the site of the TENS electrode is not changed frequently, then there are high chance of TENS failing the treatment.
That is for local, that's not pain.
But this is for nerve root, no? Nerve root value is very important. Root value is important. Root value is fixed here. We are not using for pain, where we are using like for ONE, we use on either side of the knee joint. There it is fixed. There they develop tolerance. I accept it, and they develop tolerance even for the higher currents. They tolerate even for more than 40 milliampere. There are people who tolerate even 40 milliamperes of current. But here we are targeting the root value.
So in case there is a skin issue, you can always put it in the back of the knee. We done that 2 electrodes on the back of the knee, one on either side. That stimulates the same nerve.
And once the skin heals, and you can come back to the side posterior to the malleolus always.
Thank you, Dr. Vishnu. I now invite Dr. Milind. So you're going to
Want to continue or should I break in between? I'll not break it.
dorsal root ganglia and peripheral nerve stimulation.
So I mean, when DRG stimulators came in 2012 or something, Abbott, then St. Jude's brought the DRG stimulation. That time we learned about putting the lead transforaminally and all that, and I done few. I was not a big fan of it. So I'm not going to speak too much about DRG stimulation. What dorsal root ganglia stimulation can do, peripheral nerve stimulator can definitely do. So again, dorsal root DRG stimulators are not available in India, so it will just be academic exercise to talk about them, though it was a very smart idea. So peripheral nerve stimulation is something that came in actually way back. I mean, the first evidence of peripheral nerve stimulation is William Sweet. You know, Sweet and Schmidek, our operative textbook, neurosurgery textbook. So William Sweet put an electrode in his infraorbital nerve to see what it feels like stimulating a nerve, and he stimulated himself. So it's amazing, and he's written about it. And that was, I think, probably in 1940s or 50s. So peripheral nerve stimulation, scope of peripheral nerve stimulation, when you talk about is, first is pain, obviously pain. FES, functional electrical stimulation. So you can put stimulators on motor nerve, coordinate them to initiate movements. Bladder bile dysfunction, VNS itself is kind of cranial now, but peripheral nerve stimulation. Motor stimulation, phrenic nerve stimulation, We've done that now in India also. We started doing it in ventilator dependent patients. Hypoglossal nerve stimulation for obstructive sleep apnea. So this is a very smart system that we used for obstructive sleep apnea. One lead is on the hypoglossal nerve, other lead is in the intercostal muscles, and as the intercostal muscles contractility starts going down, it will stimulate the hypoglossal nerve and the tongue will be pulled out and they will open up. So it's amazing. I mean, these patients, the only complaint by their wives is, I feel like I'm sleeping next to a snake because the tongue keeps on darting out in between. So, but that works very well. Autonomic stimulation is also part of peripheral nerve stimulation, and this is one of the DRG stimulation leads. These were 4 contact leads, and there was a little tail on them, and the tail you could guide going epidurally into the foramen, and DRG stimulation was good for anterior truncal pain. So all these pain for which I do now peripheral nerve stimulation, like ilioinguinal neuralgias, postherpetic neuralgias, anterior abdominal wall, visceral pain, or even back pain. DRG was very good, but the overall effort needed to put that for a neurosurgeon was too much. I think the pain practitioners who normally do that is probably okay for them to do it, but so focal intractable chronic pain, again, as I said, is a complex problem. How does it work? So again, there is a question about how does it work, and people think that it blocks the nerve impulses. You cannot block the nerve impulses. It's impossible to block the nerve impulses, primarily because the energy needed is so high. We had a lab, we used to work in Case Western with Dominic Duran and Niloy Bhadra. You need 4,000 hertz, 4 kilohertz of energy to block a nerve fiber. And 4 kilohertz of energy will cause burn in the tissue. So blocking is not possible. So then what we are doing? So we are stimulating itself, but we are stimulating different fibers. Are we stimulating a nerve, or are we stimulating the underside of the skin? So again, when we used to put in the occipital nerve stimulators using paddle lead, the paddles which were directed inwards had less benefit than the paddles which were directed outwards. So when you are stimulating the skin, you are having better outcomes. So the nomenclature, when Medtronic did their first trial of sub-Q stim, came peripheral nerve field stimulation. So this is a field stimulation and not a nerve stimulation. So what you are doing is basically activating the vibratory receptors underside of the skin, and that vibratory receptor output is blocking the C fibers, because vibratory signals will get a precedence over pain signals, and the vibration will go to brain and the pain won't. So the gate actually is activated at the peripheral receptor level, not at the spinal cord level. So that's probably most logical mechanism of how peripheral nerve stimulators work. Repetitive vibrotactile stimulation, that's how it works. And also there are central mechanisms, and we have done it in spinal cord stimulation. Similar studies, a PET study basically shows that there is activation of the cingulate. This is some of our patients, again, shows a lot of affective pain areas which are activated because of peripheral stimulation. Prefrontal, cingulate, locus coeruleus, so all these areas get activated when we turn the ONS on, occipital nerve stimulation on. This is one of our patients also, lower extremity, left lower extremity RST, and we had put in a lead on the nerve and basically showed activation, central activation of the cingulate along with the sensory area. So historical perspective, as I told you, simple solution for a complex problem. So when we started doing it, I started doing peripheral nerve stimulation way back 2000 onwards. And that time, we in Cleveland Clinic, we used to get patients of with herniorrhaphy damage to ilioinguinal nerve. And we used to open up the nerve, and we used to put a lead below the nerve and one on top of the nerve. We called it a sandwich concept. So it was a surgery. You had to open up, patient admitted. So when we did that in few patients, we thought, well, why not just to put a lead in the distribution of ilioinguinal nerve below the skin? Gave the same benefit. So we started doing more of a field stimulation than nerve stimulation. This was one of our old papers, and I think it got published somewhere. So we probably had done more than 1,000 of these, but this was a very old paper. So most of these patients had multiple surgeries. Duration was up to 27 years. And this was the location. These are the leads I have put in. Occipital neuralgia, supraorbital stream, complex craniofacial pain, that means leads everywhere in the face, low back pain, mid back pain, neck pain, meralgia paraestheticus, inguinal neuralgias, peroneal nerve neuropathy, arm pain, shoulder pain, hand pain, post-thoracotomy pain, even post-shunt pain, 17 shunt revisions, severe pain, we put a lead by the side of it. So anyone used to come to my pain clinic with focal neuropathy, and the issue was that insurance won't approve it, so we had to fight for it. So we had hired 3 people just to fight with insurance to get all this approved, and that's why we could get it implanted. All of them underwent clinical assessment, neuropsychology. Surgery was done in 2 stages, trial placement and then implantation if needed. And these were some of the outcomes of those first 350 patients. The best outcome was post-intervention trigeminal neuropathic pain. So this is, you either call it anesthesia dolorosa or constant trigeminal pain, but that responded very well. Craniofacial was the best outcome location. Duration of pain did not really matter. Gender, I think there was no change in the gender. Migration, infection, erosion were the complications. Optimizing outcome, patient selection, again, this I talked to you about before. This was another thing that we used. This was a tunneler called on-cue tunneler. So this tunneler is soft, it bends, goes along the curves of the body and doesn't go through the skin or close to the skin or below in the muscle. Now it's not available in India, so nowadays when I put these peripheral nerve stimulators, I'm still putting it in Kolkata. I use the angio sheath, you know, the femoral puncture sheath that the endovascular guys use. I'll make a puncture and then push that sheath through it, and that goes, the advantage of that is it only goes through subcutaneous plane. It doesn't go in the muscle, doesn't come through the skin. These were some of our supraorbital lead placements in battery here, and these are some of our x-rays. So various combinations. So this is glossopharyngeal neuralgia, this is V1, V2, V1, V2, V3, and occipital pain at the region of the craniotomy. This is one of that patient where we did post-shunt pain. So different combinations, different areas. Simple surgeries. This is bilateral, this is for migraines. So we used to do combination of occipital and supraorbital, or sometimes only occipital. This is a post craniotomy pain, neck pain, back pain, unilateral neck pain, causalgias, nerve injuries, abdominal pain, pancreatic cancer. We've done this, just field stimulation and helps with the pain. Post thoracotomy pain, back pain, axial back pain, this sacroiliac pain. This is post-herpetic neuralgias. We did bunch of those. These are ilioinguinal neuralgias, so we done bunch of those also. Shoulder pain where no surgery is possible, ankle pain, knee pain. So everywhere we put these leads, and they work pretty well, and it's not a big surgery. Programming is simple, rate 40 to 50, pulse widths very little, because if it becomes too much, causes stinging of the skin. Conclusion is the peripheral nerve stimulation is safe, minimally invasive, excellent therapeutic benefit, acceptable complications. It kind of seen as a semi-permanent treatment by these people because you do blocks, you do outside things. They work for some time, then they stop working. So I think if you take the cost out of equation, this is a very good treatment modality. If somehow we can negate the cost issues, then this is a very, very good treatment modality. This was one of the trials that we did sub-Q-stim. And then not only this, we also we can stimulate autonomic renal SPG. So this was one of our SPG stimulators we used to implant. Even for disorders like asthma, if you can put a stimulator in the bronchial or tracheal tree, and the whole tracheal sympathetic is on the posterior part of trachea, and you stimulate when the patient gets attack from outside, then you won't need medication. You can just stimulate the sympathetic activity so the bronchial attack will go away. Each organ in body is controlled by nerves. So if you can modulate nerves, you can treat diseases outside neurosurgery, outside neurology also. Thank you. This is one of the books I wrote. So I write poems. So this was a poetry book which is out of publication now. But that was also about pain. Thank you.
I want to know, like, for all this peripheral nerve stimulation, we are putting in a stimulator inside, and TENS is the same thing which is outside. So why can't we keep the TENS continuously on like a stimulator with the same parameters, let's say, or maybe higher amplitude of the energy delivered to cross the skin and the subcutaneous tissue to reach the nerve?
We use TENS as a screening tool sometimes, but remember they are stimulating two different ends of the peripheral nerve endings. So when TENS stimulates, it stimulates the skin, and when they subcutaneously placed peripheral nerve stimulators stimulate, they stimulate the underside of the skin, and there is a difference in outcome. Having said that, it's not going to be possible to carry that TENS everywhere 24/7. But if you can, then that's why we created actually, I think it's a conflict of interest, I should not say it, but pain band. So it's a stimulating band, just like the tennis players wear, with 2 electrodes in the front, 2 in the back. You wear it if you get migraines, and then stimulate with your phone app for 10 minutes, and your migraine is gone, and then 6 hours don't stimulate. When it comes again, stimulate. So yes, wearable stimulation does same work as implantable stimulator. I think we thought this was very advanced, but now I think this is kind of old. Now wearable stimulators are probably the better stimulators.
Thank you, Dr. Milind. I now call upon Dr. Vaishnavi. Dr. Meena is here. Dr. Vaishnavi, you can continue with your second talk. Okay. Treatment options for chronic neuropathic pain after brachial plexus injury.
So now I'm going to talk about chronic neuropathic pain after brachial plexus injury. So if you see this number, almost all brachial plexus injury, no matter how bad the injury is or how small the injury is, the patients or the people who land having chronic pain is almost like 80 to 90%. Chronic pain, it is almost 50 to 83%. And severe pain, the patients who actually experience chronic severe pain is almost 40%. And people who actually land up in CRPS, that is chronic regional pain syndrome, is 21%. So here we need to understand two terms. what is the meaning of denervation pain and what is the meaning of deafferentation pain? Because this particular thing is very important in understanding the chronic pain actually happening after brachial plexus injury. So whatever happens after brachial plexus injury is actually a deafferentation pain, because the afferent system, that is whatever the nerves that are signaling to the brain or the spinal cord are getting sheared or avulsed. That is avulsion rhizotomy that is happening here. In simple terms, if we can understand this as like if an autistic child or someone who is programmed to do only one thing, get up in the morning, come to OT5 and change to your OT dress, go to OT5. And he has been doing that without involving the cortex for 40 years from birth, the same thing. And that's how the nerve has been programmed. Nerve doesn't have cortex. Now suddenly what happened? Some injury happened. Now thinks, oh my God, my baby is gone. I have to do something. It is not feeling anything right now. So I should do something for it. So what will it do? First thing it starts is recruiting receptors. So even if it is a small sensation that is coming from the skin or touch or whatever it is, I should feel it. I should relay it to the brain. So what it does start recruiting more and more receptors. That is one thing it does. So what is it? Hyperalgesia. That is even the small touch. The patient will feel it as an extensive hyperesthesia. That is the touch will feel as pain. Sometimes it even feels as allodynia. Then what the next step is? It has recruited the receptors. That is not sufficient. It is still not relaying to the brain. Then what does it do? It increases the amount of neurotransmitters. The acetylcholine increases. Again, what will happen? The same thing. It is still not relaying. Then again, the same thing. Hyperesthesia and allodynia happens. Then, if the second order neurons are trying to help it, so that is the second order neurons relay at the level of thalamus. So peripheral nerve is gone and dorsal horn neurons are also devoid of the sensory input, and now thalamus is also not getting the input, and then the central nervous system is not trying to get the input, but central nervous system is relaying the sensory input to the corticospinal tract as well. The sensation, the withdrawal reflex, everything is getting relayed in the CNS. In corticospinal tract, like withdrawal reflex, for example, as simple as that. So the the corticospinal tract starts firing. Though it says that the limb is still there, come on, start moving it. So the patient starts feeling a phantom limb pain. So it is all the aberrant circuits that are continuously happening and forming a chronically disorganized aberrant circuits which actually form into phantom pain, which are very difficult to treat after some time. Acute pain is easily treatable with some NSAIDs. Once the patient is having some brachial plexus injury along with a clavicle fracture, it is easy to treat. The fracture is healed, fine, but what then? We need to understand these two terms, the nociceptive pain and the neuropathic pain. The nociceptive pain is when the patient is still having the injury. That means the acute injury. The cut is still there. The wound hasn't healed. The patient is having pain. That is explainable. That means the inflammatory process is still going on. That is the nociceptive pain. And that is having a clear-cut border. The patient can really explain, yes, here I am having pain. From here to here, the cut happened and I am having pain here. The nerves are cut, we can understand. But the neuropathic pain, it is very easily given in all the books, like patient is having predisposition, familial predisposition, the genetic predisposition and psychological factors. Those three things are not easy to treat. The patient will have so much of pain. It is very difficult to explain for the patient, and as well as it is very difficult for the doctor also to understand, the physician to understand what exactly the patient is actually feeling. And the dermatome also, it is not clear-cut demarcation like how the radicular distribution is, C5, C6 dermatome, C6, C7 dermatome. It doesn't happen like that in a brachial plexus injury. Not every time. So when these nociceptors are nothing but the specialized receptors that are present in the skin, which are having or carry the sensation of the pain to the peripheral nerve. So the peripheral nerve is nothing but the medial nerve, radial nerve, or whatever it is carrying the sensation to the spinal cord through the brachial plexus. And now that is cut, that is avulsed, and it starts having an ectopic discharge. That means to help the brain or the spinal cord to feel more amount of sensory stimulus, which is actually not there. I mean, the nerve is avulsed, right? So then the central sensitization happens and the patient will now start feeling continuous pain. And then there will be a cortical reorganization of pain centers wherever it is getting relayed, and then the patient will have complex regional pain syndrome. Here it is type, there are many types, it is with the injury type. So when the patient will have CRPS, there will be intractable change. How do you know the patient is having CRPS? It is because the patient is having color changes, the limb will be swollen, and the patient will have, the limb will be very warm, altered temperature regulation, and inflammatory changes will be there. I don't have actually the CRPS images of the upper limb. We have done for the lower limb, so I did not incorporate any images here. Sorry. So in summary, the peripheral damage, neural hyperexcitability, and brain plasticity leading to aberrant pathways and cortical reorganization, CRPS. So how do we treat them? The first line of treatment here is always antidepressants. Treat with triptoma. You can start with 10 mg BD or even 5 mg, but we usually start with 10 mg. 10 mg BD you start, and with duloxetine. You can add with duloxetine as well, because tricyclic and with SNRIs combination is like you can give as both. Like start with triptoma BD and duloxetine in the night dose, HS dose. And the second drug, gabapentin or pregabalin, depending upon the patient comorbidities. Gabapentin you can start with 100 mg BD or pregabalin 75 mg BD. And this third line treatment, the topical thing is just like taking the patient's brain away from, or thoughts away from the pain area, that is lidocaine patches. They hardly help. The maximum pain score that can come down because of this capsaicin patches or lidocaine patches is not more than 5%. And opioids and NSAIDs are the least, or we can say that it will not have any effect on brachial plexus injuries. It is like zero. So TENS, yes, there have been many studies of TENS working for brachial plexus injury, but the problem is, as long as you stimulate, the patient will not have pain. But once you stop the stimulation, the patient will have pain. So how long will the patient keep stimulating, keeping it in pocket and going for work? It is very cumbersome. And the second thing, CRPS, teleganglion ablation for sympathectomy, yes, you can go ahead with first diagnostic sympathectomy, the patient is having CRPS symptoms, and then we can go ahead with surgical sympathectomy. Botulinum toxin, if the patient is having trigger points, like patient is having certain trigger point and that particular trigger zone is the cause for pain, there the botulinum toxin can be actually used in cases of brachial plexopathies. So in the gist, so if the patient, if you can see this chart, you can see like drazotomy is the hero for any brachial plexus injury, but not for the stump pain. Why? Can anyone answer? I think no one is listening then. So in neuropathic pain, obviously, drazotomy sir has spoken extensively about drazotomy yesterday, why it is working for chronic neuropathic pains, the dorsal root entry zone, and phantom limb pain, yes, again. CRPS, we don't need to do drazotomy actually. It can be done with sympathectomies. But the pathology of stump pain is neuromas mainly. The formation of neuromas and the Valerian degeneration of the nerves that are actually happening at the end of the stumps, and they start giving new sprouts every now and then. to help the stump to understand that still there is a limb down there, start and open up and go and supply the limb that is not there and try to open up. So the stump pain actually doesn't respond much to dresotomy. So even after doing dresotomy, the phantom limb kind of pain still continues. So the stump pain hardly responds to dresotomy. So distinguishing the type of pain after brachial plexus injury is very crucial. Whether the patient is actually having a neuropathic pain, a phantom pain, a stump pain or a CRPS is very important. So talk to the patient, where exactly the patient is having pain, how is the pain, type of pain, whether it is continuous, intermittent, shock-like pain, whether there are any skin changes, where exactly the patient is having pain, rule out the phantom pain before taking any call, and especially before going into any kind of interventional procedures, try the first line drug of management and then slowly take a call, and dresotomy is the last resort. As sir I've already told, the peripheral nerve stimulation and cervical spinal cord stimulation and DBS or the new techniques for treating brachial plexopathies. The surgical target, sir has spoken extensively about rhizotomy yesterday, so I am not going into the technique and all in detail. So there have been 2-3 techniques like Sindor's technique and Nashor's technique, means like there is nothing. Microsurgically or radio frequency, laser or ultrasonic probe, there is no much difference in whatever way you do the dresotomy. The best thing is go in the, what is that called, Goldilocks zone. You have to go exactly there. Don't go and hurt the nucleus gracilis circulators. Don't go too laterally and hurt the spinothalamic tract. Don't put undue pressure in the posterior columns. Mainly because when the touch sensation is gone, when you people are doing this particular surgery, the input to the brain is gone and the patient can then develop the ataxia. So that is the most common and dangerous complication of this particular procedure. So treatment selection, obviously, if the patient presents to you after brachial plexus injury, the early interventions, that is like nerve grafts, the nerve early tendon transfers and nerve transfers, although as well as this nerve transfers give the patient good muscle function as well as pain relief along with the muscle function. So the muscle, if the patient comes after 1 year, already the atrophy might have happened and they have to go for grafts like muscle grafts. That is, they have to take the grafts from pectoralis, latissimus dorsi, and it is a very morbid procedure and the outcomes will be very, very poor. And sensory nerve transfers for pain reduction have been proposed, but the results are very poor. So the earlier the intervention, the better the results are. And the medical management, I have already told about the drugs of management. And surgical decision making always depends upon the type of the pain the patient is actually having. Coming into the recent advances about the brachial plexus injury, the emerging drugs are rapamycin. Rapamycin is nothing but an immunomodulator or immunosuppressant that they are using for graft versus host reaction, that they are trying as a neuromodulator effect for decreasing the regenerative pathways. And intrathecal trichostatin A is also actually in the same, and intravenous immunoglobulins. All these three are in the preclinical stages. All three more or less work in the same fashion. They stop the aberrant pathways regeneration. Thank you.
Any questions?
Yes. No, they are just in preclinical stages. Nothing has been FDA approved. Rapamycin is IV, sir. Intrathecal is trichostatin, sir. They are also in the clinical stages only. IVIG, sir. Just like how for GBS they are doing as a modulatory effect, IVIG. Maybe don't know, but at which stage exactly, for which particular pain, when.
Sir,
That is what you are going to conduct. No, now you are doing chronic pain as well.
the treatment of pan brachial plexus injury ends with you. If you get the patient to you, get it dressed done. That's it. There's no other
I
treatment.
told you, like, dress is a hero.
Dress is amazing. I had 2 patients, I want to say. Poor people.
5 days. And we never know, like, whether the 5 days treatment is actually going to help the patient without generating the aberrant pathways. We never know.
Another therapy you should try is for if you see phantom limb pain, is mirror therapy. Very easy to do, and you should be able to do it in your outpatients. V.S. Ramchandran, a very smart guy from Scripps, started this. And like she said, the brain keeps on sending impulses to the amputated limb and then wonders why it is not moving. So that's why you get the pain. So mirror therapy, you look at your good hand in the mirror that looks like the amputated hand, and you think about lifting it, and then you lift your good hand. So on the mirror, the amputated hand is lifted. If you do that for 3 weeks, the phantom limb pain goes away, almost goes away. I mean, we used to do spinal cord simulators for that. Then we started doing virtual reality. Now we have this hi-fi virtual reality where you can see the limb. But even in low-tech, we've done mirror therapy, and it's very good for phantom limb pain. Looks beautiful.
Ideal time for nerve transfer is actually as soon as the acute injury heals.
Now,
They do the MRI.
Yeah. So you probably are right, but let me illustrate it. If there is a clear-cut cut, you do the repair right then and there. It's no question of it. If there is on MRI scan, if there is no discontinuation, no hematoma, then you wait. You do physiotherapy and EMG, NCV. Every generally 4 to 6 weeks, and then see if there is new recruitment, motor unit recruitment, if there is any clinical improvement. So you wait for 3 months if there is no discontinuity. At 3 months, if you have some improvement at least, then you can still wait. But there are 2 nerves. One is axillary, because shoulder gets out of, it comes out of socket, then that could never repair. So you do a spinal accessory to suprascapular transfer within 3 months if things don't recover. And then you continue with physiotherapy. Then again, whatever is remaining, you do the nerve transfers. You start with axilla, and then you do musculocutaneous, and then at the end you do the hand. For hand, you do overleans. For doing overleans, at least you need to have one good nerve. When there is a pan-brachial plexus injury, you can bring the C7 root from this side to this side and can do it, but these are extensive surgeries with not very good outcomes.
Good outcomes.
So unless there is a clear-cut intra-root or intraneural hematomas, you would not do a nerve transfers earlier. You would wait. And then, so if you see pseudomeningocysts, the roots are completely avers, then you will do it early, because then there is no chance of them coming back.
Not much. If the root is avulsed, there is nothing.
We have, I think, immediately methylprednisolone for 3 days, 5 days, that's about it. After that, what's more important is therapy and muscle stim. More muscle stim, more therapy, more recoveries.
Nearly 5 to 7 patients of post-traumatic brachial plexus, but not avers root on MRI, just swelling of the root seen on MRI, and they have significant motor extension of
This society is peripheral nerve society. So Ketan does this very often. Ketan is my classmate, Ketan Desai. So he maybe we should call him in one of these meetings. He can talk about this.
This ACDH is post-traumatic or non-traumatic?
Post-traumatic cases are also doing very well. Some of them, if they are presented within a week of, not the ones who present late.
These patients had motor weakness as well.
Yeah, motor weakness
Power was less than 3 by 5.
Power was 0 and the power has improved to 4 minus 5, 5 within a month.
You're mixing up the premises. You got to look at what was the injury actually to the brachial plexus, and then get them all on the same level. Then do ACTH, and then see how much improvement. Because if it's only neuropraxia, then you gave ACTH to, it was going to improve anyway.
Even with ACTH or over the period of time.
Yes, all of it.
Thank you, Dr. Vaishnavi. We close this session.
But it's a good study. You should do it. Prospective study, randomized controlled prospective study.
Some of the talks of neuromodulation session are left. We will cover them after the lunch. It's already 2 o'clock, so we now break for lunch. Lunch is available outside in the foyer. Please carry your lunch. Around 2:45 or 3 o'clock we will start the next session. 2:45 we will try to start the next session, please. All please be here on your seats by 2:45 p.m. Thank you.
ब्रेकफास्ट कराए ब्रेकफास्ट कराए
Who is not doing the we have got 3 of his doubles and 3 there for the store of an inflammatory change. So could I refer the patient to I am from Lucknow and the patient is in pain.
Oh. Yeah, I keep on coming to Lucknow all the time.
Good afternoon, everyone. Now we will start with the post-lunch session. I am requesting Dr. Amol Reja to kindly chair this session for us. Dr. Amol Reja, please.
Hello. All right, so let's begin with the next session. Now I'd like to invite Dr. Rajesh Meena, my colleague, for presenting on occipital nerve stimulation, indication, procedures, and long-term results. Good afternoon. Good afternoon. Thank you, Dr. Amol, for giving me this opportunity. So it's a post lunch session, so everybody must be sleeping. And so make the presentation short. Short. So I'm presenting about the occipital nerve stimulation. So this is a new topic for me because it's a part of a neuromodulation. So I'm talking about its indications and what is the technique and long-term results. So basically what is occipital nerve stimulation? It is a form of a neuromodulation therapy. So like in neuromodulation, when we stimulate the peripheral nerves, we get the response. In occipital nerve stimulation, we stimulate the occipital nerves to get the desired benefit. So it's basically indicated for the chronic headaches, which are medically refractory. So it's a company driven, and so it have three components: the metal electrodes, which we place at the greater occipital nerve and the lateral occipital nerves, and the connector, and there is a neurostimulator, which is also known as pulse generator. So it has a three component. So this chronic headaches, generally for a neurosurgeon, most of the patients of chronic headache are managed conservatively. We refer them to neurologist, and the neurologist evaluate the case, and then there are certain cases which are refractory to the conservative managements. So in such cases, variety of therapies are available, and the last resort that some people try is occipital nerve stimulation. So what is the definition of a chronic headaches? Chronic headaches are characterized by individual experiencing 15 or more headaches per month for at least 3 months, and most of them include in the category of chronic migraine and chronic tension type headache. So headaches basically neurologists classify into two category: primary headache and the secondary headache. Primary headache like chronic migraine and chronic tension type of headache. Secondary headache, which is secondary to some pathology. So despite conservative management or medical management, some patients require another form of treatment, mostly that they are refractory despite conventional or interventional therapy. In that cases, we can try that occipital nerve stimulation. So this is about the history. It started in 1967 when Wall and Sweet, that first use of peripheral neurostimulation, and the authors stimulated their own infraorbital nerves. And the pioneer work was done by Weiner and Reed in 1999, and they have ONS implantation to treat the occipital neuralgia. So about the anatomy of the occipital nerves. We have greater occipital nerve, lesser occipital nerve, and the third occipital nerve. So greater occipital nerve arises from the dorsal ramus of the second C2, and lateral occipital nerve arises from the ventral ramus. And this nerve supply the back of the scalp. So this is more pictorial representation. So we can localize the greater occipital nerve or the lateral occipital nerve by using landmarks. Generally, it is lateral to the it is medial to the artery, occipital artery, and the landmarks generally is 2.2 centimeter below the external occipital protuberance, and 2.5 centimeter about you will find the greater occipital nerve, and another 2.5 centimeter you will find the lesser occipital nerve. So this anatomy is useful while giving the occipital nerve blocks. So however, in the literature there are various anatomical variations are seen. So in literature, greater occipital nerves can be found between 1.5 centimeter to 5.3 centimeter from the midline, and lateral occipital nerve can be found 1.4 to 6 centimeter. So why there is occipital nerves are helpful in treating headaches like chronic migraine or tension type of headache. So there is a concept which has evolved over the time. So the concept is that when we have a trigeminal type of headache, so we also experience headache in the back, or sometimes when we have a headache, back headache, we can experience the headache in the trigeminal or orofacial region. So there is a functional, this is not anatomical, there is a functional trigemino-cervical complex which receives the afferents from the trigeminal afferents as well as from C2, C3. So when we do the occipital nerve stimulation C2, C3, and this trigemino-cervical complex somehow sends some stimulation or some pathophysiology which causes the pain to relief. So what is the prerequisite for the occipital nerve stimulation? So we should have, what are the candidates for occipital nerve stimulation? So these are the three criteria. He should have a definitive diagnosis of headache disorder. He should be evaluated by a neurologist, by a psychologist, and headaches must be medically intractable, that should not respond to medications, or that haven't responded to at least 4 classes of preventive medications, and headache should cause significant disability in the patient's daily life. So first, so before we do ONS, we give a trial of the stimulation. Generally, we give the occipital nerve block. If they are effective, we can try that occipital trial stimulation, in which temporary implants are placed in the occipital region, and we have a hand control battery, and the patient receives stimulation through the different electrodes combination, and perceive what is the quality of the pain, where the pain triggers are there. So the trial period usually lasts for 4 to 7 days, during which the patient maintains a headache diary. And success of trial is generally defined as at least 50% reduction in the pain, a significant decrease in headache days, or improvement in overall quality of life. So who are not suitable candidates for ONS, that have failed trial period, who have a structural lesion in the brain, or who have a local infection, patients with CVG anomalies, or any implanted electrical devices in them, or a pregnancy, they are not suitable candidate for ONS. So we generally require 3 basic things. We require general anesthesia, we require an image intensifier, and for this procedure, for the definitive ONS procedure. So the patient is position prone on a head, shoe, horse rest, or a bolster. And generally we mark a X-ray. So we see the posterior division of C1, C2 transition, we place an electrode there. So we know that this is the posterior limit of C1, C2 joint. So this will help for intraoperative tactile orientation. So this is the patient position of the patient prone. So we mark a 4 centimeter incision at the back, and it is between the intermastoid line, and the electrode that is placed between the C1 C2 will act as a guide. So what is the direction of your trajectory or the direction of your two-his needle? So we will do a epiphyseal preparation of 5 centimeters so that the connectors can be adjusted there, and a two-his needle is then guided through the curvature of the skin, and it should be in a strict epiphyseal plane. We should not damage the epiphyseal plane. So this is in the cadaveric study. So we direct towards the mastoid. So it should be directed towards the inferior 1/3 of the mastoid, the needle. And intraoperatively, the radiological mark which we have put, that ECG electrode can act as a landmark for that. So this is the post-op. We confirm with post-op X-ray whether the placement is right or not, and it should be below the 1/3 of the mastoid process. So there are variations. There may be various type of leads, pedal type or cylindrical type, or there may be various type of devices. Or the variation in the position we can do in the supine position, we can do in the prone position, we can do in the lateral position. Or there can be two approaches, medial approach versus lateral approach. Lateral approach is when we start from the mastoid process and go towards the midline, and it is better for the unilateral lesion, and best for bilateral lesion will be the medial approach. So long-term outcome is measured in the terms of 50% reduction of the pain, and appropriately chosen candidate are the best, give the best result for occipital OCN placement. So various literature review, then this is the various studies that has done in the terms of efficacy of ONS in cluster headaches. So this study is various one randomized trial by Megas et al., which has a 15 patient 5-year follow-up, and they have a 50% reduction in attack frequency in 90% of the patients for the cluster headache. Now this is for the chronic migraine, and various studies have been done, like PRISM trial or ONSTM trial, which shows that that ONS was associated with a mean reduction of 2.59 days of prolonged moderate to severe headache per month at 3 months compared with the shame control. So this is the studies which showing the efficacy in chronic migraine. And the complications associated with are mostly reported as the migration of the breakage of the leads, infection, bleeding, scar tissue formation of failure of therapy. And in conclusion, I want to say that ONS is useful in medically refractory chronic primary headaches, and selection of the patient as well as psychological evaluation is of utmost important. And we can give diagnostic occipital nerve block followed by trial. If the patient responds, we can go for ONS placement. And it is a safe and efficacious way, and cost is another limiting factor which we are not using frequently in our setup. So there are primary 3 indications for ONS nowadays: chronic migraine, cluster headaches, and occipital neuralgia. So most of the studies have done for chronic migraine and cluster headaches. For less like hemicrania, continua, there are only case reports or some few case series. Thank you.
Wonderful presentation, Dr. Rajesh. In your opinion, occipital neurectomy, do you think it's a reasonable option in cost limited setting, where you can just do a neurectomy in that area rather than doing a stimulator?
Yeah, it may be possible, but it's irreversible. When you cut the occipital nerve, it's gone. So
maximum it will be just numb in that area, but at least the pain will go. With this device, I believe the cost would be huge, just like any other.
yeah, but where the cost constraint is not the factor, I think this must be there.
Great. The house is open for any questions. If anyone has any query, please let us know.
I would like to add one simple and effective method that's funny though. The Nasevian drops nasal spray comes. Just empty that and just add 0.25% bupivacaine in it, and tell the patient to spray in the nose, just 2 drops in each nostril, and tell them to sniff in. It will block the sphenopalatine ganglion, and at least it will abort the migraine, but it will spare the temporal zones. It will be very effective for the supraorbital, supratrochlear. Actually, it is an extended form of trigeminal neuralgia only. The dura mater is actually everything is supplied by the trigeminal nerve. So only the temporals are somehow spared, but it will block the sphenopalatine ganglion if the patient can actually sniff it very well, especially when they're driving or when they have some presentations, when they have to work, then they can do it. So I do for the patients, I fill it and give, tell them not to over sniff it so that it can cause LA toxicity. So it works well. It's a very simple thing. Yes, a 0.25 bupivacaine. Tell them to bring a Nasevion bottle to us, empty the Nasevion, nasal saline, and fill it with 0.25 and give them, and tell them to just sniff 2 drops in each nostril. It will be very bitter though. Spray, but it is 10%, sir. So we don't know if they do it over, and then I don't want them to land up in LA toxicity. Anything, actually it works, but it works only for, I tell you, it works only for 1 to 2 hours because it is very short acting, because nasal mucosa is highly vascular, it absorbs very faster. Yeah, you can use it when you have any presentation or you have any exam to write. Yeah, you can really use it, but I again warn, the temporals are actually spared.
You can put it on your mask. Just make sure it doesn't turn into a general anesthesia. LA should not convert to GA by nose.
Occipital nerve block, I haven't tried much. So occipital 1 or 2 cases we have tried, and long-term follow-up is not. They give short-term relief, but long-term follow-up is not there. All good results.
Especially if the patient can point out, that the current trigger not there. You put the occipital nerve, and then you can give long-acting steroid with bupivacaine or something. That will help them. I think it breaks down the vicious cycle. So that can give long-term relief for 3 months. So I had one patient of occipital neuralgia in which they did a RF ablation as well as long-acting bupivacaine and steroids, everything, but gradually they tend to fail, and I think that's where I think goal of everything fails. But I think this is a durable option, right? Because if that works, that means the opposite. That's a trigger point. Exactly. Absolutely. Right. Okay. Thank you, Dr. Rajesh. Thank you for the presentation. Now I'd like to invite Dr. Vaishnavi Lingareddy, my co-chair, to present on epidural adducer for persistent spinal pain syndrome.
My last talk for today. Lysis of epidural adhesions lower. Previously we used to call as failed back syndrome. Now that is obsolete term. According to American Pain Society, it is retermed as persistent spinal pain syndrome. So the new understanding of persistent spinal pain syndrome has come after extensive evaluation of the patients through various modalities of investigations, and they came to know that because of epidural adhesions, the patient will undergo first, they will come to the pain physician. The pain physician will inject some steroid because there is some small disc. Then surgeon will do discectomy. The discectomy, first it will be for foraminal, then it will become central. Then again discectomy, then it will be another disc, then again discectomy, then the patient will have instability of spine, then they do TLIF, and then there will be a cage, and now the patient is having 2 cages, 6 screws, 2 rods. So now the patient is carrying almost a toolkit in the spine. Obviously he will have pain. So now what is the cause of this thing? So they have explored why does the patient is continuously having pain even after treating him with all the possible options available for the patient. Even the nerve roots are free, the disc is removed, the cage is proper in size, it is not pressing any exiting nerve roots. The patient is still having axial back pain and the radicular back pain. So they have evaluated extensively with contrast, without contrast, CT, MRIs, and they found that there is some small scar tissue kind of thing abutting the nerve roots, causing a similar kind of pain that they used to have before the surgery. So now the people started thinking that surgery has failed. And the theory is repeated inflammation and irritation of that particular space that was used to be naive because of multiple instrumentations, upcutters, your screws, the bone cutters, everything made that particular space very angry and caused these adhesions that are very stubborn to leave that space. So now what can we do now? Now that MRI is showing there is no compression of the nerve roots, there is no disc. CT is showing that the cage is normal in size and in the place, the screws are normal, they are not causing any end plate disruption, they are not causing any nerve root disruption. So what can we do? So we could come up with some other option called as a minimally invasive procedure where we can lyse the adhesions to decrease the pain. So we can do the catheter adhesiolysis. And how do we access the space? By sacral hiatus, just like nothing but like caudal epidural space. I'll show in the next following slides. And the drugs are steroids along with local anesthetic, hyaluronidase, which is a natural enzyme that is found in the human body, and hypertonic saline. So what are the techniques of lysis of epidural adhesions? There are two types of catheters that we can use, that is steerable catheters and non-steerable catheters. Steerable catheters are nothing but, you people are well versed with it, like neurologists will use, who can guide this catheter even to enter the anterior choroidal artery. The non-steerable ones are nothing but what anesthetists used to put into the right atrium. As simple as that. And features allows the precise navigation. Features of non-steerable is simple design, but they are very flexible. They doesn't cause trauma. And steerable has complex adhesions, or they means like the patient is having complex adhesions with the steerable thing, because it is tough, it can rotate and we can break the adhesions and lyse the adhesions. And the agents used are hypertonic saline. Just like if the patient is having VAP in your ICU, you advise the patient to have nebulizations with hypertonic saline. The same way, hypertonic saline can be used as adhesiolysis agent. Hyaluronidase, it is an enzymatic degradation. And corticosteroids, again it is reducing inflammation. Though the literature shows that commonly used is triamcinolone, again it is a particulate steroid, again it can form adhesions. So personally I don't use triamcinolone, I prefer dexamethasone. So proper patient selection. If a patient is coming to you with a recurring low back ache just after one discectomy, please don't go and approach your epidural space with a steerable catheter. Wait and do another scan or MRI and see what is going wrong. So how do I do? Confirm the level first. First I'll show you the steerability of the needle. I have actually used this, this is the guide wire that I used for placing a spinal cord stimulator, and I used that guide wire, I sterilized it and I used it, and I used an epidural catheter over it. So if you see the steerability of the guide wire, so access the epidural space by using a 2 needle through sacral hiatus. Use this steerable guide wire, put the epidural catheter over the steerable guide wire and access the epidural space. This is a patient, he is a 32-year-old farmer who underwent maybe 4 surgeries within a span of 2 years with a recurrent discectomy followed by TLIF. So he came with the same symptoms like recurrent back pain, continuously having radicular pain in one, especially left lower limb more than right lower limb. If you can see in the last picture, my guide wire, I am not able to negotiate beyond this point. my dye spread is only till here. The problem is beyond this cage, I was not able to steer my guide wire. So I did this epidural adhesive lysis in 2 steps here in this particular case. I accessed the epidural space through the sacral hiatus, caudal epidural space, steered the guide wire using an epidural catheter over it as a sheath, extended it till here. One second, sorry. Use the combination of these drugs. 2 ml of 0.25% bupivacaine, Dexa 4 mg. As I told, I don't wanted to use any particulate steroid again in a space where the adhesions were already there. Hyaluronidase 300 international units. You will get 1500 international units as one small vial. Reconstitute it and dilute it and use as a 5 ml. So each ml will contain 300 international units, and use hypertonic saline 3%. But in literature they are telling like 8% hypertonic saline is very good, but it is very difficult to obtain it in every pharmacy until you actually ask for it prior. So I used it in each level. That means I was under fluoroscopic guidance. I was pushing the dye and making sure where I am. So I gave in this particular level so that the nerve roots coming from in this particular epidural space are free. So in each level I gave that cocktail here and here. But I was not able to negotiate my guide wire beyond this cage. The cage was having oversized, and I was not sure whether the cage subsidence was there or not, because it was very unlikely. He was a healthy male, end plates were not over prepared, end plates were healthy. And I think the cage size was more, it was abutting to the anterior epidural space as well. So I had to access the epidural space again here using the interlaminar epidural approach. And again I used the same cocktail here as well. And it's been 5 months since the procedure, and the patient is absolutely pain free. The pain score is almost 0 now. Coming to the studies, there are multiple studies. It started since 2005 actually, the epiduroscopy started, and there have been consistent improvement in studies. There have been, till date, there have been multiple RCTs and meta-analysis comparing epidural adhesive lysis for persistent spinal pain syndrome. The recent study have shown that level 1 and 2 evidence have shown the decreased consumption of opioid. They did not tell that how long the patient is going to be pain-free. They only commented that for 1 year the consumption of opioids for persistent pain syndrome has been come down. But there is this particular study where they used flexible endoscope, what surgeons usually use for even for ETV or for spinal endoscopic discectomies. You can actually negotiate it through the sacral space only, but making it through a bigger burhole kind of thing, bigger endoscopic route. You can go inside in the real-time view. You can see whether adhesions are there. You can lyse it and use the same cocktail. You can drop it there and come out and see how the patient do after the procedure. There are results telling that 80% of the patients are having pain relief after epiduroscopy at 3 months. The complications are like the same as for any other procedure. The risk will be there for the spinal cord injury as the space is very less, but when it comes to lumbar, the epidural space is bigger, so the risk of spinal cord injury are less. But as in any other case, like how many times we can do epidural adhesive lysis per year, it is like not more than 2 times as per the literature. And the risk of dural puncture is always there because the steerable catheters are little bit sharper, so you have to take care that you are not puncturing the dura. So when we overcover it with the epidural catheter, which is very blunt, the steerable catheters will lose the capacity to puncture the dura. So that is another added advantage if you cover the epidural catheters with the steerable catheter, so that it will not puncture the dura and the structures around that are going to be safer. Any doubts? Yes, sir. I keep it after putting the spinal cord PEC catheters. You keep at least 2 or 3, sterilize it and keep it. So I mean, it's like we are not actually entering any blood or blood products until unless the patient is actually positive for anything. So, and another thing is, sir, for every spinal cord stimulator for like electrode catheters, we will get two steerable catheters. So if we open one, we get two.
Other thing is, obviously we can, if we just put in the, we said even if we don't have steerable, we can use it with the electrode catheter.
But the thing is, you will not be able to negotiate it beyond a point, sir. The maximum you can go is L5. Beyond that, you can't go.
The level up and then again.
Multiple punctures might be required. That is the problem.
Arachnoiditis, we get a huge number of patients.
Yes, sir. No.
And we have stuck everywhere, they're getting syringe formation. I think, but that is more intradural.
That is more intradural, and syringe formation is not only in the epidural space, no, sir. The patient will have psoas abscess, and the vertebral bodies itself will be, if the patient is having arachnoiditis, the patient will be having discitis and the vertebral bodies might be collapsed, and the patient having pain is this pain. Yeah. Yes, sir.
Great talk. Thank you, Dr. Reddy. I think so we can move on to the next session, the Botox session. And now I'd like to invite Dr. Rajiv Sharma, the host for today, to present on the topic, what is Botox?
Good afternoon, everyone. After we'll be starting this presentation on a toxin, botulinum toxin. I'll be introducing you to this toxin, how from where we get it, how we make its preparation, and what are the likely indications. My colleagues, Dr. Ila and invited faculty, Dr. Rajesh Lalchandani, will be telling you more in details about this product. I'll be telling how it's from where it is extracted with its detailed history, how it, first of all, how it came into use. This is the one of the most poisonous substance known to the human being, and this is the first biological toxin that has been licensed for treatment of human use, and it is a multi-purpose drug actually. It is in higher amounts it's quite lethal, and these are the doses where in which it can be lethal to somebody. So if it is lethal, can it be used as a bioweapon? Yes. During the 1990 Iraq war, it was told that Iraq is having multiple missiles filled with this botulinum toxin for killing as a bioweapon, and that was one of the reasons why Iraq got attacked. But can the preparations which are available in the market for medical use, can they be used as a bioweapon? No. The amount of botulinum toxin in the single vial, it is very, very minuscule, and even if you use 100 vials at a time, that won't be lethal. So it is a quite safe preparation. Coming to the history of this drug, in 1817, it was first this toxin was first extracted from infected sausages, and in 1895 Clostridium botulinum was isolated, and it was there was an outbreak of botulinum following a funeral dinner in which smoked ham was fed to the people, and those people fell ill, and from them this Clostridium botulinum was extracted, and this is the serial history till 1989. This was the first time when it was approved by US FDA for strabismus, blepharospasm, and hemifacial management. This is the sequential. This picture tells us the sequential history of this botulinum till date. Coming to some slides now of human botulism, because this was quite seen frequently, especially in the developing countries or underprivileged countries, but this is very rarely seen in developed countries in view of good hygiene maintenance and good standards of living. This botulinum toxin is extracted, is usually derived from Clostridium botulinum. This is a gram-positive spore-forming obligate anaerobic bacteria and is quite abundantly seen in soil. And besides this Clostridium botulinum, it can be extracted from other strains of Clostridia like Barati and Bactericum. And the toxin which is extracted from this bacteria is a simple dye chain polypeptide of 150 kd, and it's made up of two units. 100 kd is a heavy chain plus 50 kd is light chain, which is joined. And for making it active, this joint between the light chain and heavy chain needs to be lysed. But one thing you have to understand, that botulinum toxin doesn't penetrate intact skin. How it gets spread, botulinum, how it can spread either by food or by contaminated wounds or through intestine, or there is an inhalational botulism is also known. What about this botulinum illness? It is usually an acute afebrile illness in which we see the symmetrical descending paralysis, which starts usually in the bulbar musculature, and multiple cranial nerves are involved. This clinical picture is usually diagnostic, and this botulinum is not a contagious disease, and sensory changes are not observed in these patients. And if untreated, death can happen because of the airway, because of the respiratory muscle paralysis leading to airway obstruction. Recovery, usually a patient infected with botulinum recovers only when the new motor axons twigs sprout out to reinnervate the paralyzed muscle, and which requires very long time. Probably a period of months is required for recovery. Till then, we have to, if any patient of botulinum is there, it needs to be given supportive ventilation and other biological support to keep him alive till this new axon recovery happens. This is one of the picture, and this is the various presentation. And most common is abdominal cramps, diarrhea, this dyspnea, difficulty in swallowing, double vision, blurred vision. These are the common symptoms of this toxin. These are some of the mimics that needs to be ruled out before diagnosing somebody as giving somebody a clinical diagnosis of botulinum toxicity. Coming to the toxin per se, this one I would already discussed. It's two parts, light chain, heavy chain, which are joined together. I would like to show this diagram. And this is an inactive form of botulinum toxin, in which we can see this is the light chain and this is the heavy chain, and which is joined together. And for making it active, this needs to be cut, and this is cut by the enzyme. And many times this enzyme itself is produced by the bacteria itself. And in this we can see this light chain and heavy chain having a translocation domain and receptor binding domain. The snare proteins, I'll show the importance of the snare proteins in its mechanism of action. Coming to the mechanism of action, how this botulinum toxin affects, it causes the flaccid muscle paralysis because it inhibits the release of acetylcholine at by the presynaptic terminal. This is the picture where we can see how in response to an action potential, how acetylcholine is released. This is the vesicle in which acetylcholine is stored, and when some action potential comes, snare proteins join this vesicle to the membrane. They fix this vesicle to the membrane, and then then exocytosis happens, and this is how normally with a normal action potential this neurotransmitter is released. When this acetylcholine is present at this botulinum toxin is present at the synapse. This is usually uptaken by the nerve end by the process of endocytosis, and once this is uptaken, the light chain and heavy chains are cleaved by the protease enzyme, and the light chain then lyses the various snare proteins which were responsible for fixing this vesicle to the membrane and exocytosis. That's why the exocytosis of acetylcholine containing vesicles doesn't happen, and this is a three-step process as I have described here. Various serotypes of this botulinum toxin are known. Different bacteria produce different types, and we have to understand there is no interchangeability between the different toxins produced by the different bacteria. And even the dosages of one serotype is not same as the doses of others. We can see like this ona botulinum toxin and abobotulinum toxin. There is a they show 1:2.5 dose equivalency, and similarly is with ona and rima as 1:50. Now, this is the table where we can see the various serotypes, and we can see the different half-lives and how we calculate half-life. What is the factor that controls the half-life is the when the snare protein regains function. When the snare protein snare protein is able to rebind the vesicle again to release it. That's how the half-life is affected, and serotype A is having the maximum half-life. These are the various types of toxins and specific snare protein targets are there for each type of toxin, and this is how we differentiate them into 7 types. These are the various FDA approved formulations of botulinum toxin: ONA, ABO, INCO, and RIMA. And these are the various, this is the chart which is showing the various differences between the various preparations. Mainly differences there in the molecular weight, storage temperature, and their activity. These are the common preparations, and we can see they are stored differently. Like Botox is vacuum dried, Dysport is lyophilized, and Myoblock is a liquid preparation. Potency of botulinum toxin is measured in mouse units, and 1 mouse unit is equivalent to the amount of toxin that kills 50% of a group of 20 gram of mice within 30 days after its intraperitoneal injection. And this we have already discussed that units are not equal. Here we can see the this LD50 dose for an 70 kg adult is around 2500 units. That means at least like each vial contains at least 100 units. So we require at least 25 vials for it to make a lethal amount. This per vial amount is very less. This diagram is showing the how it is manufactured. It's synthesized by bacteria. From there it is isolated and purified, and then excipients are added to make a formulation, and which is then stabilized and then packaged. This is from 1793, since when it was first known until 2001. These are the various timelines of the various developments which are related to this product. Various FDA approvals for various medical indications and cosmetic indications with respect to time shown in this diagram. Coming to the indications, we have to identify the disorders which are manifesting by abnormal or excessive or inappropriate muscle contraction, and these are the cases which botulinum toxin can be used for as therapeutic measure. These are the various symptoms and various diseases in which we can see different products are different efficacy. Like one product is not efficacious for all. We have to specifically identify the problem and specifically choose a product to give a optimal outcome to the patient. These are the various indications in movement disorders where botulinum toxin can be used to treat. FDA approved indications: chronic migraine, cervical dystonia, blepharospasm, primary axillary hydrosis, adult bladder dysfunction, pediatric retrocerebral instability, spasticity, and cosmetic. These are the all FDA approved indications to the current date. Various off-label indications are also being practiced routinely by experts. It's having a long duration of action, and it takes at least 2 weeks to have full efficacy, and effect usually in the initial doses is for a period of at least 3 to 5 months, but as you keep on repeating it, the duration of response reduces with time. At the recommended doses, the botulinum toxin is undetectable in blood. How frequently to inject? In view of immune resistance, one should never inject it at least within a period of 3 months. After a period of 3 months, it can be repeated safely. Non-responders can be defined as primary and secondary. And antigenicity, as it is an antigenic product, there is a possibility of patient developing blocking antibodies, and that's how immune resistance develops. Various factors affecting efficacy of injection. I think the next presenter will discuss these points in detail. Likely complications of injections: flu-like symptoms are quite common and which are usually manageable by a simple paracetamol tablet. dysphagia and weaknesses of slightly seen, and which is usually well tolerated, and effect usually goes off in within next few hours or days. And volume and dilution of the product is very important in causing this complication. That's why we have to choose our amount of volume and amount of dilution to be done for the product before injecting into the specific muscle. Limitations, yes, there are limitations, like especially the immunogenicity and high cost. Per vial of 100 units, 100 mouse units of Botox cost you around 23,000 to the patient. Contraindications, yes, pregnancy and breastfeeding are specific contraindications for this drug, besides the other neuromuscular disorders and allergies to the botulinum toxin. In attempt to create novel botulinum toxins is being made, so that this this problem of immune resistance over repeated injections can be overcome. This is the area where the active research is going on. Take home message: various FDA approved indications are there, and it has to be choose specifically and very carefully, and the person injecting should have a excellent anatomical knowledge of the muscles, especially their origin and insertion and action, before planning to be an expert of botulinum toxin. Thank you so much.
Any questions? Sir went too much up to history and bio war and all. It was interesting, sir.
Thank you.
Now I would like to invite Rajesh, Dr. Rajesh Lalchandani. Here or not? Yes, sir. Sir is here to give a talk on Botox indications and how to give Botox and how much to give.
Actually, yes, indications I'll mention, but yesterday we had a talk regarding the post-stroke spasticity upper limb muscles. So the dosing guideline, of course, today we have to discuss the dosing guidelines on that, and what will be the dosing for Indian patients, and what will be the dose modifying factors and the complication management. So that will be the topic, and plus other indications we cannot cover in 10 minutes. I think I have only 12 minutes. How much time do I have? 20 minutes, good. So the other talk is trigeminal neuralgia, so I don't want to miss that also. Yeah. So actually, thank you so much for this opportunity. Yesterday we were talking about post-stroke spasticity with acute ischemic stroke or traumatic brain injury. So if it's acute ischemic stroke, usually the pattern is flexor pattern, and if it is hemorrhagic stroke, sometimes there's flaccidity, and there is an extensor pattern in 80% of the cases. And if long term, between 3 months to 9 years is the best time to inject patients with botulinum toxin. First line of therapy will be physiotherapy. It's probably a multidisciplinary approach where the counseling of the family is more important than the patient's counseling actually. Most important part is botulinum toxin injection. When not to inject is patients with myasthenia gravis, Eaton-Lambert syndrome, patients with active COX treatment, pregnancy and lactation, pregnancy category C, and a lot of other areas like post-chemotherapy, suppose. So botulinum toxin cannot be given because it's finally a poison. So how much to give is very important, then how good can it last. So beneficence should be more than the maleficence. That means you're not injecting too much to harm the patient, rather than you should get too less. You should inject suboptimum doses to give the best outcome. So we also tried dry needling. I showed a video yesterday. I don't know how many people attended yesterday for my post-stroke. We showed that dry needling with cervical dystonia gives immediate results for 2 weeks, and after that botulinum toxin takes over. The new treatment would be dry needling with botulinum toxin as a combination therapy for especially poor patients who cannot afford botulinum toxin in a high dose. So if you want to go a suboptimum dose as per their financial requirement, which is the biggest issue in India, we can add dry needling to that with optimum results. So that's what I showed yesterday. Same goes in post-stroke spasticity. Once you decide the Ashworth score, whether it is 1, 1 plus, 2, 2 plus or near contracture, Tardieu score where the catch is there and the goal attainment scale. That means you and the patient are on the same page. So this is what we closed this yesterday with the muscles that are involved. If there is, for example, can I use your hand mic? So yesterday we were speaking about goal attainment scale and the dosing guidelines for patient with post-stroke spasticity. So usually in acute ischemic stroke, the hand is something like this. When I start from the shoulder, adduction of the shoulder. So I will always think of pectoralis major and latissimus dorsi. My primary muscle will be pec major and my secondary muscle will be latissimus dorsi. When I say flexion at the elbow, I will always go for high dose on the brachioradialis and low dose in the short head of the biceps. Now biceps have long head, short head and brachialis. So you should always inject the short head of the biceps, but injecting the short head will take the hand more in pronation because it is a strong supinator. So be very careful what is the function of the muscle, what is the origin of the muscle, what is the insertion of the muscle, what is the power of the limb. If the power is too less, the dose has to go down. 0 to 5, if the power is 5, 5. If the power is 3 or 2, reduce the dose. Because you might harm the patient by giving high dosing and taking power to 0. There are two types of outcome you will give. One is a functional hand, other is a cosmetic hand. So remember, what do you want to give the patient? A functional hand or a cosmetic hand? The physio has to be part of this multidisciplinary approach where we can give a functional hand to the patient. So when I say the elbow, I will go for high dose in the brachioradialis and low dose in the biceps. When we inject the pronated teres, we always think of the wrist flexion, that is FCR and FCO, flexor carpi radialis and flexor carpi ulnaris. And when we talk about thumb in palm, clenched fist, we think of finger flexors. So one is the whole finger, other is the tip of the finger. So there are two muscles, FDS and FDP, flexor digitorum superficialis for the whole finger and tip of the finger. If you feel the tip of the finger is more spastic, then you do FDS, flexor digitorum profundus. So also for the thumb flexion cannot be, I have seen they have taken thumb flexion for granted. Thumb flexion, you should always see that flexor pollicis longus is very near to the radial artery. So you have to inject where the radial artery gets over. So be very careful that you are not in the radial artery. Also flexor pollicis brevis, opponens pollicis and adductor pollicis here. So these are the small muscle 5 units. Is very interesting results for upper limb post-stroke spasticity. When you go for the lower limb, there is a circumduction gait. So when I say circumduction gait in acute ischemic stroke, I will look at probably the adductor longus and brevis, the tibialis posterior, because on the lateral border, when they walk on the lateral border, we look for gastrosoleus because the R1 and R2 might be 0 or 5 or 10. You have to exactly check with the normal leg and with the normal foot, and you can compare exactly how much it is. You will find clonus also like this in the foot. So you can take care of that with the soleus. So soleus, lateral plate of the gastrocs is twice the size of the medial head of the gastrocs. So we will always give a larger dose in the lateral head and smaller dose in the medial of the gastrocs. Soleus is a muscle which is known as physiological shortening of the soleus in such cases. So you will have to inject at 2 to 3 sites to release with dry needling. It's known as PS, percutaneous epineuritic stenting or dry needling or whatever you say. It has to be in aseptic precautions. We will prefer an operation theatre with fumigation rather than doing it in the OPD, preferably. So even for the great toes, if you see the great toe, you will have high Checkers toe. It's known as striatal toe. There are a lot of patients who come with a striatal toe. I haven't worn a shoe for 2 years because of the great toe. You have to inject 50 units in the flexor hallucis, extensor hallucis longus. And regularly, at least it becomes soft. And then it goes down, then they can wear the shoe. It's a very difficult situation. This happens in those cases who have post-stroke spasticity more than 9 years. So the best results is 3 months to 9 years. But after 9 years, you will find dystonia in the hand and the leg. In those cases, you will find sub-situations where you will have the rest of the toes going down as flexion. So flexor digitorum has to be injected. You have to think a lot of things for your hand and for your leg. So how much do you want to inject, the affordability and the dry needling, all this is very important. But if the leg, the power is less than 3, Suppose you are injecting the adductors and you want to inject the quadriceps also. Be very careful, because spasticity sometimes is good. They say it's good to be spastic. At least the weight bearing leg can hold your body weight. So body weight is directly proportional to the dose you inject in the weight bearing limb. If the patient is 90 or 100 kilos, I will go for low dose in the lower limb with good physio, because I don't want the patient to have a waddling gait. Somebody is injecting the biceps femoris. So be careful of those muscles which are secondary. Focus on primary muscles and sometimes keep some spasticity left in that patient, and let's not make it completely flaccid just because we are doing as per the book. So dose modifying factor is a very important aspect in post-stroke spasticity. So this is the dosing. This is what I left yesterday on. So if you see, I would prefer always primarily the pectoralis major, 25 to 50 units. Now, what care you have to take? It's not injecting is not enough. So lateral 1/3 of the clavicle, when you go down on the armpit, the imaginary point there, you have to hold the muscle and inject at 45 degrees, two sides of 25 units. But patient should not have history of COPD, bronchial asthma, because it gets absorbed in the lung. Sometimes such patients get breathlessness. Today I'll also tell you what not to do. Not that you're injecting, it's a wow effect, nothing like that. You have to be careful. 7 days you cannot have cold and sour food. You cannot inject too much dose in the pectoralis major because the lungs will absorb it very easily. Patients with COPD and bronchial asthma, or those who are, especially in CP, when we inject quadriplegic, we are very careful because they are premature lungs. So in these cases, it gets worse. In fact, the relative says he's got worse. Patient has got admitted because we did not take the complete clinical history of the patient. So when we talk about flexed elbow, brachioidalis would be the first choice, 25 to 50 units. Dilution will be 2 ml of 0.9% preservative-free normal saline in 100 units as of bottom toxin type A. Biceps, yes. If the hand is slightly in supination, fine. But if the hand is too much in pronation, biceps is a strong supinator. Injecting too much in the biceps will take the hand more in pronation. So just be very careful. When we talk about brachialis, is the last option where you see that patient is nearing contracture. So when we say pronated forearm, the first thing is pronated teres. And I would also try to put something in the brachioidalis because I want to release the elbow joint. So never the biceps, because biceps will make pronated teres worse. Pronation. So 10 to 25 units, but even if you give 25 units, it's fine. Because of the long strip, it starts from the medial epicondyle to the lateral 1/3 of the radius. So you have to hit the belly. Why belly? Bottom toxin does not work in tendon and ligament on the origin and insertion. It will give you the best results when you are belly of the muscle. If you are not injecting in the belly of the muscle, you are not injecting bottom toxin. Because it needs maximum blood supply to give the best results. So if you inject at the origin or insertion, there will be no result. The best result will be in the belly. Whenever you talk to any doctor, tell them we are going to inject in the belly of the muscle. We should know the origin, insertion, the blood supply, the nerve supply, and we should know where the belly is exactly. And you have to hold the belly and be very confident, yes, I'm injecting here. This is the origin, this is the insertion, this is the belly, and I'm here. So when I talk to, flex wrist. So flexor, FCR, FCU. Flexor carpi radialis, flexor carpi ulnaris. Flexor carpi radialis is just below the pronated teres strip. So what we do, there's a new technique. When you're injecting the pronated teres, in the same needle, in one prick, you can do both. Superficial pronated teres, 1/2 inch, and 1 inch FCR. So you don't have to take 2 pricks. So if you are injecting 50 in the 25 in the pronator and 25 in the FCR, then you have to go 1, 2, 1/2 inch, 1 inch, 1/2 inch, 1 inch. In one shot, you can do both. And FCU, flexor carpi ulnaris. So you have to see if the flexion is like this or like this, or maybe normally if you see like this, you will come to know slightly on the ulnar side, then we'll give higher dose in the FCU, flexor carpi ulnaris. And the best, everybody asks me, oh, how do you know the muscle? There's something known as dancing needle. Every patient cannot afford an EMG needle. Every patient cannot afford an ultrasound. We call it dancing needle. We put the needle in the muscle, we move the wrist, and the needle also moves. That's more than enough. You are in the belly, you don't need the patient to have more burden of money on that. I think for patients that we are doing in institutes and wherever, We should think of dancing needle always, and it works amazing if you're in the belly. So this is clenched fist, flexor digitorum, now finger flexors. If you feel, patient will, in post-stroke spasticity, acute ischemic stroke, patient will always have a tendency of closing the fingers, that is flexing. Extension would be very difficult for the patient. In such patients, FDS, flexor digitorum superficialis, 25 to 50 units, actually 25 to 50 units, and flexor digitorum profundus for tip 25. So 25 is good enough. Profundus goes from here, deep, and flexor digitorum superficialis is halfway between the wrist and the elbow, slightly on the ulnar side. Just aspirate, go in 1 inch, take a 1.5 inch needle, 26 number or 27 number if you get, and go 1 inch. Just move the finger and the needle will dance. So patients, most of such patients are poor patients. I tell doctors, you have an EMG, wow, you have ultrasound, wow. I do CT fluoroscopy for sciatica, piriformis syndrome, pelvic floor. I even train urologist on overactive bladder pain syndrome, and interstitial cystitis, vaginismus. I'm a trainer for urologist, gynecologist, Foxy. Everywhere I inject through the cystoscope. I have learned cystoscopes. But the problem here is the affordability. What can you do best for the patient at the most affordable price is the question today here. So, thumb in palm, flexor pollicis longus, adductor pollicis, flexor pollicis brevis, opponent's pollicis. This is what we spoke. 5 to 10 years. So flexor pollicis longus, how do you go there? Go on the radial artery, on the radial bone, where the pulse gets over, put the needle and try to move this, the needle will dance. That's it. You don't have to ask anybody. Dancing needle is the best technique, the most reasonable option to do it. And this is the opponent's pollicis, this is the adductor pollicis. So 5 units, you will come in with the dancing needle. The intrinsic plush hand, it is something like this. Sometimes some patients come like this. Rather than this is known as intrinsic plush hand. So you will inject the lumbricals. Always go from the palm, never go from the back. It's too painful. So you have to use ice pack also along with that, because it's not going to be easy. But you have to counsel the patient and get it done the right way. Okay. So now coming for the lower limb. Lower limb we spoke about tibialis posterior, flexor hallucis longus. So gastrocnemius. So this is for gastrocnemius, medial head, lateral head. This is the highest dose. So you always underdose. Up to 50 units is more than enough. And for soleus also 50 units is more than enough for a patient of 100 kgs. This is the first time. Always underdose for the first time. Increase the dose per session. So you have to increase the dose per session. And flexor hallucis longus and flexor digitorum. So how do you decide? It's in the lower limb actually. Flexor digitorum is somewhere 1 inch away from the tibia here. Flexor digitorum. And flexor hallucis is somewhere here. 1/3 from the ankle to the knee. 1/3 laterally, posteriorly is the flexor hallucis, and anteriorly is the extensor hallucis. Thoda haath se ulta hai, is the other way around. Hand is like this, leg is ulta, if you see. It's like in the Hindi movie, you see those witches, no, pair ulte ho jate. So whatever muscles are in front, it goes behind there. So it's a rule. So it's God has given it. So it's something like that. So injection sites, if you see, this is the gastrocs, medial lateral plate, and this is the soleus, if you see below there. So you should know the injection sites, 1 inch deep. Dose modifying factors, patient weight, muscle bulk, number of muscles, Ashworth score, underlying quality, Tardu score, goal attainment scale, multidisciplinary approach. First line treatment is physiotherapy, counseling, injection techniques, injection site, injection dosing, dilution. So when we go for dilution, lower limb will always be 4 ml of saline in 100 units because you want more dispersion. They are bigger muscles. For the arm, upper limb, you will go for 2 ml in 100 units. So it depends. Now some doctors use 1 ml in 100 units. You can go up to 5 ml in 100 units. In urology, when we do for overactive bladder or ND or neurogenic, we do 10 ml in 100 units. So it all depends from how much dispersion is required and the dose. So what is bottom toxin? That sir has taken, I will not get into it, but I'll just show you the pictures of people who are behind the invention of the bottom toxin. So Dr. Alan Scott, we lost him last year, sorry. And this is the Gian and Alistair. I know all of them personally. So Alistair sir died 3 months back. She does the aesthetic. She is first one to launch the aesthetic indication. He was the first one to launch the therapeutic indication. He's an ophthalmologist, Dr. Alan Scott, late Alan Scott, and Alistair, sir and madam, our husband and wife. She's 93 right now, So we have done the stereotypes also. I want to thank you for this lecture. Any questions for this lecture?
Go into the next section. Yeah. You can take the questions at the end of both the lectures.
Yeah. So what is neuropathic pain? Neuropathic pain is a chronic pain that occurs when there is damage or dysfunction to the somatosensory nervous system. Prevalence is 7 to 10%. So if I talk about trigeminal neuralgia, so there is peripheral neuropathy, trigeminal neuralgia, myofascial pain, post-herpetic neuralgia. You can talk about a lot of things that come in plantar fascia, so many things in pain management. But for as per American Academy of Neurology, trigeminal neuralgia is intense, stabbing electric shock-like pain, is the fifth cranial nerve, that is the trigeminal nerve, that's V1, V2 and V3. Now the interesting part is if V2 and V3, V1 is not that common. So V2 and V3 standalone will be 60% of your cases, and V2 and V3 together will be around 30 to 35% of your cases probably. These patients are usually above 50 years of age. These are not young patients. They will come to you in their 50s, in their 60s or in their 70s. So 1,50,000 patients are diagnosed every year in India. Incidence is 4 to 13%. The incidence in women is higher. That is 3:1 versus male. If you see in women, trigeminal neuralgia 3:1. Aging is a risk factor for development of TN. Trigeminal commonly occurring in patients above 50 years of age. So it's above 50 years of age and 3:1 for females versus male. So peak onset 50 to 70 years, 60% of TN female are probably 60% are trigeminal neuralgia, and 60% of the patients may have V2 and V3 involvement, and 35% will have V2 and V3 together involvement. And other thing is unilateral. It affects only one side of the face. It never affects both sides of the face. That may be then myofascial pain and not trigeminal neuralgia. So right side is more frequently affected than the left side. Right side is more affected, females are more affected 60%, V2 and V3 standalone are 60%, V2 and V3 together are 35%. This will not change. This is a protocol. If you see all the trigeminal neuralgia data globally will be the same. So whether it is idiopathic, whether it is because of neurovascular compression, I know that neurosurgeons usually go for surgery in such patients, but if those patients who cannot afford surgery or surgery has failed or whatever the reason, the secondary reason may be the tumors or artery malformations. So bottom toxin is a good option for post-care maintenance, or you want to do it mainly as a patient who cannot afford the surgery. So this lasts for 3 to 4 months. You have to inject at least 2 to 3 times a year, and these are intradermal injections. Follow the pain technique for V2 and V3 with a trigger factor actually. So what are the symptoms? Sudden or unilateral severe facial pain described as sharp and stabbing pain, lasts from fraction to a couple of minutes, occurs in the distribution of the branches of the V1, V2, V3. So attacks both in bouts, paroxysmal. What are the triggers? Sunlight, mastication, accidental touching of the face, or maybe cold weather, anything. It can be anything. Mostly it's idiopathic, so we cannot decide. We will just keep on guessing why it has happened. So Sachin Tendulkar also has it, Salman Khan also has it. So they themselves don't know why it happens. Sometimes they say that a dentist has removed my first molar. So since then I have this pain. So that's myofascial pain. So you have to differentiate between myofascial pain and trigeminal, the organic cause and the idiopathic causes. So what are the tests? Of course, you all know MRI, CT scan, everything. Pathophysiology, central dissemination, stimulation, CGRP and substance P. These are different mechanisms. Like bottom toxin, if you see, the actual mechanism is inhibition of acetylcholine by STAP25 cleavage. That is the snare protein. This is another mechanism hypothesis where CGRP substance P for pain management. Same thing what Sir said in the first lecture about chronic migraine, the PREEMPT trial. So coming to the medical management, there is carbamazepine, oxycarbazepine, gabapentin, surgical intervention, MVD, radiofrequency, ablation, gamma knife, radiosurgery, and dry needling. Now, the new thing, if you see in trigeminal neuralgia, dry needling has come up in a big way for poor patients. Where if you do dry needling in the V1, V2, or V3, it works every 15 days. The patient has to come to you, and you have to do dry needling, and really works well at the VAS score of 50% approximately. So, bottom toxin again coming back. This was the theory actually I had put in. What is the dosage? How do you decide a patient coming with you with V1, V2, V3? How will you decide how much dose to inject? So anything in the range of 50 units. So you have a vial of 50 units and 100 units. So there are a lot of studies starting from 40 units to 100 units. Ideally, the dose, if you see V2 or V3 together when they are involved, you can go up to 100 units. But when you are using any V2 or V3, anyone or V1, then you can do it within 50 units. The dilution is 1 ml of 0.9% preservative-free normal saline in 50 units, or 2 ml of 0.9% preservative-free normal saline in 100 units. So if you see this technique, that is 2 units at each side, there will be a trigger near the tragus of the ear intradermal wheel of 10 to 20 units. And after that, whether you want to go to the V1 or V2 or V3, it all depends on the pain. And last thing, if you are doing V3, always remember to inject inside near the first molar 10 units for the trigger. Along with the tragus trigger, you need the first molar trigger for V3. So 20 here and 10 here, and then you can follow the pain with 2 units intradermal. So be very careful. If you don't have triggers involved, you will not get the desired result. Clinical evidence, a lot of data is there with 50 units, 70 units, 40 units, but ideally you can afford a 50 unit vial for trigeminal neuralgia. You can use a 10 unit wheel near the tragus of the ear and make a wheel of 10 units, one inside the first molar and the rest 30 units. You can do 2 units, follow the pain for the V3. At least 5 rows you have to make. So you have to make in such a way that you use 50 units here, and it will take around 12 to 15 days for the pain to go down. There's a lot of clinical studies. Another thing is diabetic neuropathy. So if you see diabetic patients, a lot of pain in the lower limb, high blood sugar can injure. This is a new thing that has come in. So IDF, that is International Diabetes Federation, is one of the organizations where 2 people living with diabetes may experience nerve disease. So prevalence is 7%. So these are injection techniques of bottom toxin if there is severe pain in this indication, that is 50 units. So how do you dilute it? 50 units and 1 ml of 0.9% preservative normal saline. Intradermal, you decide 10 sites near the pain, and you inject 5 units on each side. Intradermally, don't go deep. So intradermally, you have to raise the skin and inject 5 units at each side and 50 units, rather than giving them so many medication and the pain doesn't go. This really works well in such patients. So this is a new thing that has come in, so you can do it in both the limbs, and it really works up to VAS score from 10 to 2. So you can try it if you want. It's absolutely amazing. If you want, you can start 25 and you can go up to 50. It's terribly painful, so you can really help the patient with this treatment. So contraindications. One of the contraindications of using bottom toxin, that is myasthenia gravis, Eaton-Lambert syndrome, pregnancy category C, lactation, active COX, AKT treatment, chemotherapy, patients with hypersensitivity with any of the ingredient of the bottom toxin, that is human serum albumin, HSA. So this is a protein. You have to be very careful if they are peanut allergy, sulfur allergy, penicillin allergy. Such patients, shellfish allergy, prawns allergy. These patients might be, I'm not claiming yes, might be hypersensitive to HSA that is being used in the drug, that is human serum albumin. So you have to be very careful with the clinical history of the patient in such cases. Adverse event, localized pain, inflammation while injecting, of course temporarily you will have excessive weakness of the muscle, that is temporary. Swelling and edema may or may not be there depending on the injection technique, slight weakness and tenderness and localized infection. Yes, if you don't take aseptic precautions, of course. So sometimes bottom toxin can cause immunogenicity. That means you have to increase the dose every time you inject. That means it's a secondary therapy failure. So you have to check which molecule you are using. You should know that this molecule, the LD50 is done, and the studies are equally done to use the molecule. Otherwise, you will get primary or secondary therapy failure. That is immunogenicity. So reconstitution, as we discussed, 1 ml in 50 units and 2 ml in 100 units. This is the dilution technique. You can use 2.5 also in 100 units. You can use 4 ml in 100 units for lower limb spasticity, and 2.5 used in aesthetic indications. Potency is the lethal dose. This is what the data shows, that LD50 is an important aspect of any molecule that you use, because finally it's a poison. If you do not know the neurotoxin protein content, that the poison content of 100 units, that is should not be more than 4 micrograms per 100 units. That is the important part, because the first thing you will find with the local botulinum toxin is the drowsiness. If the patient is drowsy, something wrong with the botulinum toxin. So be very careful. Patient have to be full stomach. Empty stomach patients cannot be injected with botulinum toxin. Keep your crash trolley always ready. Never inject botulinum toxin without a crash trolley. Something about the crash trolley, a small crash tray is also okay. You cannot just inject. You have to have all the things ready with you. Of course, we have to do stability studies. That suppose you reconstitute 100 units and you have injected 50 units. What do you do with the rest 50 units? So we have done a stability study that at 2 to 8 degrees, you can keep the vial for 14 days. So that if you have another patient within 14 days, or your colleague wants to do a procedure, at least you know that it is not wasted, it is used in the right place, rather than you have to discard. You can use a vial in 2 patients as well, but do not contaminate it by keeping it in the domestic fridge where you have food kept. Keep a separate fridge for your medicines. That's a request to all of you. This has been repeated time and time again, but yes, we have a tech transfer from Prime Bio USA. We have got this molecule from the US Defense, known as MCL44 strain, and they have been kind enough to give it to Prime Bio UMass University Dartmouth, and that is why we at Gufic Biosciences procured this molecule to India as one of the pure forms of botulinum toxin with 99% purity, with human serum albumin, which is native, not exposed to heat light temperature. That is why the vial, if you see, the bottom is transparent. You will never find a white rim in Zabot. You will always, because it is not coagulated protein. This is human serum albumin, is a virgin protein. That is the reason the chance of immunogenicity is very low, and it is optimally efficacious. I thank you all for your patient hearing in this summer day, and thank you so much. If there are any questions, you're welcome. Thank you.
Excellent talk, sir.
Thank you, sir.
Impressive. So do you have a secret that you don't have any wrinkles? Is there any Botox secret to it?
My wrinkles are scared of my wife. She has so many because they are not scared of me. So the only way I'll tell you what I do is 7 hours of sleep is the best anti-aging. I have a cosmetic clinic in Mumbai. I am not a neurologist. I am a cosmetologist. I am an aesthetic clinic in Bandra, Waterfield Road. I'm enjoying my life, but this job, I love this job. I'm doing this from the last 20 years, from Botox to Xeomin to Nabota to Zabot, and I run around 15 days a month, and I train neurologists, neurosurgeons. Dr. Rajiv, I've been very thankful to Dr. Rajiv and my business director, Vikas Dwivedi, who is sitting behind, who has been very kind to get me in. And we are here to train. Let me tell you, I want all you to get trained. If you want to get trained, I have 800 indications which I have learned. You want anything, you let me know and we can do it. Even writer's cramp, hand dystonias, anything you tell me. Restless leg syndrome, you want to learn restless leg syndrome, you plantar fasciitis, anything you talk about. Even, of course, Dr. Ila, in front of Dr. Ila, I will not speak about movement disorder. Out of this, yes, I do that also. I train in aesthetics also. If you see anybody, I train in fillers. Now, the new treatment that I have gotten, she has allowed me to speak. I do a lot of training of neurologist and neurosurgeon for Bell's palsy with HA fillers. So we do facial symmetries with HA fillers where there is muscle mass loss, especially for girls and young boys and girls who are going to get married. And if you see, we lift the whole face with HA fillers. It is being trained only to neurologists and neurosurgeon. Last year, I spoke with Dr. Doug Dresser at Uday Mothani Oration, that is with Dr. Prashant Talke in Bangalore. And we talked about using neurologists and neurosurgeons using HA filler for facial symmetries. So any kind of surgeries that is done, we train all of you on facial symmetries. So if you want to get into that, with energy-based devices also, lifting devices. So I can train on lifting devices and filling devices. So they're as good as botulinum toxin and it's very safe. So this is a new thing in town. Bell's palsy is a new thing in town. We get full symmetry of the face up to 98%. Yeah. Thank you.
the last talk for the day. I would like to call Dr. Ilavarasi for the talk on how chemical denervation complements neuromodulation. Botulinum toxin in cervical dystonias.
Thank you. So I am privileged to give this talk in front of a group of neurosurgeons and other practitioners who are interested in learning it and doing it. I'm sure we will complement this talk with the session, hands-on session tomorrow. So let's get started. So today I will be limiting my talk more or less to cervical dystonia. I am going to give you a flavor of how all cervical dystonia can present and the various planes of movement and how to assess them. So look at this patient. So in this position, if you are seeing the patient, you are able to see that there is a turn towards the left side. The neck is slightly tilted towards the right shoulder. The right shoulder is elevated here, and you also see that the neck is tilting posteriorly. So the plane of movement is taking place in at least 3 movements in this particular shot. But if you look at it in a dynamic, continuously playing video, you are still able to see that the movement is happening in both there is extension and there is a compensatory corrective flexion. There is extension and a compensatory corrective flexion. So these are the minute things that you may have to take care of. So yesterday, as I showed 2 straightforward cases that I was able to demonstrate from the OT. One of the patient had an antiflexion and the other patient had a retrocollis. But in this particular patient, what we are able to see is there is extension, and after that the corrective flexion, rather than coming and stopping at the neutral position or in the midline, it goes anteriorly and it flexes. So that shows that both the flexion and the extension, both of them are simultaneously or alternately contracting. So in such a situation, as we discussed yesterday, sternocleidomastoid is predominantly a flexor of the neck, and splenius capitis and semispinalis capitis are extensors. So in this particular patient, we are going to target both the muscles, and because of this asymmetry turn towards one side, we are going to give the dose asymmetrically. Likewise, we see this second patient, in which you are able to see a ACS dystonic tremor. But this neck is not getting flexed. It is extending and then it is coming back to the neutral position. It's not getting flexed. So in this particular patient, you are going to target only the extensors of the neck, which is the splenius capitis and the semispinalis capitis. So it is slightly different from the patient that we saw yesterday, the second patient that I demonstrated. The pattern was almost the same in that patient also. But the difference is in that particular patient, it was predominantly a fixed dystonia in which the neck is extended. There is no phasic component which is bringing the neck back and forth. So that is a case of pure dystonia, and this is a patient who has dystonia with dystonic neck tremor. So depending on whether it is only fixed dystonia or dystonia with both tonic and phasic components, then the dosing may be slightly different from patient to patient. Now this is another patient which I recently injected. Let's see this video. So you are able to see that there is a dystonia and there is an associated dystonic tremor also. Here also you are able to see that the neck is tilting to lateral tilt towards the right side and it's pulling backwards, and there is a compensatory flexion as well. So in this particular patient also you are able to see that the right shoulder is quite elevated. So the shoulder elevation, you observe whether the lateral part of the shoulder is elevated or the medial part of the shoulder is elevated. If there is lateral shoulder elevation, then it is predominantly the trapezius muscle, and the medial shoulder elevation, it is predominantly the levator scapulae, because the levator scapulae muscle gets inserted into the medial border medial angle of the scapula. So when the medial border is being pulled upwards, you find the medial aspect of the shoulder getting pulled. So this patient we injected, and this was quite a complex pattern, and I think this was the first injection that we gave him. And after that we are able to see that it has the extent of movement has reduced significantly, but we have not yet completely obtained the optimum effect. So next time we will decide that, okay, based on the residual deficits, we may have to increase the dosing for this right-sided tilt. So in this particular patient, because the medial shoulder is elevated and there is right-sided tilt, I will increase the dosing from what I gave. I gave 20 units in the right levator scapulae. Next time maybe I may try 30 or 40 units so that we get optimum neck positioning after injection. So this was one more video that I showed yesterday. The first video yesterday we had seen already, but this is the second video that I am showing today. This patient had not received injection for a long time because I was out of station and he was not able to get injections from his local place, and he had difficulty in getting appointment here in AIIMS also. Yeah. So he was hardly able to speak because of the lingual dystonia, and this is the video after injection. He has remarkable improvement. And this is a patient in whom you are able to see in this shot here, this muscle, this is the levator scapulae muscle, which is quite prominently seen here. But he also has a trapezius which is prominent. Both the lateral and the medial border of the medial part of the shoulder on the right side is elevated as compared to the left side. So sometimes if the neck posture is most disabling, then you may choose to ignore the trapezius. But some patients with cervical dystonia may have significant pain in these areas, and they may benefit with injecting both the levator scapulae as well as the trapezius. But of course, we need to look at the total amount of units that we are able to use, because depending on the increase in dose, the patient may have to pay more if they are paying out of pocket. So in this particular patient, what are the muscles that I targeted? Since he also has a retrocollis component, we have injected both the side splenius and both side semispinalis. But because the right side, there is a right tilt, I am injecting the right levator, right trapezius and right scalene. The levator and trapezius also play a part in retrocollis, and the scalene is predominantly an antiflexor, but in this particular patient we were able to demonstrate muscle activity, and here you are able to also see the scalene muscles contracting here. Here in this aspect, this is the scalene muscle. So we also targeted the scalene, and there was good improvement in this patient. So in the interest of time, I will not be talking about complex dystonia with. So this is a patient that I saw in the OPD yesterday. So he is treatment naive. He was taking some antipsychotics for his. यार ये डबल स्पीड में क्यों प्ले हो रहा है? बहुत फास्ट प्ले हो रहा है. वीडियो 2x में क्यों प्ले हो रहा है? So there are a few things that I want to demonstrate in this particular video. So first is, here I am asking him to eat a piece of biscuit in the OPD. His main complaint was difficulty in chewing. So as you see here, when he is chewing, his jaw is getting stuck and he is not able to open it. Though you are able to appreciate that he also has a significant retrocollis here and also a blepharospasm. His shoulders are also shrugging repeatedly. So, but in this patient, he said very clearly that his most bothersome symptom is just the jaw closure dystonia. In such a situation, the muscles that I would be targeting is, first I would start with the medial pterygoid, and if there is insufficient response, then I will add bilateral masseter and bilateral temporalis muscle as well. But most of the times, if you give just 25 units in each of the medial pterygoid muscles, you get a very good response, and you can use just 150 unit vial. On the other hand, if you want to then add up more muscles, then you may have to go up on the dose, and in up to 100 units, like if you parse it like 25 in each of the medial pterygoid, 20 in the masseter, and maybe 10 units in the temporalis muscle, then with 100 units, these patients have very good improvement. So in jaw injections, we have to warn the patient about jaw weakness. There can be drooling and open mouth and difficulty in chewing if you are injecting the lateral pterygoid. And tongue injections also can lead to dysphagia and tongue weakness and deviation to one side if you are injecting. So the topic that I have been given is how do we integrate it with neuromodulation and take help of our neurosurgery colleagues. So yesterday I had shown this video as well. This patient had a very poor quality of life because of her significant retrocollis, and this patient after she was having difficulty in affording botulinum toxin, and we asked our neurosurgery colleagues to get a radiofrequency pallidotomy, and after bilateral pallidotomy she did very well. And we had a telephonic follow-up in which we knew that she's doing quite okay, but after that we lost her to follow-up. And this is a patient which I'll show you. She has such significant jerks and she has difficulty in maintaining her posture. I'm so sorry for the video, somehow it's playing in 2x speed, but you are able to see that there is a lot of jerky movement and she's hardly able to stand straight. Her spine as well as the neck, both of them are bent, and when the extent of involvement is quite large, it is difficult to inject botulinum toxin because the maximum recommended dose as per the label for Botox is 400 units, though we use up to 600 and sometimes 800 units off label. It becomes very, very expensive to use so much of units, and so we started with some 300 units in this patient. So first I gave her 200 units and later on I called her for next session. So with this we were able to reduce the extent of jerking and to some extent the spine flexion. However, there is no clinically improvement or clinically meaningful improvement because she was still continuing to have this posture, and she has difficulty in doing most of her activities like household chores. When she is cooking or when she is eating, she has a lot of difficulty. So I gave her the second injection just in April, but right now I think we may have to refer her for deep brain stimulation or pallidotomy. So that is how we as a team, the neurologist and the neurosurgeon, work together. So in the first patient that I had shown who had this significant orolingual dystonia as well as the retrocollis. So that patient, in spite of me telling him that he may benefit with DBS or pallidotomy and it may be very less expensive for him because he is feeling such a remarkable benefit, he is refusing to undergo neurosurgical procedure and somehow he is getting the funds arranged. However, there are other subgroup of patients in whom we are able to really help the patient by the neurosurgical team which does one procedure, and after that pallidotomy the patient doesn't even need any form of programming. In this third patient, I don't know, with so significant extensive, if we do a bilateral simultaneous pallidotomy with already she is having some amount of dysphagia and dysarthria, so it may worsen the situation, and I think she may be a better candidate for DBS. But right now we are in the process of arranging funds, and of course you know India is a resource limited setting and we have difficulty in doing it. In spite of that, we are still working around, and our social work team is helping us really a lot to do this, and these group of patients will benefit with neuromodulation. So an ideal teamwork and good patient selection will give the optimum quality of life to patients, and I'm sure all of you would agree that when neurologists and neurosurgeon work together as a team, we can go much farther than each of us trying to run in different directions. And I showed this list yesterday as well, and tomorrow I think in the hands-on sessions we will, with the mannequin, we will be able to know the surface marking as well as the dosing for various patterns of dystonia. And do we have time? Okay, so writer's cramp, I'll show you this video, but I would suggest that when you're starting to inject, it may not be the best form of dystonia to start treating, because patients with writer's cramp, they tend to, because it is a very fine movement, and any little amount of weakness can lead to significant functional impairment. So we always do injection of writer's cramp under EMG guidance, and if you have an ultrasound and EMG, both of them together you can use as well. So the main step is to ask the patient to write, and during writing you observe what are the various movements. In this particular patient, he is basically right-handed. He was preparing for some competitive exam and he was writing a lot for his UPSC mains, and he had so much of dystonia that he was not able to write with his right hand. So he started writing with his left hand, and the left hand is less affected as compared to the right. And right now, even in the left hand, he has started developing dystonia. And in such situations, you ask the patient whether you want them to be treated for the right side or the left side. Because the left sided dystonia is so significant, and you may need more dose to produce significant improvement, and that will lead to weakness. So he opted for the left side to be injected. Now if you observe carefully, when he is writing, his wrist is getting extended, but his thumb, he is trying to hold it with the hold the pen in such a way that the distal phalanx of the thumb is held behind the pen. So basically what is happening is his hand is getting extended, his thumb is getting extended. Now what we are trying to observe here is something called mirror dystonia. So because we want to observe the left hand, we ask them to write with the right hand, and even when the right hand, he is writing with the right hand, the left hand sometimes goes into a dystonic posturing, and that will help you identify whether it is a flexor dystonia or an extensor dystonia. So you are able to see that the index finger here is trying to extend. You are able to see the minimal extending movements. So basically he had an extensor dystonia, and he is getting injections every 3 months to help him with the writer's cramp. So this is another thing that we do in AIMS, but most of the ENT surgeons are in other settings, even in Canada, ENT surgeons do this often. So this is a patient who had adductor spasmodic dysphonia. So so here the strained quality of the voice, because when he is speaking, the vocal cords are not abducting and they are staying in the adducted position. So after botulinum toxin, so here we inject in the bilateral thyroarytenoid. So maybe in some other workshop we may able to show, maybe in the cadaveric session or something we'll be able to show it, but it is quite difficult to show using a mannequin or something, because we don't have an endoscope. We do it externally using the surface landmark techniques and EMG, and it is remarkably effective, because when we are doing that, I just inject 3 units in each side thyroarytenoid, and the cost is less than 1,000 rupees. So most of the times the patients who come to AIMS, we are able to do it free of cost, because we have some leftovers from other patients who are getting injections for other dystonias like cervical dystonia. Look at his voice after Botox. I gave him his, often when I inject this particular condition, I give my phone number to them, because if you over inject, then that may lead to difficulty in breathing and sometimes even stridor. But he sent a voice note to me on WhatsApp. So this is the level of improvement that you can bring with such a inexpensive treatment. Though Botox at times you think that it is very, very expensive, with just 6 to 8 units you are able to produce this much quality of life improvement. And when you are able to do it without any endoscopy, the cost is very, very less. And I would actually encourage all of you, because most of the times these patients, they come from long distances and they spend a lot more on their travel as compared to the actual cost of injections. So if more people are able to inject in all places, including tier 2, tier 3 cities, and as close to the homes of the people as possible, then I think that would be a success as part of the training that we impart at institutes. We should not restrict this knowledge only to institutes, and I think all over the world people should be able to give it so that patients get the maximum benefit. Thank you. Thank you.
Last patient that you showed, there was loss of voice. Do you think it's an over injection, or need to find a lot of Botox, because it's a natural thing which happens. Might take a thyroid. Okay, so once you inject, there is always a tendency for the hoarseness to happen. So do you think that's a normal?
Delegates, please wait. Please wait. Some announcement is there for tomorrow.
So is it a normal phenomena, or do you think you can fine tune the amount of Botox that you're injecting?
Yeah, that's a very relevant question. So basically, when we are injecting it blind, and we are going into the vocal cord. So after the injection, there is often at times there is a little bit of bleeding and some vocal cord edema happens, which is like a natural course of the injection. So sometimes when you are injecting, you may feel that the patient is coughing a lot. That probably means that there is some little bit of few drops of blood that is bleeding inside the trachea. And in such situations, before the full peak effect is coming, there is a little bit of hoarseness that can happen. We do tell that to patients. They may have a little bit of hoarseness, and they need to think about whether this strained quality of voice is easier for them to manage, or this transient hoarseness. Of course, it's a ultimately the patient's choice, but we do tell them that it is a during the recovery road to recovery, this transient hoarseness does happen.
Thank you. Any other questions that anyone want to ask to Dr. Ila or Dr. Rajesh before then? We can close the session.
Thank you.
Thank you, Dr. Ila,
sir.
for this nice presentation, and we are very happy to see your gesture of exchanging your exchanging or sharing your knowledge with your colleagues. Thank you so much. With this, we are over with the scientific session for today, but before we leave, there are some important announcements for tomorrow. As it's a big batch of 80 delegates which we are catering tomorrow, so we have tried to streamline the sessions tomorrow to avoid any mishap, or everybody should get adequate amount of information which they are expecting for tomorrow. First slide se. First slide pe jao. Tomorrow there will be faculty demonstration from 8:30 to maximum, I think 10:30 we should be able to finish, and there will be some small tea break after 10:30. This will be faculty demonstration. Faculty will be there down in the cadaver lab, and all of the delegates and observing faculty will be sitting here. After the ये मूव क्यों हो रहा है? लूप हटा दो आप. हाँ, कंट्रोल दे दीजिए मुझे. 8 o'clock we'll start relay. It will start with the blocks session. 8 to 11 faculty will be down in cadaver lab. From there, there will be direct relay here. All the delegates has to be here. After 11 o'clock, once the faculty demonstration is over and tea is over, then we have to divide the delegates into batches, and this division is based on your registration number. Okay, delegates will be divided into two groups, 1 to 42 and 43 to 80. So you have to see your registration number here in this list. I have already forwarded this list to in the group of delegates. From there you can see your number, and you have to remember this number so that you go into the right group. You don't land up in the wrong group. If you land up in the right group, all the stations will move automatically with time, and you will be able to finish all the stations without anything missing. This is the two groups registration numbers. First group A will go to basement, and second group B will go to stations which is there on the first floor near the dining station. Pre-lunch session will be 11 to 1:30 will be one group will be in the down in the cadaver, and one group 43 to 80 will be up in the stations. This is how we will move into there are 3 stations down in the cadaver lab. Cadaver station 1A and 1B are same. Route blocks 7 delegates will be on station 1A, and 7 delegates will be on station 1B. Next station is trigeminal neuralgia station. There will be 14 delegates who will be practicing one by one under OAM guidance this trigeminal neuralgia needling. Okay. Then next station will be erector spinae block and stellate ganglion block. Again, these delegates, 14 delegates will be divided into 2, 1 to 7 and 8 to 14. And turn by turn they have to do. And this you have to follow your timelines. Once your time is finished, you have to move to the next station. Okay, this will be the workflow for from 11 a.m. to 1:30 p.m. for this group from 1 to 42, and all the stations will be covered in the cadaver lab. Once you finish this after lunch, this is the similar way we will be covering all the stations on the first floor from 43 to 80. These stations will include ultrasound, Botox, DBS, spinal cord stimulation, and RF. Okay. After lunch, this groups will be reversed. The persons who were initially in cadaver lab will come up, and the persons who up will go down into the cadaver lab, and this similar way we have to proceed. We have tried to streamline this, and we want to ensure that everybody is able to get all stations and maximum output we are able to achieve, for which you people have come from so far off places. So I request you, all of you, to follow the system so that everything goes smoothly and we get maximum out of it. Thank you so much. Any questions are there? Please, you are free to message me or ask me personally. Thank you. We can, session is closed for today.